guidelines on the optimal type and duration of antibiotic. Therefore, there is a need to study to find out and develop standardized protocol for particular antibiotics for cost-effective outcomes and to prevent the development of resistant organisms. The benefit of prophylactic antibiotic use in endoscopic transperineal pituitary surgery is controversial. Many surgeons prefer antibiotic just to stay safe. The most common infections, as we have already told, is meningitis and sinusitis. Various studies have shown that the risk of CSF leakage during and after the surgical procedure is associated with meningitis. So the objective of our study is to identify the common type of antibiotic that can be used as a prophylaxis if used at all, and also the optimal duration of its administration. We'll also like to discuss and find out other existing literature that determine the antibiotic prophylaxis that reduces the risk of infection within 30 days of surgery. So, based on the survey by Little and White, the current opinion on prophylactic surgery is that 91% respondents indicate that there is no strong evidence and they use it just to remain safe. In another study by Smith and Sanger that showed that 92.8% of endoscopic skull-based procedures preoperative antibiotics were administered. So coming to literature, I have found very less literature, only 3 retrospective descriptive cohort studies and 1 prospective case series only. There was only 1 randomized control trial that also to rule out the nasal sinusitis and not on meningitis. So based on the NOS administration, the studies were considered moderate and low in quality. The eligible studies were observational in design and there were different antibiotic regimens used. Cephalosporin was the most common prophylactic antibiotic used in those studies. So there is no clear-cut baseline as we have stated. So there is more need to studies on this. So we studied around 62 patients from 2017 to 25, and we gave a standardized regimen of ceftriaxone and amikacin for 2 to 3 days, depending upon the duration of nasal pack left. The rate of meningitis and sinusitis were noted, and follow-up was done for 30 days post-operatively. There was every care taken to rule out any CSF leak and steps taken to control or adequate cellular repair. So the results showed that 55% patient received ceftriaxone amikacin and 5% patient received with amoxicillin and clemelanide because they was found to be some sensitive to cephalosporin. So 22 patients had intra-op CSF leak and 1 patient had a post-op CSF leak that required surgical repair. Within 30 days, 2 patients developed meningitis and there was managed conservatively. 3 patients also developed sinusitis. There was mortality of 1 patient. Post-operative resulted in increased length of stay and escalated cost for the 5 patients. So now we're going to discuss what are the studies and studies that are available. So in one randomized control trial, they saw for the nasal sinusitis, the role of prophylactic and short-active antibiotics. They have found, they have used, it was done in the USA, and a standard 24-hour post-operative antibiotic was given. They have found no improvement in the sinonasal quality of life or reduction in post-operative complications with extended antibiotics study, and they have supported short-term perioperative antibiotic and emphasizing antibiotic stewardship. The study was published in Neurosurgery 2021. In another retrospective analysis of a new antibiotic chemoprophylaxis regimen in 170 patients undergoing endoscopic endonasal surgery, they have given amoxicillin plus sulvectam 3 grams or cefazolic 2 grams on induction, and with no post-operative administrations have been performed. All cases of CSF leak, meningitis and systemic infections were recorded. Meningitis was statistically associated with intra and post-op CSF leak, and other factors such as extension of the tumor and their malignant histology causes increased risk of meningitis. Extended approaches producing more extradural defect, posterior contracted with a higher risk of meningitis. All surgical maneuvers to prevent, detect and quickly repair inter and postoperative CSF leak were crucial to prevent meningitis. So again, another study of the efficacy of ultra-short regimen antibiotic chemoprophylaxis reducing the risk of meningitis in patient undergoing endoscopic endonasal transpanoidal surgery. They have divided ultra-short into less than 1 day, only single shot and just after surgery, and short into 1 to 3 days and long into duration more than 3 days. The study suggested that ultra-short single prophylactic antibiotic first generation cephalosporin is safe, cheap and effective in patient undergoing endoscopic and endonasal transplantal surgery only when they do not require lumbar drainage after surgery. If lumbar drainage is required, antibiotic may have to be changed accordingly. In this patient, also the rate of minor infective complications were acceptable, and the more expensive regimen on third generation cephalosporin plus aminoglycoside, they said, could have been avoided with only cephalosporin. In another antibiotic prophylaxis in endonasal, endoscopic and skull-based surgery, 20 studies were done across the world, and they have found that multiple groups of antibiotic does not show statistically significant difference to that of single antibiotic regimen. Ultra-short duration maintenance groups show lower incidence of postoperative intracranial infection. All surgical maneuvers, again, to prevent the CSF leak is crucial. In another antibiotic, where they have given postoperative oral
you need to please come
antibiotic,
to the conclusion now because
yeah, they have also found no benefit. So the systemic review was limited because there was no significant randomized control trial. So to conclude, watertight closure is the key to reduce the risk for the need for prolonged antibiotic. The incidence of meningitis or other related infection does not differ with the type of antibiotics. Short duration perioperative antibiotics provide effective result. We recommend prophylactic antibiotic until nasal pack is removed. Any CSF leak post-surgery should be managed with priority. So the take-home message is current evidence does not support routine prophylactic antibiotic. Increased duration of antibiotic will only increase the risk of drug-resistant bacteria, and prolonged antibiotic is not an alternative to proper CSF closure. Thank you.
Thank you, Dr. Binoy, for your presentation. I think, can we have discussion right now or at the end of session? I think any one or two questions, any queries, Dr. Sumit? Mike. Yeah, sure. I think what they say, basically, if you give more of antibiotic, you make that area very sterile and an area to, like, for the opportunistic bacteria to set in. So a short-term antibiotic
the take-home message reads that, ultra short-term antibiotics, maybe a day or two will be sufficient. So this is a misnomer concept, I would say. Why? Because there are a lot of factors which act as variables and decide about the post-operative infection in such cases done endoscopically. For example, how much was the leak, whether the leak was repaired correctly or not, was there a post-operative continuing CSF leak, was a lumbar drainage put, the patient profile, was the patient diabetic or not. So there are a lot of factors. So it's a lot of heterogeneity. So we should not summarize it into a one single slide and say that only single day antibiotic or is more than sufficient to prevent the post-operative infections in the kit. The patient has to be individualized, rationalized, and acted accordingly. That is my take on that.
Any other comment? I think he's right to say, but then as to generalize it, I think, like to give a message to younger generation, I think if it's uncomplicated cases, there's no serious leak, there's no lumbar drainage, we can stick to 3 days post-op, and depending on then if there's a lumbar drain or there are comorbidities or there are apparent CSF leak, you have to continue for a little longer period. And so any other comment, any other suggestions?
Can I just ask one question? You know the 2 patients or 3 patients who had meningitis in your study, do you know the organisms, were they covered by the antibiotics you've given?
It was, I don't remember, but it was actually resistant to most of the antibiotics. So that is why it is crucial to not to overuse the antibiotic, because
I think the policies and guidelines are varied across the world. In the UK, we just give prophylactic pre-operative or induction, at induction, and there's no post-operative antibiotics unless there is a specific cause like Dr. Sumit that said. But generally, we just give at induction, that's it.
Thank you, Dr. Binay. We'll go to next talk, which is by Dr. Mukesh Sharma, and he's going to speak on endoscopic disc preserving cervical spine surgery. Dr. Mukesh.
Good morning, respected dignitaries. Myself, Dr. Mukesh Sharma, Associate Professor at Medical College, Jaipur. My topic for presentation on today is cervical endoscopic disc preserving surgeries. So, as we all know that the surgical management of the cervical disc has evolved over past few decades from ACDF to artificial disc, and then recently the endoscopic disc preserving procedures. The most commonly used ACDF procedure is associated with certain morbidities and certain limitations like reduced disc, pseudoarthrosis, and adjacent disc degeneration. To overcome all these limitations, certain modification has come into play, that like anterior cervical disc decompression without fusion and anterior foraminotomy techniques like anterior cervical decompression and posterior keyhole foraminotomy techniques. There are certain advantages of these endoscopic procedure. Disc preserving microforaminotomy, there is no need of fixation. It preserves the range of motion of the disease segment, and there is no need to manipulate the root to handle the offending structure, and there is no graft site complications. These endoscopic disc preserving surgeries are indicated in radiculopathy, monosegmental soft and hard disc causing compressive myelopathy, myelopathy with unilateral or bilateral radiculopathy. There are certain contraindications of these endoscopic procedures, like patient with significant reduced disc height, significant posterior compression like ligamentum flavum hypertrophy and fasciate hypertrophy, cervical instability, congenital canal stenosis, and compression which is extending more than the half of vertebral body level, like in the migratory disc and OPLL. There are certain relative contraindications like patient having previous surgery at the same disc level and patient with the multiple disc disease and dense OPLL. We have two approaches in this, the lateral approach for the radiculopathy and the central approach for the myelopathy and myeloradiculopathy. Here we can see the entry point for the foraminotomy and entry point for the central disc disease. The surgical procedure is same like that of the standard ACDF. I am not going to narrate these all. We reach the prevertebral fascia, and here we have a short video of one of the procedure we have performed in our patient. Patient is under GA and positioned with supine position and head slightly, neck slightly extended. After reaching the prevertebral space, we introduce the serial dilator and then fix the ejigo sheath with stent. And then prevertebral fascia is coagulated and small annulotomy done. Then we do the drilling, which is inverted cone shape drilling, inferior end plate of superior vertebra and superior end plate of inferior vertebra. The cone shape drilling is made till the PLL, and then PLL is removed with 1 mm Carician. And by using the hook, we sweep the offending structure like disc into the field of vision, so that here we can see that the migratory disc is swept into the field of vision and then removed here. We then completed the disc removal, and then PLL is completely removed. Here, after removing the PLL, the glistening white structure which appear, that is the dura, when there is uniform bulge in the dura, it is the completion point of the surgery. So, after achieving the hemostasis, here this F-gel and the Sagicel are placed. And these are the post-operative CT pictures. And these are the comparison of the pre-op images and the post-op images. Here we can see in the pre-op there is significant cord compression by the disc, and in the post-op image we can appreciate that there is significant adequate decompression of the cord and the spinal cord. We have performed this endoscopic disc preserving surgery safely and effectively for the myelopathy and radiculopathy in more than 1,000 cases over past 10 years. No doubt in the initial phases of our learning curve, we have certain complications like possible recurrences, dural tear, failure to improve, and no doubt the steep learning curve. Here are some of the publications on the endoscopic disc preserving surgery in the national and the international journals. And here is a chapter on the endoscopic disc preserving surgery in the neuroendoscopic surgery book. There are certain learning pearls which we have learned over our 10-year experience, how to control the bleeding and how to achieve the precisions. And to conclude, this endoscopic disc preserving surgery is a good alternative in microscopic procedure with similar decompression and better visualization, minimum morbidity, and with additional advantages. Although it is difficult to learn, it is safe once the sufficient experience is gained in the endoscopic surgery. And with deepest gratitude and admiration, I extend my heartfelt thanks to my respected mentor, Professor Y.I. Yadav sir, for his extraordinary work and dedication in the field of neuroendoscopy as a surgeon. Thank you.
Thank you very much for sticking to the time. Very neat presentation and a neat procedure. Can I start with a question before asking the audience for questions? Now, do you know the long-term integrity of the disc? Do they maintain the lordosis? Do the disc collapse? Because you've stated that disc preserving surgery, particularly the central the operation you've done, the disc, I'm not sure whether the integrity of the disc is preserved over time. So I just wanted to know what you thought about that in the longer term.
We remove 20 to 30% disc only over here, and in our experience that no significant complication like disc reduced disc height.
So it'll be useful to know what happens in a few years. What happened to the integrity of the disc? Is the disc still preserved, or do they result in natural degeneration? And so I'll ask the audience for any questions. Anyone? Thank you very much. In the absence of any questions, we move on to the next talk.
Thank you, sir.
Next, I invite Nimesh Patel to talk about endoscopic assisted lateral skull base surgery, optimizing outcomes.
I would kindly like to request all the presenters to submit their presentations in the preview room so that the session can be conducted without any delay.
morning, everyone. I'd like to thank organizing committee for having this opportunity. For the longest time, we all have trained to become a microscopic surgeon, and of late, for last almost couple of decades, we are moving more and more towards the endoscopic surgery. And assistance with the endoscopy has significantly changed the outcome over past couple of decades. Still, for us, the gold standard is microscope, specifically because of the good visualization, high resolution. But when it comes to the depth, especially in the skull base, the poor field is an issue. Narrow view field is an issue, ergonomic is an issue, and poor illumination is an issue. Hence, the endoscope has significantly enhanced the outcome by better magnification, large depth of the field, and wide angle of the view. But there are still limitations like fisheye effect. So I always feel that combination of microscope and endoscopic utilization in skull-base surgery has definitely optimized the outcome in the tumors and other functional conditions. This is my setup. I generally use endoscope and microscope combinedly whenever it is needed. That's a setup of Kinevo. Now, this is a medial sphenoid wing meningioma. Major surgical resection is microscopic only. She was a 58-year-old female with headache and giddiness, right-sided vision disturbance, no gross other deficit. It was a medial sphenoid wing, and there was an extension deeper upward. Now, to minimize the craniotomy, I have used the endoscope. So when you use endoscope for the depth, you have a better visualization of the portion which is extending deeper, and you can reduce the size of craniotomy and reduce the retraction of brain. So you can see the one which is going upwards towards the corpus callosum. If you only wanted to remove it through the microscope, you literally need to retract brain too much. So after resection and using endoscope, that is the final outcome. After the complete excision, it's the optic nerve chiasm and ICA bifurcation, good preservation of the plane. So I regularly use microscope and endoscope intermittently. Whenever I feel that the deeper portion is difficult to visualize, use endoscope. So that's a final outcome, and that's the final picture, endoscopic view. That's the post-op scan, complete excision, and no major scar marks of the retraction. That's the 3-month post-op scan. And she's absolutely fine. The vision is regained very well. Now, this is a supratemporal epidermoid, predominantly into the medial and temporal area, 60-year-old male with the cognitive disturbance and absence seizure. Here it's difficult to retract literally because this is epidermoid and it is never going to fall as you approach the lesion. If you literally want to chase the deeper portion, you have to retract the brain. Hence, predominantly in this, after the initial excision, I have used the endoscope. I'll try to forward. So that's the endoscopic, so it's basically standard pterional craniotomy, dissection of the anterior sylvian fissure, and then after removal of the anterior portion of the epidermoid, I use the endoscope through the same corridor. Rather than retracting, it's on the dominant side. So I'll just try to fast forward it. So it's the endoscopic assisted removal, and keep going deeper portion towards the medial and posterior part of the temporal area, and that is the final view. It's the complete excision. Patient recovered very well, and there is no retraction, so no speech issue, nothing. So I always feel that using endoscopic utilization in this kind of cases will definitely reduce the post-operative
for the lateral skull base, especially for the trigeminal neuralgia and hemifacial spasm, has significantly changed the outcome, especially for the hemifacial spasm. As we know, the loop is predominantly towards medial region, towards the brain stem. And since the time we started using endoscope, even 30 degree and 70 degree, we could able to visualize the loop, especially for the hemifacial spasm towards the brainstem, and we could probably decompress. Hence, the results of hemifacial spasm have significantly improved
over a period of time. But not just the hemifacial spasm. For the trigeminal neuralgia, all cases what we do is endo-assisted. So no retraction technique, no retraction of cerebellum, size of the craniotomy is small. I generally use 30 degrees scope, and the results are excellent. No major morbidity related to this. So here one of the case of trigeminal neuralgia, the cerebellum was so bulky. And when your cerebellum is so bulky, only doing MBD is a bit difficult because you literally have to retract the cerebellum, which actually can lead to retraction of 7th and 8th nerve complex, which eventually can lead to post-op hearing issue. So this is a kind of pure endoscopic utilization, visualization of the loop, and then using microscope, and then putting the Teflon. So I use both in a single screen. So that's a Kinevo and Kivo utilization basically. So no cerebellar retraction for hemifacial or even for the trigeminal neuralgia. So it genuinely reduces the morbidity post-operatively. Now this is one of the hemifacial spasm case. There was an anomalous vertebral artery which is compressing at the junction towards the brainstem. And it was very difficult to get the angle through the microscope at that area. So, So that is the vertebral artery. That is the first Teflon which I have slided towards the brainstem, and another Teflon, and this is another loop. So main culprit was vertebral artery. Now getting that angle without endoscope is very difficult, especially for the hemifacial spasm. And that is the pre-op, and that's the post-op. She is absolutely fine, no recurrence or anything. Acoustic schwannoma, I use it mainly to see the boundaries of the acoustic schwannoma after the internal decompression. Even for the acoustic also, I don't use the retractor, so same no retractor technique beyond certain level actually. So this is the initial dissection through the microscope. That's the first glance of the lesion. You keep doing the arachnoid dissection. So that's the arachnoid dissection and sharp removal of the tumor. Using CUSA for the internal decompression. So once I'll remove, I would say majority of the tumor, I use endoscope mainly to see the arachnoid boundaries on either side, to see the cranial nerves, and then again proceed further with the microscope. So that particularly reduces the retraction with the Leila. So that's a post-op scan, no major, you can reduce the craniotomy size when you are using endoscopes. It's a complete excision. Epidermoid significantly changed with the endoscope. I'll just quickly try to finish. This is one interesting case, double compartment epidermoid, where I have used the endoscope mainly for the infratemporal compartment extension of the lesion. So that is the complete excision. So it significantly minimizes the brain retraction. It reduces the retraction-related brain injury and much better visualization for the deeper corner. And it optimizes the tumor removal in skull-base surgery. Thank you very much.
Any questions from audience? I think it's a very clear-cut presentation, very straightforward. Thanks, Nimesh.
Thank you.
Our next presentation is Nishant Sadashiva. Endoscopic lateral transorbital approach is choosing the right view.
Please carry.
Next.
Is there? Dr. Nishant? Okay, we'll, I think, start the next one. Dr. Rakesh. Dr. Rakesh Kumar Luhana, posterior cervical monoportal endoscopic discectomy.
Good morning, everyone. My talk today is posterior cervical monoportal endoscopic discectomy. So basically, as it suggests, it's posterior cervical. It's a monoportal where the portal is just one incision, and your working instrument goes through that endoscopic channel. So basically the concept is it's a targeted fragmentectomy, disc preservation surgery. There is no need of expensive implant. It is ultra minimally invasive. That's why it really minimizes minimal approach-related morbidity. It minimizes tissue trauma, less post-op analgesic requirement, and shorter stay. Patient selection is very important when you are going for this posterior cervical approach. The selection criteria has to be very strict. The patient would have severe radicular pain, not responding to conservative measures for almost 4 to 6 weeks, focal neurological deficit, and it's reserved for predominantly foraminal and posterolateral disc herniation with radiculopathy. And clinico-radiological correlation is must because brachial plexitis and other pathologies are also very common here. So this ideal candidate is like this kind of patient with an acute soft foraminal disc with no central compression, no myelopathy, and on MRI would show acute foraminal disc. This is an ideal candidate. Contraindications are associated symptomatic myelopathy, central disc herniation, pre-existing instability, significant mechanical neck pain. In that case, fusion is a better approach, and presence of a kyphotic deformity at index level. Again, anterior surgery is preferred there. So this is a first case, a young lady with a C6-7 foraminal disc herniation, clinically C7 radiculopathy, not responding to conservative measures, and you can see on MRI acute foraminal disc, and axial MRI T2 showing acute foraminal disc. So X-ray, and first thing is docking. So docking is done on AP at the junction of superior lamina meeting inferior lamina called V point. That is your entry point. You mark it with a needle, and then you check in AP. You make an incision around 1 centimeter, and then this is your first dilator. This is a single dilator system. Your dilator goes between C6 and C7 lateral mass, just like this, and over which the sheath is passed, and then you go in with an endoscope. So this is how you hold the scope, and this is holding of your instruments which works through this channel. So as soon as you get in, you will see this kind of muscles and soft tissue. You coagulate with radio frequency. So basically you try to identify, this is V point, this is very important, this is rostral lamina, this is caudal lamina, and this is lateral mass. So identify V point, and you start drilling with a inferior aspect of the superior lamina. So this is a hooded burr with a protection sleeve around. So you drill inferior aspect of the superior lamina, then you drill superior aspect of the inferior lamina. More drilling is done over inferior aspect, and then you use small punches, 1 millimeter, 2 millimeter punches, and you can extend up to the medial 40% up to 50% of medial lateral mass. So usually at the junction of root to thecal sac would be the disc space. So you do basically a bony foraminotomy. And then you use blunt hook or ball point probe inferior to the root, and you can see the disc here. So you fish out the disc without retraction much, and then you take it out with the disc forceps. There may be few more fragments, so search for few more fragments, and then you can see that more fragments are coming out. And then you check it with ballpoint probe about thorough decompression, and you can see well pulsating root and well decompressed root. And this is post-operative incision. Patient had complete relief post-operatively and triceps weakness recovered over 6 weeks. And this is what you see in post-operative MRI. Post-operative MRI showing complete clearance of the disc fragment, and there is very little footprint. And on CT scan, you can see this much bone has been removed. So that kind of minimally invasive procedure it is. This is next case, C5-6 foraminal disc herniation, C6 radiculopathy not responding to conservative measures. You can see C5-6 foraminal disc here. Axial view showing left C5-6 foraminal disc. Again, it's a general anesthesia. Under general anesthesia, position is prone on a bolster and gel. And again, docking is the same at the junction of V point, dilator, sheath, and you get your scope in. And this is what I was saying is this V point, identification of the V point. This is the rostral, that's caudal, identification, bony window opening. And again, you can see the junction of thecal sac to the root. And the disc is always, most of the cases, it's inferior to the root. Unless it is superiorly migrated disc, in that case, you have to explore superior to the root. So most of the disc is lying at this juncture. So you use blunt hook and take out the disc. And you see well decompressed root there. Again, post-operative MRI, you can see on sagittal complete clearance of the foraminal disc, axial again also complete clearance, well decompressed root with a very minimal scar tissue there. Post-operative protocol, patient is mobilized on the same day, discharged next day, and no collar is needed because it's a very minimal bone removal here. Complication, if you handle the root too much, post-operative paresthesia can be there. A neurological deficit if there is a retraction of the cord. CSF leak can be there if handling is not too great. And there is a small chance of recurrence disc herniation. And if you resect too much of lateral mass, post-operative instability is a complication. Advantages of monoportal endoscopy is unmatched with detailed visualization. Incision is very small, minimal soft tissue damage, minimal intraoperative bleeding, shorter hospital stay, less post-operative pain, faster return to work and daily activities, and it's basically a motion-preserving surgery. Points to remember, yes, there is a learning curve. You should begin this scopy after getting sufficient exposure of full endoscopic lumbar cases. Case selection has to be proper. Sheath position should be as close to lamina as possible. You should not be starting fenestration till you identify proper anatomy and V point. And don't get panic with epidural bleed. It usually settles down in some time. And avoid cord retraction at all cost. Thank you.
Thank you, Dr. Rakesh, and for excellent presentation. I just want to know what is the incidence of recurrent disease, like after you've done this? Did you find what is the incidence of recurrence?
Recurrence.
And did you ever go, then again, you had to go anteriorly and do a ACDF?
Yeah, so we have done around 56 cases and 2 recurrence so far in last 3 years. One of the patient we did similar, again we went in again and did a posterior foraminal disc. Another patient had a recurrence on opposite side, and that patient we did ACDF.
Can I? Very nice presentation, thank you. And I think it's a neat procedure because the disc integrity is largely preserved. My question is about the, I presume you were using a Revo system from the drill.
Yes, this is Revo. Yeah.
What water pressures? Cervical, your always concern is about the jet. If you're using a stenosis kit, you're putting it 100, it can potentially cause compression of the spinal cord. So do you have any advice on that?
Yeah, so yes, very important to reduce. So what I use now, what I shifted from pump to gravity based system. So we just keep gravity based and keep it half open in a cervical case. As one of my patient did develop post-operative paresthesia and weakness where there was minimal handling just because of water pressure. So as you go in dorsal and cervical, water pressure has to be kept in mind.
Thank you. Is there any more questions from the audience? Thank you.
Next speaker is Dr. Ashok Nirala, and he's going to speak on Comprehensive Surgical Management of Neonatal Hydrocephalus, Dr. Ashok Nirala. Is he here? Yeah.
Good morning, everybody. Thank you especially Dr. K.K. Bansal, who has given me opportunity. This is my wild entry. I have sent two topics. Not even a single topic has been accepted. What was the reason? I don't know. But he has given me a wild entry today. My topic is role of endoscopic third ventriculostomy in posterior fossa sole with obstructive hydrocephalus and institutional experience. Neuroendoscopy is a recent development in the field of neurosurgery and minimally invasive surgery with all the advantages as in the other field. Posterior fossa sole is a common lesion, especially in infancy and childhood, presenting with obstructive hydrocephalus due to proximity to the fourth ventricle. Neurosurgeons still differ in their opinions concerning the best way to manage obstructive hydrocephalus secondary to posterior fossa lesions. There are three options to us. Either you have to go for preoperative BP shunt or conservative treatment like steroids and dehydrants. Third option is preoperative endoscopic third ventriculostomy. We adopted the policy of preoperative endoscopic third ventriculostomy in cases of symptomatic hydrocephalus. Between January 14 to December 25, 101 patients with posterior fossa sole admitted in neurosurgery department. All patients had a CT scan upon admission. There are exclusion, 39 patients excluded from the study. The exclusion criteria were the patients with no hydrocephalus, patients with asymptomatic mild hydrocephalus, and of course the patient if it is shunted previously. Inclusion criteria, 62 patients included in the study, patients with gross hydrocephalus, patients with symptoms and signs of raised ICP. All 62 patients kept on steroids, Dimox and dehydrants on admission. ETP performed on a day after admission in all except 10 in whom on same day in emergency because of altered sensorium and poor general condition. Morning dose of dehydrants missed it to keep the ventricular system dilated on the day of ETV. Follow-up CT scan was performed after ETV for all patients on third day, and MRI if not underwent earlier prior to definitive surgery for posterior fossa sole in same week. ETV was performed using a rigid endoscope. A blunt probe was used to fenestrate the floor of third ventricle, followed by dilatation using Fogarty catheter. Liliequist membrane was always stressed and fenestrated. Tumor removal was scheduled usually on third day of ETV or in same admission on the another day till general and clinical conditions improved, sometimes on new admission on patient or attendant demand. There is nothing new in endoscopic third ventriculostomy. We used to fenestrate the floor using bipolar forceps, keeping a firm hand control. This needs only basic instruments. We are using the GAPS neuroendoscope for third ventriculostomy. These are the equipments, minimum equipments needed in this. This is the ideal case for endoscopic third ventriculostomy. I would like to highlight the cauterization gives parchment-like consistency of the posterior fossa, third ventricular flow. Usually, I try to avoid doing cauterization. This is one of the complications while doing third ventriculostomy. The pre-op and post-op, the tuberculoma of posterior fossa, third ventriculostomy is almost curative. Thus, the endoscopic third ventriculostomy in intraventricular hemorrhage, and the ETV is sufficient to cure this. This is the pre-op, post-op. I would like to highlight a child has been operated for third ventriculostomy and posterior fossa sole. After 5 years, there is a huge recurrence on frontal region, but still ETV is working. This is a patient, posterior fossa sole. Anesthetist was not able to negotiate the endotracheal tube. Hence, on the table, we decided to go for tracheostomy followed by surgery. The third ventriculostomy followed by posterior fossa sole excision. This is the same boy, pre-op, post-op. Out of 101 patients who presented with posterior fossa lesion, 62 also having gross hydrocephalus included in the study. Age ranging from 2 months to 72 years with mean age of 27 years. Included only symptoms and signs related to raised ICP, major presentation with headache, vomiting, impaired vision, papilloedema, altered sensorium. ETP performed in 62 patients, EVD done in 3 cases at the same time. In one patient, we were not able to make adequate size of a stoma because of balloon rupture. In 2 patients, we were not able to clear the intraventricular fluid in spite of proper irrigation, though there was no visible active bleeding points. In all the 3 cases, EVD systems removed on 3rd day of definitive surgery. Among these 3 patients, 1 required BP shunt in first follow-up after definitive surgery at 2 weeks. Hence, procedure failure may be regarded in these 3 cases because in remaining 2 EVD cases, we were not able to tell whether definitive surgery helped or ETV worked to relieve the hydrocephalus permanently. Complications seen in 3 patients, 2 patients in whom EVD required due to failure of clearance of ventricular fluid. In 1 patient, sign and symptom of raised ICP persisted on 3rd day of ETV, hence underwent CT scan and found hemorrhagic contusion at the entry site, though managed conservatively. Signs and symptoms of raised improved in ETP all patients. Follow-up CT scan showed reduction of ventricular size in all. Definitive surgery showed satisfactory posterior fossa condition in relation to CSF pressure. Even with cases with showed some tightness in the posterior fossa, the routine measures were adequate to control the pressure, and especially after opening the cisterna magna. Definitive surgery done in 59 patients with adequate decompression and favorable results. In remaining 2 years female baby having tuberculoma and 3 years male having cerebellar infarction managed conservatively, and ETV were curative in both patients, and in another 22 years newly married female having complete loss of vision who lost to follow-up, most likely due to family disputes. Post-operative period showed no complications related to CSF pressure, except one who needed VP shunt as mentioned. 1 minute, sir. Mentioned earlier, like CSF leak or pseudomeningocele or so his midline in 62 patients, midline lesion were 30 and lateral lesion were 32. The association of posterior fossa sole with hydrocephalus, both potentially lethal conditions, necessitates urgent surgical treatment. The reduction of pre-operative ICP by relieving hydrocephalus by means of reduces of overall morbidity and mortality. The advantage are rapid improvement, of favorable posterior fossa condition, prevention of post-operative ICP elevation. There are 3 alternatives. First option, pre-operative BP shunt. This has a disadvantage like more morbidity, more infection, shunt failure, upward herniation, possible peritoneal settling. Second option, disadvantage is 10% risk of infection of bad herniation, hemorrhage, accidental pull out. 17 to 40% patients treated with this protocol develop post-op uncontrolled hydrocephalus, hence need permanent diversion procedure, usually within first month of surgery, and thus more chances of CSF leak and pseudomeningeal seal formation and prolonged hospitalization. Third alternative, preoperative ETV, less time consuming, less morbidity, can be done in emergency, allows rapid clinical relief, avoids risk and complications of other approaches. Burhole
Please go
used
to the
for
conclusions.
ETV proved successful in immediate and long-term control of hydrocephalus, both clinically and radiologically with minimal risk and complications. Other studies also support ETV a favorable alternative. Hence, it should be tried in each and every case having gross hydrocephalus before going to definitive posterior fossa surgery.
Thank you, Dr. Nirala. Any comment? Any comment or suggestions? Any questions?
Tumors. Do you like to see the T2 images in the sagittal section to see whether, because in posterior fossa tumors, it pushed the brainstem and the pons anteriorly?
No,
so
no.
Do you want to see the prepontine space? Is it adequate to drain the CSF?
No, not even a single case I have found tumor pushing brain stem forward.
But it usually pushes the brainstem.
There must.
There should be adequate space once you make the stoma, so the CSF should flow smoothly. Then only it will work.
In my case, successfully done cases have worked very well. No one required other treatment.
Can I ask one question? If you have a recurrence of the hydrocephalus, would you consider repeating the ETV, or would you do any more definitive reversion procedures? If the hydrocephalus recurs, what is your policy?
Hydrocephalus occurs, then we will go for VP shunt.
You go
definitely.
for VP shunt straight away. Thank you.
I have done in one case.
Thank you. Can we? Thank you very much, Doctor.
Thank you.
Can we invite Dr. Sai Kalyan Savarpu for the Insight 2 portals from Vision to Precision in UBE?
Good morning, respected chairperson, dignitaries. First of all, I would like to thank Dr. Bansal sir and team, Dr. Sharat Chandra sir, Dr. Subhadraju sir, President and Vice President of Neuroendoscopic Society for this invitation. Well, I would like to clarify that this presentation does not advocate any one particular procedure is superior to the other. Rather, it is how you tailor it according to your expertise and the pathology. A gradual transition in this approach is very essential, as we have often keep seeing the youngsters jumping into the endoscopic surgery without knowing how to tackle the complications and the troubleshoots. So this presentation outlines our journey, and it also highlights the videos covering the full spectrum of the maximum spectrum of lumbar pathologies which we have done in the past. So it started like this. During our residency, we used to perform these open laminectomies and discectomies, and gradually we progressed to perform the microdiscectomies. And after residency, with almost 7 years of practice, I had the opportunities to perform around 600 microdiscectomies. Then what made me shift to minimally invasive spine surgeries is these many meta-analyses which have proved that tubular microdiscectomies have definitely better results when compared to the microdiscectomies. And then after learning from the experts, I started doing this with a wide lumen, wide diameter tubes, and again slowly we have the lumen size is reduced, and later we were doing it well, and one day one patient came to me and asked that we want endoscopic surgery, and that has pushed us to start with Destendo technique. And after learning from experts again, we started doing Destendo, and a couple of years back in PGH Chandigarh, in the same NEUROENDCON, I was invited to present this, and we have presented a work there. So we were very happy doing this. And as you all know that the market started saying that the VET system is it is going to overtake all these procedures, and it is going to become the gold standard in managing the lumbar pathologies. So again, it was a pain, but still we we learned from the experts and started doing this uniportal system. After doing good cases, it is my personal opinion that I used to get tired very soon after doing this. Maybe my ergonomics of the posture was wrong. So of late we kept hearing from all that UB, and people keep saying that our orthopedic brothers have got advantage because they are very well versed in arthroscopy, but it is wrong, because we do, when we are able to manage the complex pituitary tumors through uninostril and binostril technique, it is not a big challenge for us. And then I started this. So this is one of the first case. So we are standing on the left side of the patient. Once the triangulation is achieved, which is an important thing, pause and focus at the endoscopic lens on the RF probe. Make sure that there is adequate distance between the RF probe and the camera lens, that is the lens of the scope. And we need to maintain adequate distance when we are drilling. Often we keep hearing that microscope has a 3D view and endoscope has a 2D view. So this pseudo 3D sense can be created by having the tactile feedback. What we do is we try to move the scope or the instrument, and we try to touch it over the bony landmark, and we can develop a pseudo 3D perception. So the patients in practice generally improves this pseudo 3D orientation, and here you can see the big chunk of disc has been removed. And this is a case of a calcified disc, L4, L5 calcified disc. We are standing on the left side, and the procedure is same. You try to go into the Son space, identify the root of the spinous process, spinolaminar line, laminofacetal line, drill it till the attachment of the ligamentum flavum, and once we reach here, the procedure is the same. It is microdiscectomy. We are seeing it in a clear plane without any bloody field and from very near. So the advantage is you can use a retractor also, and you can see that annulus was calcified, and you can use the drill also to open that calcified part, and the disc fragments along with the free fragments are removed, making the thecal sac and root free from compression. So now I'm going to the other case of lumbar canal stenosis because of the ligamentum flavum hypertrophy, disc bulge and facetal arthropathy. We are standing on the left side of the patient. So identify that C. The C is the top of the C is the root of the spinous process, spinolaminar line and laminofacetal junction. Try to drill the ipsilateral spinolaminar line and the lamina. We can see the cortical, cancellous and cortical bone. And go to the opposite side and do the same. And you can see a small cleft in between here with the fat. That is the midline, and try to dissect out the ligamentum flavum from its attachment gently. The challenge here is about the posterior spinomeningeal bands, which we often don't encounter in the microdiscectomies. Here, because of the saline pressure, these are going to pop out, and when we try to pull it out, there are chances of dural tear, which has happened in a couple of cases with us. The other advantage is you can see here that the ipsilateral root, contralateral traversing root, the disc which we have removed on the opposite side, the contralateral exiting root and the ipsilateral exiting root. So this is another case where we are addressing the right-sided pathology standing on the left side, but this is only possible when the patient is thin built. So here you can see this is the root of the spinous process, the spinolaminar line, the laminofacetal junction, and we have the wide interlaminar space here as it is L5S1. So without touching the bone, we did a flavotomy, and once the flavotomy is done gently, the thecal sac around with the root and the disc can be visualized as shown here. Slowly retract it and try to do an annulotomy, and once the annulotomy is done, the disc fragment is going to pop out. Remove the disc fragment and try to remove the free fragments which are going to come, because saline is also going to help us. Here you can see the axilla of the root, shoulder of the root, free from compression. This is another case of L5S1 fenestration. where you're not going to touch the bone at all. So we have a wide interlaminar space. In the wide interlaminar space, try to remove the flavum. And once the flavum is removed, we can see the inflamed root here. The inflamed root annulotomy is done and the disc fragment is removed. So this is another case of para-UBA for extraforaminal disc. Here the docking point has to be between two TPs and you need to find the isthmus. A partial isthmus drilling has to be done. Make sure that we are not going to fiddle the fascia which is from the two TPs, because there are chances that the collection may go and settle in the retroperitoneal space and form the hematoma. Here we can see the disc and the root. The root is displaced because of the disc here. The disc fragment is removed. Make sure that you are not going to go and fiddle the ganglion, because the patient will forget this pain and he is going to complain of the burning sensation later on. So this is another case of L4-5 listhesis, where we have procedure is the same. We have a navigation in our institute, so we use this. So the procedure is same, where you try to do the facetectomy followed by removal of the ligamentum flavum in toto. Once the ligamentum flavum is removed as a butterfly fashion, the next thing is preparation of the disc. Once the disc is prepared, you introduce the shavers, prepare the end plates. The advantage here is you can see the end plates from very near. So once the end plates are prepared, the advantage is you don't do even the overzealous preparation of the end plates here. The bone is placed in the space and the cage is placed and the screws are placed. So this is a navigated UBE TLIF. And these are some of the complications, if you have time on media, complications which we see here. So this is one of the case. So we had a dural tear, and this dural tear can be quantified by using a pen field. It is less than 2 to 3 mm, then that's okay. There is no need to address it. So what we did here is we tried to put some artificial dural substitutes. Fat or muscle is also going to help. And so this is another case where there was severe ligamentum flavum compression. Because these complications is addressing these complications are very difficult. So here you can see a big tear, and I tried to remove all the ligamentum flavum, but unfortunately at last we can see some of the roots were popped out at the time of closure. So immediately you may have the ability to repair, but in the initial days it's better to keep your ego aside, and we have converted it into a microdiscectomy. So these are the results. In the total of 84 cases, we have converted microscopic conversion done in 2 patients. Yeah, to conclude, sir, these are the complications. And so this is one of the slide which is very important, where you can come to know what is the incision size in the tubular, monoportal and biportal. Muscle damage is very, very less in biportal, when of course monoportal is the least one. Operative time is longer in biportal. The dural sac expansion is excellent in the biportal when compared to monoportal. So, yes. Thank you.
Any questions?
Thank you, Vishwa. That was a good presentation. Now, this is a personal question, Dr. Sai.
Yes.
Now, if you had a choice of using uniportal and a biportal in a patient, and you could do both procedures, which one would you choose and why?
Sir, if it is L5S1 pathology where you have adequate window, I would still prefer using a monoportal.
Thank you. Dr. Bhagat Singh.
You are exposed to all the 3 systems.
Yes.
Dry system, very rare, because nowadays we are focused on select any of the one system and focused on it. But you are exposed in all the 3 systems. Very nice to see all your presentation. Thank you.
Thank you, sir.
Thank you, Dr. Sai. Our next speaker is Suraj Kumar Singh. Novel technique of primary dural closure following endoscopic intradural extramedullary tumor excision. Okay, I think Dr. Suraj is not there, so we conclude the session.
Thank you very much. I was looking forward to that talk, but thank you very much. All right, go to the next session now.
Thank you so much to our moderators and presenters for that truly insightful session.
That was a perfect reminder that precision in neuroendoscopy is not just a skill, it's truly an art.
And also a reminder that 8 minutes in neurosurgery feel shorter than 8 seconds. Up next, we have the award paper session where innovation meets excellence. Because in neurosurgery, it's not just about cutting edge techniques, it's also about the cutting very carefully.
We are honored to introduce our judges, Dr. Sanjay Kumar, Dr. Sarat Chandra, Dr. Fuminari Komatsu, and Dr. Aminderpreet Singh. Also, our off-the-chair judges, Dr. Arthur and Dr. Deepak Agarwal. For the first award paper, we would like to call upon Dr. Abhishek.
So Dr. Abhishek will be speaking on endoscopic endonasal management of craniopharyngiomas, a 10-year single center experience. So please be on time, because time is of essence and you should finish it exactly on time. And I will advise everybody not to show your institution names. So if the other candidates have already written their institution or affiliations, please remove that, because we want this to be a blinded assessment.
Originating commonly from the doxum cella, representing around 2 to 5% of intracranial neoplasms. Now, their invasive nature with the critical neurovascular structures, their close relationship with them makes them difficult to resect, but endoscopic options provide a direct midline access and an option to decrease brain retraction. Now, favorable visual outcomes have been, they have traditionally been operated transcranially, but now favorable visual outcomes and resection rates have been achieved through endoscopic surgery. The methods that we used, that our study design was a single center study, and all the patients operated between 2016 and 2025 were included, either primary or recurrent, but histologically confirmed craniopharyngiomas. All are post-operative biopsies that turned out to be optic chiasm, gliomas, or Rathke cleft cysts were excluded. We also excluded all transventricular procedures if they were not succeeded or preceded by transnasal endoscopy. Our preoperative evaluation included imaging, hormonal assessment, ophthalmological assessment, and a neurocognitive assessment. Surgical technique, we used a binostril, forehand technique. Extended approaches were used when required. Maximal safe resection, GTR, STR, or GTR, NTR, or STR was done. The extent of resection was classified that way. The visual outcomes, endocrine outcomes, neurocognitive outcomes, and the complications like CSF leak rate, meningitis, electrolyte imbalances were recorded. Coming to our results, out of the 96 patients operated with radiological suspicion of craniopharyngiomas, biopsy-diagnosed craniopharyngiomas was found in 83 patients. The tumor volumes ranged from 1.8 cc to 260 cc. The mean tumor volume by ellipsoid method was 24 to 26 cc. 84.3% of our tumors were transinfundibular or retroinfundibular in location when looked at by Cassam's grade. So we had 36 patients who had Cassam's 2 and 34 patients who had Cassam's 3. The lateral extent that is measured by the Puget's grading, we had 50.6% of patients who had hypothalamic invasion. So the quality of patients and the profile of patients that come to our Indian setups are usually different than those compared to international data. So sometimes it's not very easy to correlate international data with our data. They have a lesser degree of hypothalamic invasion. They present to the institutes earlier. We have a later presentation and a more degree of hypothalamic and invasion and a retroinfundibular invasion, as we can see. We had about 20 patients with cystic tumors, 11 patients with solid, and 52 patients with mixed solid cystic variety. So our preoperative visual assessment was 78.31 patients had some form of visual impairment preoperatively, with 51.8% patients having a moderate or a severe visual defect, which we have graded, as we can see. Our neurocognitive status, 46 patients had normal cognition, 19 patients had some form of memory or attention issues, and 18 patients had severe neurocognitive impairment in the form of either a neurocognitive, either a behavioral dependency or some executive dysfunction. We could completely excise either a JTR or NTR. That means 90% of more of the tumor could be excised in 57 patients, and 26 patients we could do a subtotal resection. The reason was that there was reason for an NTR was a small tumor around a critical vessel or a cranial nerve, and reason for an STR would be a tumor that is invading the brainstem or it is invading the hypothalamus. 45 patients, we had to sacrifice the stalk, and in 38 patients, the stalk was preserved. When the preoperative endocrine status is poor, and the stalk, the tumor completely involves the stalk, it sometimes makes sense to rather sacrifice the stalk and give hormonal replacement postoperatively. Intraoperative leak rates this is the intraoperative leak rates, but when we come to our endocrine outcomes, 44 patients had panhypopituitarism, while 22 patients had normal function. Some patients had multiple axis dysfunction. Our posterior pituitary outcomes, 39.75 patients had some form, had a permanent DI, whereas 63% patients had some form of DI, either a transient or a permanent on preoperative evaluation, postoperative evaluation, sorry. Visual outcomes, 80.72, a total of around 89% of our tumors showed either improvement or stability after surgery. Even when you compare it with Puget 2 grade tumors, around 83.3% of the tumors improved after surgery. So a complete resection was achieved in Puget 0, and a subtotal resection was achieved more in terms of numbers in Puget 1 and Puget 2. Neurocognitive outcomes, 84% of patients either improved, was stable, or was stable after surgery, 16% deteriorated. Now if we can see that in Puget 2 grading, that means there is hypothalamic invasion, the neurocognitive outcomes are worse. We had good postoperative CSF leak rates, only 2 patients, that is 2.4% of postoperative CSF leak rates. Analyzing that, the stalk sacrifice strongly associated with achieving GTR and NTR, CASAM and Puget grading were significant predictors of extent of resection, and hypothalamic sparing tumors are significantly associated with better postoperative neurocognitive outcomes. So discussing this with our international study of patients, as we had discussed, our extent of maximal resection is well within global limits. Our greater proportion of patients are in P2 and CASAM grade 3, and we had a much more greater tumor presenting volume. These are our preoperative and postoperative image cases. Thank you.
Okay. Okay, thank you. So we can take 2 short questions from the audience. There are no questions. I want to ask you, what is unique that you demonstrated in this study? I mean, this is all part and parcel of a literature, and I know you had series, but did you learn anything new in this or something substantial?
Sir, when it comes to, especially our main aim was to compare our Indian data with international data, sir. Indian data, even when we have Indian data, the published report or the published studies are very few as in numbers. And even the amount of patients that are published, around, we had 44, 45 patients in the last study that I saw. But we have to increase that numbers, and we have to also extrapolate those neurocognitive outcomes and those visual outcomes when it comes to their actual functional status of living. That is what the aim of the studies.
Okay, thank you.
Thank you.
So we'll ask for the next speaker to come onto the podium. Kshitij Raj Mahajan. He would be speaking on outcomes of pre-operative endoscopic third ventriculostomy in posterior fossa tumors with hydrocephalus. So, is the speaker here? Who's the speaker? You're the speaker. Oh, I think he's not there. So we'll call upon the next speaker, Dr. Meghna KS, who's going to speak on surgical endoscopic endonasal anatomy of transpterygoid approach, a cadaveric study. So you can begin your presentation. So please stick to your time.
Good morning, everyone. I'll be presenting on the surgical endoscopic endonasal anatomy of transpterygoid approach, a cadaveric study. The skull base is one of the most complex anatomical regions, housing critical neurovascular structures. Conventional transcranial approaches require brain retraction, facial incisions, and carry a high morbidity. This approach offers minimally invasive access to petrous apex, lateral clivus, infratemporal fossa, inferior cavernous sinus, and the jugular foramen. This study was conducted to have a comprehensive knowledge of the surgical anatomy in this approach and to identify the Vidian nerve, which is the key landmark for petrous ICA. Moreover, CT and neuronavigation guided studies exist. However, cadaveric measurement studies are scarce. This was the first cadaveric study of transpterygoid anatomy from our institute. The aims and objectives were to map the surgical landmarks, which include the Vidian canal, foramen rotundum, medial pterygoid plate, and the paraclival ICA. Then, to measure the critical distances, that is, Vidian canal to midline, foramen rotundum to midline, foramen rotundum to Vidian canal, bilateral paraclival ICA at the level of foramen lacerum, and bilateral medial pterygoid plate distances. Then to establish an Indian reference data and to compare with the existing international CT-based and cadaveric literature to help us aid in preoperative planning. This study was conducted in our institute between Jan 2023 and June 2024. 10 cadaveric heads were used, 5 were non-dyed and the rest were silicon dyed. Red dye was used for ICA and blue was used for IJV. For the dissection purposes, skull-based endoscopic system Karl Stoss was used, and the 0 degree, 30 degree and 45 degree endoscopes coupled to a HD camera and video monitor for recording was used. For drilling the pterygoid bone, Esculap high-speed drill system was used, and for the measurements, transparent graph paper was used with a 1 mm precision. The following measurements were taken. In the stepwise dissection approach, we started with a nasal phase, which was a binostril approach where the turbinates were lateralized, posterior septum was removed, sphenoid was opened, and ethmoidal bulla and uncinate process was also removed. Superficial vascular plane of the pterygopalatine fossa was entered via modified Denker's approach. Then, the dissection was continued in a deeper plane in the nervous plane, and foramen rotundum and the maxillary nerve was identified. Following which, after the periosteal dissection, the Vidian canal and nerve was also isolated. Once the foramen rotundum and Vidian canal were identified, the distance between the two was measured. Later, transpterygoid drilling was done and vertical and horizontal petrous ICA were exposed. Other than that, paraclival ICA, foramen lacerum and bony eustachian tube were also identified. The drilling was continued laterally and foramen ovale and the medial temporal fossa was also exposed. These were the results that were obtained. The distance between the middle turbinate and the septum was 4.4 mm on the right side, and on the left side it was 4.3 mm. From the foramen rotundum to the midline it was 14.5 mm on the right, whereas on the left it was 16.2 mm. From the foramen rotundum to the Vidian canal it was 11.4 mm on the right, and on the left it was 12 mm. From the Vidian canal to the midline it was 11.5 mm and on the right, and on the left it was 13 mm. For the medial pterygoid plate, on either side it was 10 mm, and the distance and the mean distance between the bilateral paraclival ICA was 20 mm, and between the bilateral medial pterygoid plate was 22 mm. Displayed are the endoscopic images of the cadaveric dissection and the measurements. Here we can see that the measurement between the middle turbinate and the septum has been measured, which is around 4 mm, and between the foramen rotundum and the midline has been measured, which came up to be around 20 mm. And between the foramen rotundum and Vidian canal, which is approximately 13 mm, and between the two paraclival ICA at the level of the foramen lacerum, which came up to be around 23 mm in this cadaver. Key statistical findings of the study were that there was no significant difference in the measurements of right and left side, but there was a strong correlation, as in as the bilateral ICA and pterygoid plate distance increased, there was a significant increase in the distance of foramen rotundum to midline and Vidian canal to midline. But as compared to the other CT guided studies, international studies, the foramen rotundum to Vidian canal distance was larger in our study. As we can see in the slide, while comparing our study with the existing literature, we can see that the distance between the foramen rotundum and the Vidian canal was almost twice as much as compared to the other studies. However, the rest of the measurements were comparable, and ours was a cadaveric study as compared to the other studies that were CT based. Discussion. Vidian canal is the most reliable landmark of Peters ICA in this approach, especially in poorly pneumatized sinuses. Our cadaveric data confirms its consistent position relative to foramen rotundum. Foramen rotundum and Vidian canal distance is notably larger in our study as compared to the CT-based literature, possibly because of the morphometric variation in Indian population. This requires a CT correlation. There was no significant difference in the left and right parameters, and these measurements aid for preoperative planning of this approach. Knowing the distance between the foramen rotundum and midline and Vidian canal to midline helps surgeons anticipate depth of dissection and ICA proximity. The limitations of the study were that there was no CT correlation, the sphenoid pneumatization was not taken into account for, it was a small sample size, only 10 cadaver heads were used, and fresh cadaver studies would offer, we had a dried cadaver heads, fresh cadaver studies would offer a superior anatomical fidelity. To conclude my presentation, this study is the first Indian cadaveric morphometric reference for endoscopic endonasal transpterygoid approaches, a foundation for Indian-specific preoperative planning protocols. Skull-based parameters are comparable, and in our study, foramen rotundum to Vidian canal was notably larger. There was no statistical difference between the left and right measurements, and there was a strong positive correlation between the bilateral ICA pterygoid plate distance and Vidian canal and foramen rotundum to midline values. Thank you.
So thank you. Any questions from the audience?
Yes, sir. That is the reason probably the difference, there was a huge difference between the CT guided and our cadaveric studies. When it came to the foramen rotundum to Vidian canal distances that we measured, it could be because of the anthropometry. Yes. We should have taken that into consideration, so that had not been taken.
Thank you, Dr. Meghna. If we have no more questions, we go to the next presenter. Dr. Raghavendra G. Patel is here. Yes. And he'll be talking on endoscopic management of unusual cellular pathologies. Can I get a slide, please? In the meantime, when the other presenters are here, kindly ensure that your institution name does not figure out in the first slide. You can go to the preview room and do it if you have time.
Actually, the computer is not working.
You already put it. Yes. I think award paper, you should be having time and you should be going to the preview room and giving us slides earlier. The last moment is not appreciated.
It's a technical view.
Okay.
So till then, I request all the speakers to please upload their presentations on the preview room, please, to maintain the flow of the session.
Good morning. I'll be talking on endoscopic management of unusual cellular and supracellular lesions. Cellular and supracellular lesion. Cellular and supracellular lesion being the one of the very high complex region anatomically. So most common lesions seen are the pituitary adenomas, which account for about 85 to 90% of the incidences. So other non-adenomatous lesions account for about 10 to 50%, which are mainly the craniopharyngioma, meningiomas, and Rathke's cleft cyst. And even the rarer and unusual lesions account for less than 1% that I'll be enlisting now. So this table enlists different categories of the less than 1% of the incidences of unusual lesions. But I'll be speaking more on the hypophysitis, Rathke's cleft cyst, Arachnoid cyst, Masson's tumors, and the clival metastasis. So coming to the hypophysitis is the inflammatory disorder causing the endocrine dysfunctions, and occasionally it might also cause the cellular mass effect. And as described with the Caturegli et al., there are mainly two types, the primary and secondary, and again they are subdivided into many categories. And as compared to the adenomas, they differ in the manifestations, mainly in the endocrinological, and diabetes insipidus being the most common of it. And the Gutenberg et al. Has described the scoring system, where the scoring system ranges from -13 to +8. So if the scoring is less than 0 or equal to 0, then it's more suggestive of the hypophysitis, and more than 1, it's more suggestive of the adenoma. So accuracy of this scoring system is about 97%. So this has reduced the need for biopsy for the diagnosis of hypophysitis. So in this, you can see the first post-contrast coronal section MRI, where you can see the cellular lesion and also the stalk enhancement. And in the second, the post-contrast coronal sections causing the chiasmal compression, and the lesions being the post-contrast and hyperintense.
And in the third, you can see a post-contrast image of the sagittal section showing the sellar suprasellar. And all these three were managed, were initially diagnosed on the biopsy. But over the last 20-25 years, we have the collection of about 40-45 cases of hypophysitis. And over the last decade, the need of the surgery or the biopsy has decreased because of the more evolution of the clinical radiological scoring system. So next, coming to the Rathke's cleft cyst, these are benign and one of the frequently seen cellular pathologies which are lined by the epithelial lining. And the most common presentation being the headache and visual disturbance and hormonal imbalance, and these constitutes for the indication for the surgery as well. These can be cellular, most commonly seen, the ectopic or with a squamous metaplasia, or rarely in the carcinomatous stage. So in the MRI, you can see the post-contrast MRI in the axial, sagittal and the coronal sections, the cellular lesion, which is hypointense, well-defined and causing the chiasmal compression. And this is the case of the 14-year-old boy with the hypothyroidism and visual impairment. And you can see intraoperatively there is a typical machine oil appearance, and the cyst content can also be seen. And the main worrisome of the Rathke's cleft cyst is the recurrence. So here you can see with using this technique called as nasal mucosal coupling, which maintains the patency between the sphenoid sinus and the cyst cavity. So chances of recurrences are comparatively lower. So that is the histopathology where it shows the columnar epithelium-like lesion, the pathognomic of the Rathke's cleft cyst. Arachnoid cyst. So I'll be talking about, I'll be concentrating more on the intracellular arachnoid cyst. As we know, when someone addresses the cellular arachnoid cyst, it's more commonly addressed as a supracellular, which are comparatively more common, accounts for 5 to 12% of all the intracranial arachnoid cysts. But intracellular arachnoid cysts are extremely rare, and there are only less than 100 reported cases in the English literature. So to differentiate, the intracellular arachnoid cysts are seen more commonly in adult age groups, and the pathogenesis being the herniation to the diaphragm and causes the bowel wall mechanism. And here the hydrocephalus is usually rare, and the presentation is more like of any cellular pathology. And mainly what differs is even the management. In the intracellular, it's more of the endonasal, and the supracellular it's a transcranial. Both wise endoscopically can be managed. So this is the MRI. In the coronal, you can see the T2 hyperintensistic lesion in the cellular going all to the floor of the third ventricle. Mason's tumor is one of the vascular lesions, and it's rarely seen intracranially, more pronounced in the peripheral and the visceral. And these also mimics typically of the cellular lesion. So this is in the coronal sections, it's a hypo to iso intense on the T1, and post-contrast enhancement can be seen on in the section B. Intraoperatively, after opening the tumor cavity through transpinodal, it was a highly vascular lesion going more towards the left cavernous sinus. The maximum safe resection was done. And this confirms the pathology with the intravascular papillary endothelial hypoplasia, that is a Mason's tumor. You can see a significant difference between the pre-op and post-op. And coming to the metastasis, highlighting mainly the nature of the clivus because of the rich blood supply and the more common are hematogenous roots. This was from the Signet-Relsing carcinoma of the rectum. Take-home points, hypophysitis is now largely a clinical radiological diagnosis, rather surgery can be avoided. The Rathke's cleft cyst, the nasal mucosal coupling reduces the recurrence rate. Intracellular arachnoid cyst should be differentiated by the supracellular because the incidence, the clinical feature and the management, everything is different. Thank you.
Thank you, Dr. Raghavan. We'll take questions. Thank you very much. Can I invite the next speaker, Sarthak Dhulia? Yes. And he'll be talking on coexistence of two rare complications, late onset failure of endoscopic third ventriculostomy presenting as neurogenic pulmonary edema in a child with Dandy-Walker malformation.
Good morning, everyone. I'll be presenting a case report of late onset failure of endoscopic third ventriculostomy, presenting as neurogenic pulmonary edema in operated case of Dandy-Walker malformation. So Dandy-Walker malformation is a posterior fossa anomaly characterized by Vermean hypoplasia, cystic enlargement of fourth ventricle, and posterior fossa enlargement. Endoscopic third ventriculostomy is an established treatment option for the same. And ETV failure is characterized as early failure and late failure. Early failure is usually within a month, and late failure, the usual incidence is 2 to 15%, but sudden death due to late failure of ETV is extremely rare. Neurogenic pulmonary edema is usually seen in the setting of SH, TBI, or epilepsy, and rarely it can be seen in case of hydrocephalus also. So in this case report, patient was a 6-year-old girl, known case of Dandy-Walker malformation. First time she presented to us at 9 months of age with complaint of headache and vomiting and increase in head size. So at that time, she underwent right phaseous MPVP shunt and posterior fossa cystoperitoneal chamberless shunt. In post-op scan, the chamberless shunt was in C2, but right phaseous shunt was in prepontine cistern. But patient had subdural hygroma on the scan, and clinically patient was better, so patient was followed up. However, after 1 month, she again presented with complaint of headache and vomiting. So she underwent endoscopic third ventriculostomy. At that time, ETV success score was 60. After 5 months, she presented with complaint of CSF leak from abdominal bone, so that shunt was revised, and in view of infected CSF, shunt was exteriorized and removed, and patient was on clinical follow-up. This was the MRI done after 3 months of ETV, which was showing flow wide across the floor of third ventricle, suggestive of functional ETV. This is the flow wide. After that, patient was on regular follow-up, asymptomatic, and then 6 years later, at 6 years of age, she presented with complaint of headache for 1 day and multiple episodes of vomiting. At the time of presentation, patient was E3, V4, M6, and moving all 4 limbs. CT was done, which showed increase in ventricle size and effacement of all the sulcal spaces. Within 30 minutes of admission, patient had sudden deterioration to E1, V1, M1, and she underwent cardiac arrest. So CPR was initiated, patient was intubated, and right frontal EVD was inserted. Patient was revived with 1 cycle of CPR, and she improved in sensorium to E3, VT, M6 after EVD insertion. This was the CT done after the EVD insertion, which was showing EVD in right frontal horn. But after the intubation, during suctioning, there was pink frothy sputum, and patient saturation was 90%. This was the HRCT chest after the intubation, which was showing bilateral consolidation, ground glass opacities, suggestive of pulmonary edema. Then after that, patient was shifted to ICU for supportive ventilation and inotrope supports. Her 2D echo was done, that was normal, ejection fraction was 55%, but despite all measures, patient did not maintain saturation, and same evening she had cardiac arrest and could not be revived. So in this case, the unique points were sudden death due to late ETV failure, which was after 67 months of ETV. Then previously around 15 case reports were there of sudden death due to late ETV failure. But in none of the cases, patient improved after the insertion of EVD. In our case, patient improved to M6 sensorium after EVD insertion, but again she deteriorated because of neurogenic pulmonary edema and could not be revived. Neurogenic pulmonary edema due to VP shunt failure, there are some case reports, but due to ETV failure causing hydrocephalus and neurogenic pulmonary edema, there were no case reports. These are some case reports of late ETV failure. I'll be summarizing these in tables. So around 16 case reports were there of acute neurological deterioration after late ETV failure, out of which 13 patients died. So longest follow-up was 84 months after the ETV, which was done for congenital hydrocephalus, but in none of the cases, patient improved after the insertion of EVD. In our case, patient improved and again deteriorated. Then complication of endoscopic third ventriculostomy, so delayed sudden death is extremely rare complication, around 0.07% cases are documented. Then neurogenic pulmonary edema. So usual mechanism of neurogenic pulmonary edema is massive sympathetic discharge after the acute neurological insult, which causes hydrostatic damage and capillary damage to microvasculature of lung, which causes pulmonary edema. Usually it is a transient condition and patient improves with supportive measures and treatment of primary neurological insult. But in this case, patient could not be revived. These are two case reports of neurogenic pulmonary edema due to VP shunt malfunction. So this case demonstrates late ETV failure causing acute neurological deterioration, and this neurological deterioration was the trigger for neurogenic pulmonary edema, and she could not be revived despite neurological improvement after EVD insertion. So our learning points are, we have to suspect late onset ETV failure in cases of ETV who present long after the ETV with headache and vomiting. We have to educate the patient's relative about possibility of late failure of ETV even after months and years of ETV. We have to explain them about the danger signs. And in case of respiratory compromise following some neurological insert, neurogenic pulmonary edema should be suspected. Thank you.
Any questions? So yeah, it is a demonstration of a very important complication, and obviously you said it's not very well demonstrated in it. So how do you prevent it? Let us say you have a VP shunt which has failed. So one way is you can immediately exteriorize on the bedside. So you have some kind of a rapid resuscitative method. Now in case of an ETV, let us say, how do you?
Sir, in case of ETV failure, if patient has deteriorated rapidly, so the only option is to put an EVD. If, like in this case, patient deteriorated to M1 sensorium. So immediately we have to take up for, immediately we have to insert an EVD. In case of VP shunt failure, this first, if we have to, we can do a shunt tap to check for the characteristic of failure, whether that is proximal or distal block. In case of distal block, it can be immediately exteriorized. In case of proximal block, we either need to revise the shunt immediately if patient's clinical condition permits, or we can insert an EVD.
That's okay.
So, complication of CSF leak or hardware-related complication, and sudden death due to late ETV is extremely rare complication. So, this long follow-up is means better as compared to putting in Omaya and increasing the risk of infection, but it can be considered.
In your study, what is your conclusion? How frequent is the ETV failure?
Sir, it is extremely rare. Only about some 0.0 in one case series there was some 0.07% cases of late on sudden death due to late ETV failure. Late ETV failure is some 2 to 15%, but sudden death is extremely rare.
Okay, in your presentation you told about that the VP shunt was placed and it was in the pre-Pontine system.
Yes, sir.
Is it a typo error or was it really in the pre-Pontine system? I mean, we have all seen malpositioned shunts, but what did we do about the VP shunt going up to the pre-Pontine system?
Sir, in post-op CT, it looked like that
CT
it was in
so did we remove the shunt immediately once we saw that?
Sir, actually, in immediate post-op scan, there was some subdural hygroma, and patient was clinically better. So we did not do anything at that time. But 1 month later, when patient came with complaint of headache and vomiting, at that time ETV was done, but we did not remove the hardware. When patient had presented with infection after 6 months, at that time this hardware was removed.
So if there was a VP shunt in the pre-Pontine system, how did we do an ETV? I mean, that's what I wanted to ask, because that's where we want to penetrate.
Sir,
and that's the point I want to ask. You understand what I'm saying?
Yes.
See, in the ETV, we are diverting the CSF flow to the pre-Pontine system. So if there was already a shunt placed there, so how did we negotiate that? That is something to be. Okay, fine. Thank you. Thank you.
Thank you, sir.
I have a question. Yeah. Can I ask a question?
Please, please.
Yeah. You reviewed 16 cases in the literature. Is there any suggestion of any predictive factor for this edema?
Sorry, sir?
Any predictive factor for this edema in the
Sir,
16 cases?
In 4 of the cases, previously shunt was there. And in case of shunt infection, there was some increased risk of ETV failure, but there was no clear-cut predictive risk factor for late onset ETV failure.
Is there any suggestion in any protocol change in the management?
Sir, actually we can follow up patient with repeated MRI, and long-term follow-up is the only thing that can help in this, because we have reported cases even after 7 years of ETV causing sudden death due to failure. So long-term clinical follow-up and education of patient's relative, that is most important. And early suspicion of ETV failure whenever patient presents with headache and vomiting.
Hello. The bulge at the ATV site can be a sign. Can be asked patient to look in for if there's seeing the bulge at the ATV site. That's a telltale sign that probably ATV is not functioning right. Dr. Soman Kanjilal for his presentation on modern endoscopic perspective, the supracerebellar infraterritorial approach to deep intracranial lesions.
Accessing deep brain structures demands not only surgical precision, but also optimal illumination to safely identify crucial neurovascular anatomy. With the advent of modern endoscopic system, many of these challenges have been addressed effectively, expanding the horizons of minimally invasive neurosurgery. Good morning, everyone. I am Dr. Soman Kanjilal, and today I shall be presenting our experience in managing these cases. So lesion in and around the pineal region represents one of the most technical demanding domains in neurosurgery. Due to their proximity to vital structures, these lesions encompasses a diverse spectrum of tumors with complex pathological characteristics. Traditionally, the occipitotemporal and supracerebral infratemporal approaches are most commonly employed. The classical CETA is performed in sitting position, providing a direct trajectory to the pineal region. However, the microscopic technique is often limited by a deep, narrow operative corridor, suboptimal illumination, surgeon fatigue due to steep tentorial angle. So, this study was conducted to evaluate the clinical outcomes of tumor resection using the endoscopic supracerebral infratentorial approach in selected cohort of patients, lesions located in and around the pineal region. The objective was to assess the safety, feasibility, and effectiveness of the minimally invasive technique. Here we have performed a retrospective review of all the patients who underwent endoscopic supracerebellar infratemporal resection at our institute between January 2024 to December 2025. Patients' demographic, presenting symptoms, neurological findings were recorded and were analyzed. So all the procedures were performed using a pure endoscopic supracerebellar infratemporal approach. Patients were positioned in left lateral oblique position with head secured in a 3-pin Mayfield clamp and the upper body elevated by approximately 30 degrees. A 7 to 8 centimeter posterior midline incision was made over the inion. The pericardium and the deep fascia were harvested in selected cases for dural repair. Midline muscle retraction was performed and laterally retracted. The 2 burr-holes were placed on either side of the external occipital protuberance, and a 4x4 centimeter craniotomy was performed. This exposed the torcula and the inferior portion of both the transverse sinus. A 2-surgeon 4-hand technique was employed. A 0-degree rigid endoscope held by assistant allowed the primary surgeons to operate bimanually. The arachnoid over the quadrigeminal cistern was opened and bridging veins were carefully mobilized. Select lateral bridging veins were sacrificed when necessary to widen the corridor, as operating within the tight venous confines risked sudden tearing and significant bleeding. The surgical corridor was developed through the left side of the quadrigeminal cistern. After arachnoid dissection, the tumor was exposed and removed in piecemeal fashion. After final tumor removal, hemostasis often is achieved by gentle applying gelatin sponge and gentle suctioning and continuous irrigation. The primary dural closure was attempted in all cases. When not feasible, gelatin sponge was initially used, though this led to postoperative wound bulging in some patients. Subsequently, routine facial graft reinforcement was adopted, significantly reducing the risk complication. The bone flap was secured with titanium mini plates and screws. Now, this is an image of the previously operated case where we can see a huge lesion over the just posterior to the midbrain, and this is the postoperative image of the same. We operated a total of 30 patients with this using this approach with a median age of 21.5 years. The majority presented with features of raised intracranial pressure and most had preoperative modified score of 3 to 4. So gross total excision was achieved in around 84% of the cases, and primary dural closure was feasible in 4 patients, while 9 required reinforcement with gelatin sponge alone. In later cases, we transitions to the closing the dural defect using locally harvested facial layers. The median operative duration measured from induction to extubation was 7 hours with a median blood loss of 450 ml. The average postoperative hospital stay was 7 days. Postoperative complication occurred in 20% of the patient, most commonly a CSF leak or wound bulge. 1 patient developed meningitis, and a serious adverse event was observed in 1 patient with the brainstem pilocytic astrocytoma who developed bradyarrhythmias and asystole 6 hours postoperatively and finally succumbed. So our outcome analysis was that 66.7% of the patients showed significant clinical improvement, as the most common complication was of that of CSF leak, observed in 6.8%, and 5 patients required BP shunting, where 2 patients were preoperatively shunted and 3 patients required postoperative shunt. So while reviewing the literature, we identified a limited number of cases and original studies. Notably, G and associates conducted a comparative analysis of the median and paramedian variants of supracerebellar intratemporal approach. So while they concluded that the median approach offers superior access compared to the paramedian variant, our experience differed. We performed all cases using the paramedian approach, as we found it unnecessary to sacrifice the precentral cerebral vein, which is often required in median approach. So to conclude, the modern full endoscopic approach represents a promising advancement for resection of tumors in and around the pineal region, enabling gross total excision while minimizing the risk of associated with traditional techniques. Our findings suggest that this technique effectively integrates the strength of conventional approach with the advancement of minimally invasive endoscopic surgery. Thank you.
Anyone from the audience have any questions for the presenter? Yeah. Dr. Jayesh, come with the mic.
So, I mean, absolutely amazing. No doubt that the endoscopy for pineal region is beautiful because you can address all the quadrant, bilateral, irrespective of the size, you can approach the tumor. Just a surprise that you are doing endoscopic assisted. Why that large craniotomy, which usually we do for microscopy, you need for endoscopy assisted things?
So, sir, in most of the cases, what we do is that we access that even though the tumor is large, we access it from one side only. So for manipulation of the instruments, we require a larger craniotomy so that because we need space for the brain to shift also, so as to manipulate it. So to counter that thing, we need a larger craniotomy.
No, Dr. Soman, you don't understand his question. He's saying that in a microscopic surgery, you do the same craniotomy. In endoscopy, you also do the same craniotomy. So the advantage of endoscope over microscope is that it's a smaller craniotomy you can go into. You can have a panoramic view. You can go through the crevices, which is not seen in microscopes. So did you compare those things? That's what he wants to ask.
I mean, if you want to go to a paramedian, you can tailor your craniotomy 2 centimeter here or 2 centimeter there. You have approach all the corridor first, and then you are doing endoscopy. So did you do that at the end of 30 cases? You try to tailor your craniotomy in small because it's not necessary. Do you agree with that?
No, till date we haven't tried to reduce the craniotomy size as of now. So yes, it is a very good idea. We can perhaps do, in our follow-up cases we may do it. In the subsequent cases, we can definitely reduce the size.
Thank you. Thank you, Dr. Soman.
Thank you.
Thank you, Soman. Do we have the next speaker, Vartika Gupta? Yeah. And she'll be talking on outcomes of endoscopic transsphenoidal pituitary surgery in patients with Cushing's disease, a retrospective review.
Good morning, everyone. Cushing's disease remains one of the most challenging endocrine disorders, not because we cannot operate, but because defining surgical success itself remains controversial. Today, I will be presenting our experience on outcomes of endoscopic transnasal surgery in Cushing's disease with a special focus on how remission rate varies based on the biochemical definitions. Let me begin with a brief background. Cushing's disease is a rare but serious endocrine disorder caused by the ACTH secreting pituitary adenomas. In terms of epidemiology, the prevalence is 40 per million with an annual incidence of 1.2 to 2.4 per million. The surgical goals were biochemical remission, durable disease control, and minimum morbidity. And the determinants which were used for outcomes were tumor size and cavernous sinus invasion, MRI characteristics, perioperative cortisol and ACTH levels, and intraoperative tumor visualization. The core challenge in Cushing's disease remains variability in reported remission rates. According to literature, the success rates vary widely, making the inter-study comparisons difficult and sometimes misleading. This is primarily due to three reasons. First is the heterogeneous definitions. Second is the small retrospective cohorts and inconsistent follow-ups. Third is the limited distinction between early remission and durable disease control. In our study, we have used a standard criteria based on the Endocrine Society guidelines, and in contrast, the strict criterion based on our institutional protocol using a lower cutoff value of POD3. The aim of the study was to evaluate the surgical outcomes, to directly compare the remission rates, and to assess the clinical impact of these definitions on the reported outcomes and decision. This was a retrospective study done at a tertiary care center from January 15 to July 2025. All the patients underwent image-guided endoscopic transsphenoidal surgery. The study was reported according to stroke guidelines, and the patient selection was done on the basis of overnight dexamethasone cortisol of more than 50, elevated late-night salivary cortisol, and elevated 24-hour urinary free cortisol. A total of 82 patients underwent 88 endoscopic surgeries. The median age of presentation was 33.6 years with a range from 14 to 71 years. There was female predominance with 71% females. The median duration of symptoms was 39 months before the presentation, and hypertension was present in 95% of the patients, while diabetes mellitus was present in the 73% of the patients. Cavernous sinus invasion was seen in a small number of patients, and IPSS sampling was performed in 85% of the patients, mainly in small or equivocal lesions. The centripetal obesity was the most common clinical feature. However, it is important to note that these features are non-specific. Therefore, biochemical confirmation was essential for the diagnosis. The diagnosis was performed in a stepwise manner. First, exogenous glucocorticoid exposure was excluded. This was followed by biochemical screening using tests such as urinary free cortisol, late-night salivary cortisol, and dexamethasone suppression testing. Also, in suspected pseudo-Cushing states, prolonged dexamethasone suppression test was confirmed. Next, a morning ACTH level helped in determining the source of the ACTH. Next, imaging and localization was done using MRI and IPSS, and then the patient underwent ETSS surgery. The surgery was done using a standard binostril approach. Selective adenomectomy was done when the lesion was identifiable on imaging, and diagnosis was confirmed based on the histopathological and IHC study for ACTH. The post-operative complications which we endured were the transient diabetes, which was present in 26% of the cases, permanent diabetes insipidus, which was present in 9.75% of the patients and was confirmed using the water deprivation test. Also, we observed secondary hypothyroidism in 14.6% of the cases, gonadotropin deficiency in 7.3% of the cases, particularly in perimenopausal women presenting with amenorrhea. An important observation was diabetes insipidus was more common in the macroadenomas, likely due to stalk proximity and need for more aggressive resection. Moving to the surgical safety profile, we had no cases of post-operative CSF leak, meningitis, visual deterioration, or vascular injury in this cohort. Finally, coming to follow-up and recurrence analysis, the patients were followed using a structured timeline. After surgery, HP axis recovery was assessed at 3 months using insulin tolerance test and short cyclothin test, followed by clinical reassessment at 3 to 6 months and annual screening for recurrence thereafter. Biochemical recurrence was defined as failure to suppress the cortisol below 50 nanomole per liter after overnight dexamethasone suppression. Alternatively, recurrence was also considered if there was elevated late-night salivary cortisol or 24-hour urinary free cortisol. In terms of study outcomes, a median follow-up of 4 months was done, and we observed 2 cases of recurrence. Notably, both of them were macroadenomas. And an important finding was that these patients met standard remission criteria but failed the stricter POD3 cutoff. Now coming to recurrence, more recurrence was seen in the higher cortisol in macroadenomas, and the overall recurrence rate was 2.4% and mainly in the macroadenomas. Moving to the definition variability, one key issue is the recurrence criteria differ significantly across the studies, making the direct comparisons difficult. The remission was assessed using these criteria. Our standard, using the standard criteria, the initial remission rate was 85.4%. When stratified by tumor size, microadenomas had higher remission rates, and a subset of 6 patients required early ETSS, following which overall remission improved to 90.2%. Concluding, from the surgical efficacy standpoint, the endoscopic transphenodal surgery is highly effective, particularly for microadenomas, achieving remission rates exceeding 85% using the standard criteria. However, an important observation is that remission is highly dependent on the biochemical definitions used. While the standard thresholds may overestimate the success, stricter POD3 cutoff cortisol appear to predict better long-term durability. Additionally, the tumor size remains a key determinant, with microadenomas consistently showing superior outcomes compared to macroadenomas. In terms of safety, our series demonstrate a favorable neurological profile with no major neurosurgical complications. Looking ahead, the long-term surveillance is essential, as recurrence may occur even after the initial remission, and there is a clear need for standardization of biochemical remission criteria to enable meaningful comparisons across the studies, and additionally, refinement of protocols, particularly for patients in the intermediate cortisol range, can avoid unnecessary reoperations. Thank you.
Thank you. Thank you, Vartika. Any questions you have? I don't think questions cross the time. Thank you. So I think.
So we conclude this session. So thank you very much for participating in this.
What an outstanding display of innovation and research.
A big thank you to our judges and presenters. Honestly, choosing a winner here must be incredibly tough.
Probably tougher than spotting a tiny lesion on imaging.
We now move to Plenum 1, hydrocephalus.
moderated by Dr. Anand Balasubramaniam, Dr. Ashok, Dr. Pankaj Arora, and Dr. Manish Agarwal. This plenum will consist of 5 sessions lasting for 15 minutes each. I would like to request all the participants to send their PPTs in the preview room.
Yeah, morning everyone. We will be starting the session on hydrocephalus. First speaker will be Dr. Aaron Mohanty. He'll be speaking on aqueductal stents for isolated fourth ventricle, efficacy and long-term outcome. Dr. Aaron, please.
Good morning, chairpersons, colleagues, and friends. And thank you, Dr. Bansalji, for inviting me and the organizing committee for this. Basically, we'll talk about aqueductal stenting and what's the long-term outcome of that. So, as we know that aqueductal reconstruction procedures involve aqueductoplasty and aqueductal stenting. And the indications are for aqueductal stenosis and isolated fourth ventricles. So I'll just briefly, we know about aqueductoplasty is almost given up now because of the long-term closure and failures. So we'll come to the isolated fourth ventricle where this is still mostly used there. So isolated fourth ventricle is essential. The fourth ventricle is trapped at the inlet and the outlet, and it can be associated with decompressed supraventricular hydrocephalus, which makes it more difficult to manage. It can be also symptomatic or asymptomatic. The management there have been several articles in the last 20 years of management of isolated fourth ventricles. This was a compiled list till by 2017 or 2018, and after that, I think there are much more articles on those. Essentially, we summarized this in 2018 about various procedures which are available. And there are basically 3 groups. One is a suboccipital craniectomy and excision of the outlet foramen or fenestration. And then there is a fourth ventriculoperitoneal shunt, or there is a stenting to communicate the isolated fourth with the rest of the ventricular system. So the currently practice options for isolated fourth ventricle involves basically depends on 2 different conditions. Is there associated ventriculomegaly or not, and how long is that aqueductal stenosis? Obviously, is not indicated in long segment stenosis because of the associated injury to the aqueduct and the midbrain, whereas the larger ventricles make it much easier to place a stent through the third ventricular route. As you told, the technical challenges include normal sized ventricles. We have also options like a fourth ventriculoperitoneal shunt or a combined shunts. So the commonly practiced options include a lateral ventricular shunt with a fourth ventricle shunt, or there's a lateral ventricle shunt with aqueductal reconstruction, either a stent or a aqueductoplasty, or you can also do a third ventriculostomy and reconstruction. Dilated ventricles pretty easy to place because the ventricles are dilated, and it's very easy to do the procedure. In well decompressed ventricles, slightly difficult. Either you have to dilate the ventricles to make it bigger, or you have to use one of those shunt scopes, which basically is intraluminar scopes which passes through the shunt tube to, or you can always put in a reverse stent which goes from the fourth ventricle into the third ventricle. Well-decompressed ventricles, this is the child which we placed with the shunt scope, and we did not dilate those ventricles, and I guess the shunt scopes are no longer available now. Stores used to make those, and I think they discontinued several years ago. Coming to the stents, there are basically two groups of stents, which is a non-anchored or a free stent, or there's an anchored stent. Initially, when we started with a non-anchored or free stent. I got a picture from one of those publications where there's basically a little bit of ventricular catheter covered with some cotton to keep it in place and to cause fibrosis. Or in sometime in 1999 or 2000, we devised a aqueductal stent with a shoulder, which basically prevents it from migrating downwards. The problem with these stents do migrate. And you have to follow up with, you have to revision or retrieve this stent afterwards. So subsequently came what was the anchored stents. And it's basically a long ventricular catheter with additional perforations connected to a Ommaya reservoir which keeps it in place. So these stents do not migrate, so that's a good thing, but over time you realize as the head grows, these stents fall short or they retract, so some of them may need a revision. There are two ways you can put the stents. There are a lot of neurosurgeons advocate a single system, which is stent connected to Ommaya reservoir connected to a VP shunt. What I usually prefer is two different systems. There's a individual stent which is connected to Ommaya reservoir to the frontal burr and I put in a ventricular shunt to the parieto-occipital burr. The advantage of this is that if the shunts will malfunction, you cannot keep them patent forever. And when they malfunction, you need to probably, if it's a single system, you need to revise the shunt and the stent together, and nobody wants to do those in the middle of the night. So it's better to keep them separate so that if you need to revise the shunt, you revise the shunt and don't touch the stent. So the experience is from 2005 to 2023. We had 32 patients with isolated fourth ventricle. I excluded aqueductal stenosis. So this is for isolated fourth ventricles underwent stenting with an anchored stent. So it excludes non-anchored stents which used to place between 1999 and 2004. So there are 31 trans third ventricular stents, routine trans third ventricle, transaqueductal one. One was a transatrial because the atrium was so dilated to put a stent through it. We lost 2 patients in the follow-up. They got lost, and there 2 patients expired. They were neonatal kids which had problems subsequently. So we had 28 patients which you could follow up. The age of the initial stent insertion is, most of them were less than 6 months of age, and there is a good number between 7 to 24 months of age, and there were 2 were in adults group. So basically the concern comes when you have these children, the neonates who are born early and you put in a stent, when they follow them up, what happens to those? The follow-up duration varied between 2 years to 20 years for the kids who are less than 6 months and up to around 8 to 10 years for the adults. So the average was somewhere between 8 years to 10 years. So on the follow-up, we realized that do the stents obstruct? We had never, we did not see, I cannot say never, we have not seen a patient still which the stent has obstructed and the child was symptomatic for it, or it was detected asymptomatically at follow-up. We usually routinely follow them up every year with a CT scan and a shunt series and intermittent MRI scans to be done, and we did not see any of the stents malfunctioning or obstructing on their own. What about stent retraction? This is one thing we are realizing is more frequent now when the child grows. With our 20 patients, the stent retracted from the position. They did not move up, but the head grew, so the stent, basically, the tip migrated up. So I just divide them in 3 groups for classification purposes, group 1, group 2, and group 3. 15 of them had very mild retraction, which is expected, and the tip was below the level of the apex of the fourth ventricle. In about 3 patients, it moved up superior to the apex of the fourth ventricle, but still inside the fourth ventricle and did not need revision. And in 2, we had to revise those. We had no stent retraction in 8 of these children. I think 2 of them are adults which head never grew, and there are few of them are, we don't have that long follow-up, which only about 2 or 3 years follow-up. So this is a child who was born in 2017 of March. We put in a stent, and it's a pretty significant stent in the second picture, long stent. And in 3 years of time, you can see the stent has retracted superiorly. It was still functioning, but it was precariously moving, retracting up. And so you revised it. I put in a longer stent. We used one of the intraluminal scopes through it and put it back, and we are following up the child. And this is from 2025 May, which is stent has placed. So the child is now 8 years old. I don't think the head is going to grow that much to cause any concern in future. There's another one which was also in 2017, and this stent is a longer stent in the first picture on the left side. It's even touching the calvarium. But over time, it is retracted up now, and it is sitting somewhere near the apex of the fourth ventricle. We are watching this child, again 7 to 8 years old. I don't think she will need any surgery, but we are watching her. So of these 5 children who had grade 2 or grade 3 retractions, 4 of them were placed less than 6 months of age, which 4 of them were placed, all were placed actually below 3 months of age, and 1 was placed between 6 to 9 months of age. And the duration between the initial placement and the retraction was less than 4 years in 2 and around 5 to 8 years in 3. All the two needed correction were born significantly premature, around like less than 26 weeks of gestation, and the stents were placed around 3rd or 4th months of the life, so they're pretty significantly, practically placed at birth. And we had put longer stents in both, and we used intraluminal scopes in both of those. The other thing we noticed that when the shunt malfunctions, the fourth ventricle dilates with in some of these children, because basically we are making the biventricular hydrocephalus univentricular hydrocephalus by connecting them, and the shunt malfunctions, the ventricles dilate, the fourth ventricle can dilate. And when the shunt is revised, the ventricle size comes down. This is a child who has a preoperatively placed stent, the fourth ventricle came down to some extent, had a shunt malfunction in June of 2023. I didn't have an MRI scan done prior to the surgery, but you can see the ventricles are pretty large in the CT scan, SAG images of the fourth ventricle, and after revision, the fourth ventricle size came down when the lateral ventricles came down. So this is the third thing we have observed at follow-up. The reduction in ventricular size, we know that the aqueductal stents do not reduce the ventricle size significantly as the fourth ventricular shunts. It's probably around 33 to 1/3 to about 50% reduction in size, not as significantly as the fourth ventricular shunt, but some of them do reduce in size. So in summarizing that, it's a procedure which is reserved only for certain group of people, basically short segment stenosis, and is preferably done in a ventriculomegaly. With associated ventriculomegaly, the incidence of stent obstruction is not very significantly high now. Retraction is a concern which we followed up, especially when they're placed at a younger age group. Physiological stent malfunctions with a dilatation of fourth ventricle occurs, but it reverses. Thank you very much for the thing. Most of this was done in one of my previous practice at UTMB in Texas.
Thank you, Dr. Mahathi. That was very clear solution to this very vexing problem. My question to you is, what do you do when there is collapse of the lateral ventricles and you have only the isolated fourth ventricle dilatation?
Yes,
What,
so,
in your experience, how have you handled
yes,
that?
so I think there are a few of these. One of them is that you can do a reverse stenting left from fourth ventricle to the foramen magnum and put it there. I have no experience on that. And the second thing that we can, what I've done is usually externalize a shunt, dilate the ventricles, and then make it safe to pass for a rigid scope and put in a stent. Or you can use one of those intraluminal scopes. I think Medtronic still makes those. They're disposable and they're expensive. Stores used to make those. I think I was told last year they discontinued it. Or you put in a fourth ventricular peritoneal shunt.
I think that's the only option. Yeah, please.
Very good paper, actually. Very impressed with the results and all that. My question is that what are the complications you have encountered during stenting this entrapped fourth ventricle, and how do you manage these complications?
Yes. So the apart from the most significant concern we had when we used to put those stents, free stents or the stent microstent, I usually choose only when there's an aqueductal web or there's a very short segment stenosis, where I can identify the proximal inlet of the aqueduct as I go from the lateral ventricle to third ventricle. I don't try to do them when there's a long segment stenosis. So that basically avoids any aqueductal injury. But I had two patients where there was ptosis. I think one had aqueductoplasty, who got a ptosis, and it improved, and another one had a diplopia or a double vision. But what I've seen that it's more a scare than more actually a concern. People get scared about it, saying that I'm not going to go on aqueduct, but if you choose the right patient and in the right size of the ventricles, then it's a pretty easy job.
Dr. Bharti.
Going back to the first question of the isolated with the normal or a small sized ventricle, you said one of the techniques as reverse stenting from foramen, and you have no experience of that. Have you seen any article on that in Journal of Neurosurgery Pediatric section? I think you showed on this side there was that article, was that, or?
Yes, there have been articles published through the stenting through the transforamen magnum route. Yeah. The problem here happens is that you are going from it's always convenient if you go from a dilated ventricle to a dilated ventricle. But here you're going from a dilated to a non-dilated ventricle. So if you can identify the outlet of the aqueduct, which is usually dilated, and find where is obstruction, you can put in a stent through that. But I don't think there are many people who are practicing it or doing it.
I was wondering if anyone has the experience of that reverse stenting.
Yeah.
Thank you, Dr. Mahanti.
Thank you so much.
Dr. Mahanti, one question. Yes, sir. What is your take on post-infective isolated fourth ventricle?
Yes, you can do this. Once the infection settles down, you can put in a stent. I think for me, if you ask me, I think the only indication of aqueductal stenting right now is isolated fourth ventricle. I don't think it's that useful in aqueductal stenosis. You have better options available. Third ventricle is much better. So if there's a isolated fourth ventricle is a post-infective and infection settle down, you can always put in a stent.
Suppose you do the stenting and the ventricular size doesn't come down and patient is still symptomatic.
If the ventricle size come down and is symptomatic, then it's probably associated injury to the thing, and you probably can reverse it.
Thank you.
Thank you.
Thank you. I think we go on to the next speaker. Is Dr. Kulkarni here? Yes. Dr. Kulkarni will speak on the multi-center randomized trial of endoscopy versus shunt treatment for infant hydrocephalus. An update.
Again, I would like to request the presenters to submit their presentation in the preview room.
Thank you very much. So first, I want to thank Dr. Bansal and the organizers for giving me the opportunity to speak and be at this fantastic meeting in this wonderful city. I'll be speaking about giving an update on the multi-center randomized trial of ETV with choroid plexus cauterization versus shunt that we're conducting right now in North America, and I'll try to highlight some of the difficulties that we've had in trying to get this study done and underway and now nearing completion, fortunately. So I think most people here know that targeting the choroid plexus as a treatment for hydrocephalus is not new. This is something that's over 100 years old. In the early part of the last century, there were attempts at either cauterization or even plexectomy. These were largely not successful because of both technical limitations and anesthetic issues. And then in the mid to latter part of the last century, CSF shunts became popularized. So CPC really was not all that popular, but then regained its emergence in the early part of this century with Dr. Worf's work, where he described in Uganda using a single coronal entry site technique and then using a flexible endoscope to perform the ETV and the choroid plexus cauterization. And he would access both lateral ventricles by performing a septum pellucidotomy when required. And the attempt was to cauterize as much of the choroid plexus as you could of both lateral ventricles, in addition to doing the ETV as well. And since that time, a number of studies have come from Uganda that have shown the efficacy of this procedure, at least in that population. And overall, it's shown that the choroid plexus cauterization improves the success of ETV in a range of etiologies of infant hydrocephalus, including post-infectious hydrocephalus, myelomeningocele, and others. We've since conducted a randomized trial in Uganda looking at specifically infants with post-infectious hydrocephalus, and we showed no difference in 12-month developmental outcomes. So this was looking at cognitive outcomes. No difference in 12-month outcome, 2-year outcomes, and more recently we published 5-year outcomes that have shown that both procedures are similar. In North America, we've had a little less experience with this, but just to show you, give you a highlight of some of the studies. This is Dr. Worf's experience from Boston, from when he returned to Boston. This is over 200 patients with ETV CPC, and you can see that in the dark blue line here, he demonstrates that the primary success rate is on the order of about 50% in this infant population of ETV CPC. When he reoperates on a portion of these failures, the overall shunt freedom rate is on the order of about 69–70%, so quite good results. Now, he, of course, was the person who developed this procedure, and we would expect the best results from him. We've looked at this in our hydrocephalus clinical research network, so these are 14 centers across North America that do hydrocephalus research. And you can see here the trend in the use of ETV CPC in our network. After Dr. Worf published his paper in 2005, for the next 5–6 years, we did a few each year on some unusual cases. But then in 2012 and 2013, we did this in a more deliberate fashion. Many of us went to Uganda to spend time there and learn the procedures from Dr. Worf and the others in Uganda. And then from that point onwards, we've been doing this a fair bit. So now well over 500 cases in our database and over about 90 cases per year that we've been doing since about 2015. If you look at some of our results, they're decent but not great, about a 40% overall success rate. Keeping in mind, again, these are all very young infants where we wouldn't expect a tremendously high success rate anyway. A number of studies that we've published within our network and from others across North America have shown that the prognostic factors for ETV CPC failure in the North American population One important one is the presence of prepontine scarring or adhesions, as I've shown you here in the sagittal Fiesta MRI. So we look very carefully at that, and these are patients we typically would not do ETV-CPC on. Younger age is also a bad prognostic factor, as we've come to expect from ETV in general, especially if they're under 3 months of age. In terms of etiology, intraventricular hemorrhage of prematurity appears to be a particularly poor group in terms of success rate. But what matters also is the degree of choroid plexus cauterization. So the more choroid plexus you're able to cauterize, overall better the outcome. And so the major questions that we had for ETV plus CPC in North America are things like, what ages and what etiologies are the success rates too low to even offer this procedure? Should we just go straight to shunt? But related to that, and not always correlating with that, is how low a success rate are parents willing to tolerate for the possibility of shunt freedom. So you can tell them the success rate is very low and I would recommend shunt, but many of them still insist that you do this procedure even for a very low success rate. And then I think the other question that we all have for endoscopic procedures, and this one in particular, is we know that after this type of a procedure, the ventricles stay large. We also know that when you add the choroid plexus cauterization, studies have shown that there is some decrease in CSF production. It's not a large amount of decrease, but it is a significant amount. And does this have negative cognitive impact down the road? So these are the questions that we're faced with. And so in 2015, our research group, the Hydrocephalus Clinical Research Network group, asked if the timing was right for a randomized trial to definitively compare ETV-CPC versus shunt in North America. And it was a time that we had grown our experience with this procedure. We felt comfortable with it, but it had not yet gotten well established enough to be defined as a standard of care by any means. And what we recognized, though, is that to do this type of study properly was going to require a significant amount of resources and a lot of money. And so we worked with the, we worked with the National Institutes of Health in the US for the next 4 years to try to secure funding for this study, which I think highlights one of the difficulties in trying to get this type of research done. And ultimately, we were able to secure funding for this. It's a 7-year multi-center study that's going to cost about $10 million US. Okay, just highlighting again how difficult and how expensive this type of research is, at least in the North American setting. The primary study question that we asked is, for infants under 2 years of age with hydrocephalus requiring treatment, does treatment with ETV-CPC compared to shunt result in non-inferior cognitive outcome at 12 months? So here, although we're going to look at a number of other factors, the primary outcome was looking at cognitive outcome, and what we were looking at wasn't to show that ETV-CPC was better, but rather that it was not any worse than shunt. In addition to this outcome, we were looking at very detailed MRI, diffusion tensor imaging markers, CSF biomarkers, quality of life outcome, resource utilization, and of course things like surgical failure and surgical complications. The inclusion criteria for this randomized trial is being over 37 weeks gestational age, but under 2 years corrected age, and no history of previous shunt or ETV, so it's first-time treatment of hydrocephalus. Exclusion criteria, we excluded intraventricular hemorrhage of prematurity as a cause of hydrocephalus because we'd previously shown that the outcomes for this particular group are quite poor with this procedure. And as well, for the reasons that I talked about before, if they had moderate or severe prepontine scarring or adhesions, they were eliminated as well from this study because of their high failure rate with ETV-CPC. We also recognized that this was going to be a hard study to recruit into because when you have a surgical trial, particularly where the two treatment arms are quite different, endoscopic surgery versus shunt surgery, there was going to be hesitance on the part of families to want to randomize for this. And so one of the things that we preemptively did was introduce something called an equipoise panel. And what this meant was that when eligible patients were identified, their case would be reviewed by up to 16 independent pediatric neurosurgeons across our network who would review the case and then independently determine, is this child suitable for the study, meaning is this child suitable for both procedures, shunt or ETV-CPC. We would get those results as the investigator within 12 hours, and then we would discuss with the family and say, look, we've had 12 neurosurgeons look at this, and they think both procedures are good, so this would be a good case to be randomized for. Despite that, however, randomization and recruitment has been difficult. So Overall, if you look at the numbers, for all the people that are approached for the study, about half of the parents right away say they don't want anything to do with the study, not interested at all. They already know that they want you to do the shunt or they want you to do ETV CPC, and they don't go any further than that. Of the half that agree to at least consider the study, they're sent for the panel review, and in the vast majority of cases, the review panel says that these are appropriate patients. So these half of patients are offered randomization, but of these, only half of these families agree to randomization. So you end up with about 25% being randomized. So if you look at our overall study numbers up until now, we've screened over 2,000 patients for this study. About 500 were deemed eligible and were approached for the study. Of those, about 275 were offered randomization, and of those, about 150 were actually randomized. So currently, right now, we're sitting at 154 patients randomized since 2020. So it's taken 6 years to really accrue this number of patients. We're not quite done yet. We're going to complete recruitment hopefully towards the end of this year. And just to show you, how difficult it's been, the dotted line here shows the anticipated rate of accrual that we thought we would get prior to starting the study based on our historic numbers. And then the solid line shows you our actual recruitment rate, which has been quite a bit slower. So if we'd met our anticipated recruitment rate, we would have already finished this study last year. But here we're still continuing, and we'll end recruitment later this year. Just a quick look at our patient population. So the vast majority of these patients are under 6 months of age, as you would expect for this group. The biggest group here is myelomeningocele, actually, both prenatal and postnatal repair. Remember, again, that we've excluded intraventricular hemorrhage of prematurity, which otherwise would have been a big group for us in North America. And then the next biggest group is aqueductal stenosis. So in summary, the role of ETV-CPC in the North American population, I think, is still being determined. Randomized trials are essential, but recruitment can be difficult. And even beyond that, RCTs of this size require patience. It takes a long time just to set them up, to get the funding for them, and requires patience once the study's going. And the resources that are needed, both in terms of finances and labor and amount of work, is tremendous to do this type of study at a high level. Thank you very much.
Thank you, Dr. Abhay. It was a nice presentation. Open to the audience.
Thank you, Abhay, for update on what's happening. Few questions actually in my mind. First of all, how do you decide these pre-pontine scarring? Is it easy to pick up on radiology? That's number one. Number two, the etiology in infective pathology, hemorrhagic pathology, the other conditions that you showed are going to be different. So how do you sort of equate them in terms of your success? Because, that's a very difficult, heterogeneous group of patients actually coming.
Very true, yeah. So both good points. The first one with respect to the prepontine scarring, I mean, we demand certain MR imaging sequences to screen the patients. And so I showed you some examples of the severe type of scarring that we look for. Those are excluded. That's also why these patients go through the equipoise panel. So it's not just one surgeon determining that. There's that panel that reviews it to say, no, that's a lot of scarring. You shouldn't do ETV-CPC. So that's how we try to account for that. But you're right, there still is some subjectivity to that. To your second question about the heterogeneity of the patient population, also a very good point. That's a concern of ours. That's part of the reason we excluded the IVH population, but it's still a heterogeneous population. This is where you count on randomization to try to balance between the two groups. So there will be a range of outcomes within both treatment arms, but with randomization, it is hoped that there'll be balance between the good and bad patients in each group.
Because my potential worry is that when you have an infection or a hemorrhage, the plasticity, the wall of the ventricle probably should change.
Yes.
I can't prove it, but that's always...
You may be right. And so there's a number of questions that will be answered by this study. Only one of them is comparing ETV versus shunt. The other thing is we're going to have a very good database and prospective data looking at things like DTI, looking at CSF biomarkers, looking at the cognitive outcome, looking at brain size, brain volume, all of this, and we can answer those types of questions for specific subgroups.
Thank you.
Sam.
By
Great talk as always. Thank you for giving us an update. Based on the results of the ESTA trial, do you see an opportunity to update the ETV success score used worldwide on a daily basis? It's reproducible, people trust it, all of us trust it. Do you see an opportunity to update it in regards to CPC, favorable anatomy, or maybe some etiology considerations like fetal surgical spondylosis? Thank you.
I think that's a very good point, and stay tuned for my talk tomorrow on that. I'll talk exactly about that topic, so we can discuss that further then.
Thank you. Thank you. Thank you. May I now invite the next speaker, Dr. Arthur Henrik, going to speak on choroid excess coagulation updates.
Okay. No. This one? Here or here? Here? Yes. I think so, yes. Esse é experimento.
So, good morning. It's for me something difficult to talk about plexuchoroid coagulation after magnificent presentation of Dr. Kulkarni. Thank you so much for the presentation before. Yeah? It's okay? Yeah, again. So, thank you, Dr. Bansal, for the invitation. It's a pleasure to be part of this important meeting. Hydrocephalus remains a significant challenge in neurosurgery. The incidence is approximately 0.5 to 1% for 1,000 live births. In our daily practice, this translates to 40 to 6% of admission to pediatric neurosurgery service. It's important to note that half of these admissions for treating complications arising from previous treatment. The ventriculoperitoneal shunt remains the most commonly used primary approach for treating hydrocephalus. While it is very effective, it has a revision rate of 1.5% to 3% per patient. Additionally, the rate of infectious complication can range from 0.5 to 35%. Shunt dysfunction occurs in 38 to 70% of cases, and approximately 10% of patients may experience subdural collection due to overdrainage. The long-term mortality associated with ventriculoperitoneal shunt range from 5 to 40%. Notably, around 70% of complications arise within the first 6 months of shunt implantation. Starting in 1990, advancement in technology led to the development of the endoscopic approach as an alternative to shunt procedures. Neuroendoscopy for the fenestration of the tubucinarium provides an internal pathway for cerebrospinal fluid flow. However, this technique has notable limitation. It tends to yield poor outcome for children under the age of 2, as well as in case of hydrocephalus associated with myelomeningocele and in situations involving hydrocephalus resulting from infection or ventricular hemorrhage. Despite this challenge, the endoscopic approach has been shown to result in 50% fewer complications and a significantly lower mortality rate compared to shunt implantation. Numerous published studies have aimed to establish prognosis parameters that play a crucial role in selecting suitable cases and enhancing decision-making and informed consent. A significant article by Kulkarni, published in 2016, has gained considerable attention in discussions surrounding endoscopic ventriculostomy. This extensive prospective multi-center study introduced a predictive table designed to assess the likelihood of ETV success, considering essential factors such as the patient's age, the underlying cause of hydrocephalus, and any previous shunt placement. However, it is vital to recognize that this table is sometimes misinterpreted as the only criterion for indicate or contraindicating ETV as a treatment for hydrocephalus. We emphasize that this predictive table can also provide valuable insight when assessing the chance of success for shunt implantation, further supporting comprehensive decision-making and patient care. Whether shunt or ETV is indicated, it is important to note that the majority of our patients are infants, with 46% of these cases associated with myelomeningocele. Even when considered older children, they often have a history of multiple revision and complication. Choroid plexus coagulation has a long history in the treatment of hydrocephalus. However, the initial outcome were disastrous, leading to the abandonment of the technique. In the 1970s, advanced endoscopic equipment brought CPC back into focus as an alternative treatment. Unfortunately, it was once again abandoned due to its low efficacy and numerous complications. Given the partial ineffectiveness of endoscopic ventriculostomy in patients under 2 years of age, as well as cases associated with infection, hemorrhage, and central nervous system malformation, the possibility of combining endoscopic CPC with ETV was reconsidered to help reduce cerebrospinal fluid production. In 2005, Benjamin Ward revived CPC using flexible endoscopy in combination with ETV based on his research conducted in Uganda. Choroid plexus coagulation has provoked much discussion regarding possible developmental consequences for children. In 2017 article, Kulkarni presented a study involving 100 infants, with 51 allocated to the ETV CPC group and 49 to the ventriculoperitoneal shunt group. Median cognitive score on the Bayley scale of infant development at 12 months showed no significant difference between the two treatment groups. Furthermore, there were no significant discrepancies in Bayley scale of infant development, motor or language assessment, treatment failure rate, or brain volume between ETV plus CPC group and the ventriculoperitoneal shunt group. However, Benjamin Ward's publications were the subject of significant criticism and doubt regarding choroid plexus coagulation. Not all neurosurgery departments around the world were able to replicate the same result observed in Uganda. There were questions about whether choroid plexus coagulation would only work in Africa. In an article published in 2023, World reviewed the medical records of 348 patients under 12 months of age who received initial treatment for hydrocephalus with endoscopic choroid plexus ventriculostomy and ventriculoperitoneal shunt placement at the Boston Children's Hospital between December 2008 and August 2021. He found results similar to those observed in Uganda. In the following slides, I intend to show some of our experience with ETV and ETV plus CPC. We have no experience with primary endoscopic approach in neonates and infants for the treatment of hydrocephalus associated with myelomeningocele. We perform endoscopic surgery only in patients with previous shunts that have returned due to shunt dysfunction or infection. Here we present a series of 13 patients with myelomeningocele who returned with the clinical and radiographic sign of shunt dysfunction. The shunts were removed and ETV plus CPC was performed with satisfactory result in 85% of cases. In one of, I show you one of our cases, a 15-year-old girl corrected myelomeningocele on the first day of life and VPS in the first week. Until then, she never needed a shunt revision. In the last outpatient control, he had persistent headache, and the radiographic study showed a shortening of the peritoneal catheter. An ETV was performed, and the VPS was successfully removed. I show it very quickly. We always use a Fogarty catheter to open the third ventricular floor. And in this case, it was not necessary to do the choroid plexus coagulation. So here we have another case, a 7-year-old female patient with myelomeningocele developed late hydrocephalus and had not undergone a previous shunt procedure. She underwent endoscopic third ventriculostomy with choroid plexus coagulation. And in this case, we used another model of bipolar. This patient was part of a cooperative multi-center study between Federal University of Pernambuco and an university in Denmark, which is conducted live choroid plexus analysis. During the choroid plexus coagulation procedure, we remove sample of the choroid plexus for initial analysis using electron microscope before sending them for further analysis. Coagulation was performed from below at the pedicule of the choroid plexus to preserve viable tissue for analysis, as you see here. So, we conduct a study involving 167 infants who underwent the surgery for hydrocephalus between January 2015 and December 2023. This included 66 who had endoscopic third ventriculostomy and 101 who underwent ETV plus CPC. The study focused on pediatric patients in the first year of life who were diagnosed with hydrocephalus. Patients with hydrocephalus associated with neoplasm were excluded from this study. And here we see that the technique that we used in this study. Third, the ventriculostomy. The choroid plexus coagulation of the right side. Then the septostomy. only in 24% of the case the septostomy was necessary, but because the most of case the patient had no septum, or the septum is fenestrate. And then here, the left side of the coagulation. Then to results, 94 patients were male, 109 were 6 months of age or older. Here you see the indication of the endoscopic approach. So the etiology of the hydrocephalus. The most of cases were shunt dysfunction, 20% because infection, and 24% no infection dysfunction. And the second more frequent cause was aqueduct stenosis. 66 ETV and 101 ETV plus CPC. 119 patients had no procedural-related complication. Treatment failure included recurrent hypertensive hydrocephalus in 16.46%, infection in 5%, cerebrospinal fluid leak in 3%, and the intraoperative hemorrhage in 1%. Oh, sorry, in 2%. In the overall result during the immediate postoperative period until hospital discharge, 138 patients, 84% were categorized as successful, and 16 were deemed failure of the procedure. After 6 months, the success rate decreased to 66, with 108 patients classified as successful, and the failure rate increased to 34%, involving 56%. We compare results across age groups. No significant difference were observed in case of ETV. However, unexpectedly, patients under 6 months of age exhibited better results in case of ETV plus CPC. Although there was no significant difference in the success rate between the techniques after 6 months, the results of this study of ETV and ETV CPC are above the values usually reported in the literature, which vary between 39 and 59%. Complication and failure of endoscopic third ventriculostomy or ETV combined with choroidoplex cauterization were more common in patients who had previously undergone shunt surgery compared to those treated primarily with this method. This study was published in Child Nervous System in February 2025. To conclusion, despite the failure rate associated with both procedures, the low morbidity and mortality make the viable option for treating hydrocephalus infants during their first year of life. Among the various causes of hydrocephalus cases related to aqueduct stenosis, particularly those without prior valve implantation, tend to respond more favorable to both techniques. Although the difference is not statistically significant, the overall outcome with endoscopic third ventriculostomy combined with choroidoplex cauterization appear to be better than those achieved with endoscopic third ventriculostomy alone. Here an invitation to the next ISPN meeting in Cairo in October this year. Thank you very much.
Thank you. The paper is open for discussion. 1 or 2 comments, please.
The question for you or the whole house, do we have any scientific evidence of how much is the CSF production or the CSF volume after we do the CPC? I mean, is there anything to sort of evaluate or monitor?
How is the CSF reduction after CPC?
How much is the volume and the production rate after CPC? Do you have any scientific evidence to that fact?
I don't know, really. Yes. Yes.
30% production
yes.
is still there.
Right? Is expected, but it's...
Hi, Arthur. What kind of endoscope do you use, the rigid one or the flexible for this coagulation of the coronal plexus?
Yes, we don't have flexible endoscope.
Mm-hmm.
We work only with a rigid endoscope. And in our experience, rigid endoscope, we can coagulate 85% of the choroid plex. Yeah, because you understand, we have a very big ventricle, yes, and even the temporal part of the choroid plexus is accessible with rigid endoscope. Yeah?
Do you think...
Of course, flexible endoscope is a very nice tool, but unfortunately we don't have because it's too expensive for us.
Thanks.
Dr. Sharad?
And another thing is important to say that this study is a retrospective study. So we start now a prospective study, randomized study, with all difficult that Professor Abaya cited before. So the adhesion of the parents is not so easy.
Very nice lecture. What is your opinion about cauterization of choroid plexus in the temporal horn? Because my idea was it's more riskier as the heat sink is more closer to the anterior choroidal artery.
Well, it's really a difficult point to say something, yes. But we have next a very nice conference from Professor Abaya, and perhaps he said something about this topic. Yeah.
Jayesh, last comment.
Sir, very interesting study. So, I think before 20 years, you were doing VP shunt for infant hydrocephalus. In last 2 decades, the ETV, if you compare ETV plus CPC with VP shunt, and let's take all long literature. So, the shunt, role of shunt in infant hydrocephalus is approximately 80% in outcome. In CPC, and only ETV it is around 60%. So what do you recommend now for infant hydrocephalus less than 1 year, after such a long experience? What will you do? Shunt, CPC with ETV or only ETV?
Yes, I think the more important point is the selection of the patients. Yes, this is in many cases the ventriculoperitoneal shunt is still the indication. Yeah, but if possible, we need to have in mind the criterion that Professor Kulkarni said before. Yeah, the study of the NMR. Yeah, if the etiology of the case, the age of the patient, and of course the parent's decision is also very important, because in this time, with internet information, with the pressure of the Dr. Google, many of the parents coming to us with an idea. Yeah, I want to endoscopic approach, or I want the shunt. This is difficult. Thank you.
Okay, I think we stop this here.
Thank you very much.
Yeah. The question remains same. Here my next speaker, but this time it's intrauterine pair, ETV versus ETV, and choroid plexus coagulation. Yeah, Samir Alvapa.
Good morning. Respected chairpersons, colleagues and friends, ladies and gentlemen, greatly honored to be here in Jaipur, the Pink City, and for the 3rd time. And this is becoming one of my favorite meetings of the year, the Neuroendoscopy Society of India. Congratulations putting together a great program. Special thanks to my good old friend, Professor Bansal, and his family and his team for putting together this wonderful team. Wonderful meeting here in Jaipur. Yesterday, the workshop was magnificent. After excellent talks on CPC from colleagues, and I know Professor Faroj will be also giving another one. Subud will be giving a great talk to follow. So I will skip the data on CPC, after hearing the experts talk about it, and focus more on ETV-CPC in patients who had fetal intrauterine repair for spina bifida. Spina bifida continues to be a problem worldwide. Here in India, depending on which parts of India, the incidence goes up to almost 6 to 8 cases per 1,000 pregnancies. Although significant effort is being done worldwide for prevention of spina bifida, this remains a global problem. And if we look here at the world map, we see that spina bifida remains an active problem worldwide. Huge potential, a huge effort is being done worldwide for the prevention of spina bifida through folic acid fortification. The question is, although our primary goal is prevention, what about the cases we're unable to prevent? What do we do about them? The standard of care worldwide is to perform the postnatal repair, as it's being done here in India on a daily basis. Question is, where are we going with the standard of care worldwide? And I'm careful to say the standard of care, because many things we do in neurosurgery and in medicine have changed over the last 20 years, like coiling of aneurysms and many other interventions we do. So things are changing in a rapid direction when it comes to treatment of spina bifida. Those babies are from my own practice. We still do postnatal repair, but at the same time, prenatal repair is picking up worldwide. Question today is, how about CPC and ETV? How do they fare with this patient population? One of the challenges in spina bifida is that we deal with the hindbrain herniation and the Chiari type 2 malformation, which can increase the risk of ETV failure. We all know that the higher the lesion, the higher the risk of shunt-dependent hydrocephalus. If we go back to the 1990s, ETV was considered controversial for patients with spina bifida, specifically due to the fourth ventricular outlet obstruction or the status of the Chiari malformation. If we look at this spina bifida case on the right, this is a good case for ETV. But how about this spina bifida case on the left? This is probably not a good case for ETV. If we look at the published data on ETV outcomes in the spina bifida population, this group in France talked about 70% success rate. If we look at the ETV success score by Professor Kulkarni and the group, showed that myelomeningocele can fare lower compared to other etiologies like aqueductal stenosis when we calculate the ETV success score. As Professor Kulkarni summarized beautifully, ETV-CPC has been around for a long time, specifically CPC side, but Professor Worf, the work he had done in Uganda and published a significant amount of scientific literature looking at the outcomes of ETV-CPC and then ETV-CPC in babies who had myelomeningocele. We find that at the beginning, there was some skepticism about it, but then North American studies have shown that ETV-CPC is likely here to stay, and hoping the ETV-CPC prospective randomized trial, comparing it to VP shunting through the ESTE trial, Abaya talked to us about, will give us the answer for the future. So I'm one of the people who started doing it with the rigid endoscope. Dr. Chandra, to answer your question, as we look into the temporal horns, what's the science telling us so far? Does it make a difference to use the flexible endoscope to maximize the CPC in the temporal horns? And again, after I started doing ETV-CPC with the rigid endoscope, I went to Uganda, started learning the flexible endoscopy. Why flexible endoscopy is to maximize the reach for safe maximal CPC, specifically for the areas in the temporal horns the rigid endoscope is unable to achieve. And if you look at the data comparing flexible and rigid endoscopy, you see that there are favorable outcomes seen with flexible endoscopy when it comes to what percentage we're able to achieve. In Uganda, many of us who went and trained there, we found that actually ETV-CPC works. Long-term data is proving that those babies and those children can have great outcomes long-term. The etiology in hydrocephalus in Uganda is different in sub-Saharan Africa, and probably in some parts of India the same, post-infectious hydrocephalus, but the setup is the same. Going in with a flexible endoscope and doing the ETV. I'll skip the videos since lots of videos have been shown already. After that, doing the choroidal plexus sclerization, there are two flexible endoscopes available, the digit and the fiber optic. And the ST trial, as we heard, hopefully we get the results in the next couple of years. Technique is the same in our practice. We do the babies all in the lateral position. And our focus now on the fetal surgery. As we all know, in the MOMS trial, published in 2011, looking at prenatal surgery for spina bifida, showing favorable outcomes with improved hindbrain herniation, reduced rates of shunted hydrocephalus, improved cognitive outcomes at the risk of maternal complications, specifically increased risk of prematurity. What is fetal surgery? Fetal surgery is taking care of both the mother and the baby, or the fetus, at the same time performing the prenatal repair after meeting criteria, very strict criteria under 26 weeks of gestation. Look at the results of the MOMS trial showed a significant reduction of the shunted hydrocephalus from 80 down to 40%. The rates were cut in half. Hindbrain herniation improved dramatically. Lower extremity motor function also improved significantly in the group that had fetal surgery at the risk of prematurity. 13% of the mothers who went through fetal surgery delivered under 30 weeks of gestation, adding the risk of prematurity to those babies. So the take-home message from the MOMS trial was that fetal surgery can reduce rates of shunting for the hydrocephalus, can improve the motor function in the lower extremities, can improve cognitive function at the risk of low risk of maternal complications. Follow-up data published looked at the severity of the fetal hydrocephalus prior to fetal surgery, showed that if the baby fetal ventricular megaly reached 15 millimeters, the risk of shunting was higher. So in St. Louis, immediately after the MOMS trial, we performed 60 cases. Now I'm in Orlando, Florida. We have performed 62 cases so far and over 10 cases internationally. We follow very strictly the inclusion and exclusion criteria of the MOMS trial. The mother is placed in lithotomy position. Cesarean section is done. Now you can see the uterus is explanted. We performed the surgery from A to Z with the maternal fetal medicine team. This is after the uterus was explanted. Then we do the hysterotomy together. This is a myelomeningocele case. Here's the tube replacing the amniotic fluid. Here are some of the more difficult cases, or the myeloschisis cases. We do all the repairs using multi-layered microneurosurgical technique, closing the spina bifida in 3 layers. For the sake of time, I'll skip the technique since we're focusing on the CPC side. But as we're getting more experience, the surgeries are becoming safer, as well as the hysterotomies are becoming smaller. And after the repair of the spina bifida, amniotic fluid is replaced, and uterus is closed, and the uterus is returned back to the abdominal cavity. By day 2 and day 3, we start seeing motor movement down to the knees and ankles, looking when compared to prenatal surgery exam. Most babies at birth, over 70% of them, the backs are fully healed. We do early functional assessments as soon as the babies are born. And when we do the surgery around 24, 25 weeks, we do a follow-up MRI around 32 weeks of gestation. And we can see here at 32 weeks, reversal of the hindbrain herniation on the fetal MRI, and the babies are born. And now after the babies are born, what do we do now? We monitor the ventricular size, we monitor the head circumference. Once the babies meet criteria for hydrocephalus treatment, what do we do now? Now the MOMS trial only looked at shunting, and as you know, ETV was considered controversial, as we talked earlier. Question is, if we look into ETV and ETV CPC, specifically in this patient population, what outcomes do we have so far? Like in this case, had a repair around 22 weeks of gestation. You can see here there's significant reversal of the abnormal anatomy at the floor or the third ventricle, allowing us to perform a very safe ETV. Here we can see liqueous membrane. You can see in babies who had fetus surgery, the anatomy of the floor third ventricle is truly improved and makes the ETV much safer. And we monitor them for a long time, not only cognitive testing, but also the patency of the ETV. You can see here different anomalies of the floor third ventricle after fetal surgery. We should all have low threshold for shunting, in those babies. Any alarming signs, we should go ahead and shunt them. And we published our data in Charles Nerve System in 2017, looking at our first 60 cases. Interestingly, when we looked at the risk factors for ETV failure in this group, they were very similar to actually what the other data showed, that if the fetal ventricular megaly prior to fetus surgery hit the severe mark, 15 millimeters or more, ETV failure was higher. As we discussed earlier, in the MOMS trial, the shunting rate was 40%. In St. Louis, shunting rate was down to 77%. Right now, our range is around 25 to 30%. And as Professor Kulkarni mentioned, there's randomization happening. So our shunting rate a touch higher, probably because we're randomizing some of those babies to shunting. And we hope to get the results in the next couple of years. Should we do ETV or ETV-CPC in every baby? The answer is no. We should look at the anatomy. In this case, I do believe we have a favorable anatomy for ETV after fetus surgery, but this baby failed to improve the hindbrain herniation, which means we should not try it. We should track our outcomes prospectively. This is a very high-risk business. We should be tracking the outcomes openly. All fetus surgery centers should have access to the data. All our data are entered into the North American Fetal Therapy Network. The technique is getting better and better. Our hysterotomies are getting smaller and smaller. We used to always do 10-centimeter hysterotomies. Now we're getting smaller and smaller, almost 4 centimeter. What is the future direction? Some colleagues like in Brazil, Sergio Cavaliero and others are looking at other fetus surgery options like for encephaloceles. Great philanthropic efforts are happening worldwide thanks to Professor Worf and NeuroKids. ETV-CPC now is being offered in many countries and giving access to care for babies who did not have it before. For any of you interested in flexoneuroendoscopy training, you're welcome in Orlando. We host an annual workshop. International collaborations are key to make this better. But at the end of the day, we should track the outcomes of those kids very, very well for a long time because of the risk of tethering. We're not going to talk about tethering today. So in conclusion, fetal surgery for spina bifida is gaining momentum worldwide after the MOMS trial. ETV and ETV-CPC are proven to be safe alternatives to VP shunting in this specific fetal myelomeningocele repair patient population. Factors to consider, the surgeon's experience, the age of the baby, the status of the hindbrain herniation reversal, and is it a favorable anatomy or not? All those matters should be considered. We should look at them seriously, and we should discuss them openly with the parents of the babies. And ETV Success Score, we look forward to learning tomorrow from Abaya what's coming. Thank you all. Appreciate it.
Thank you, Samar.
Thank you.
House is open for discussion and questions.
Fascinating, Samir.
Thank you.
In Brazil, they are doing the fetoscope for the procedure. What's your opinion on that?
Say it again.
In Brazil, they are using the fetoscope to do repair of intrauterine myelomeningocele. What's your opinion on that?
Excellent question. So open fetus surgery was the technique performed in the MOMS trial. So any program worldwide performing fetoscopy to repair intrauterine spina bifida are complemented, but this is considered experimental so far because there is no prospective randomized trial. Deep in my heart, I strongly believe this is the future to do it fetoscopically, but right now we do not have the dexterity or the robotic techniques available to perform meticulous repairs. We're seeing published and unpublished complications from fetoscopic repair, although again, deep in my heart, I believe it's the future. At our busy program, very busy center, experienced team, we're still not ready to adopt fetoscopy. I do believe we are getting close, though, in the next 2 to 5 years. Thank you.
Thank you.
Amber, fantastic talk. I just wanted to ask, what are your thoughts on the threshold for treatment of hydrocephalus in the myelomeningocele population in general, but particularly prenatal repair and discussions you have with families, and if there's differing thresholds and for other conditions?
Great question. Thank you, Abaya. So this is actually an evolving discussion that I'm changing the way I discuss or how I counsel the parents after the babies are born. I always tell parents nowadays come to us begging for ETV or ETV CPC. You know, they're brainwashed by the social media and saying, we don't want a shunt, we don't want a shunt. We did fetal surgery to avoid a shunt. And I always tell them, I'm going to twist your arm when it's the right time for the shunt. But if the baby shows up in my office, the head circumference reaching 90th percentile, perfectly clinically well, ventricles slowly improving, increasing, I tell the parents, strategically, maybe if we push the CSF divergent towards 4 to 6 months of age, it's better for your babies. All the published data have shown that over 4 months of age, we can get better outcomes, specifically in this patient population. So the counseling is evolving. As long as they clinically can wait, I try to push towards the 3 to 4 months of age. But again, with the randomization as the trial, this counseling is going in a different direction. We're meeting specific criteria. After the trial is over, I think it's going to be back to counseling, and I look forward to discuss it offline with you. Thank you.
Thank you, Dr. Samar. So we come to the last presentation of this session by Dr. Subodh Raju, choroid plexus fulguration, role of laser and flexible neuroendoscope as an adjunct. Dr. Subodh Raju.
Thank you, Dr. Bansal. Congratulations for a great meeting and the Jaipur team. So my topic will continue from where all the speakers have spoken already. So I'll not go into the introduction and the trials and these things. Yeah. So choroid plexus fulguration, I don't do it across the table. My indications are very, very selective for doing choroid plexus fulguration. So we started doing this choroid plexus by using this bipolar forceps initially. The stores, either the solid state or the bipart bipolar forceps, that is how we started doing choroid plexus coagulation. And we then had the flexible scope, but we used to use the flexible monopolar, these things. So what it used to do is the time consumed for choroid plexus coagulation in these cases used to be very long. And with the rigid scope, we were not able to access the temporal horn and the fourth ventricle. We should always remember that the fourth ventricle also has a huge amount of choroid plexus. So that's how we moved to this. This is my short experiences of choroid plexus coagulation, diversified across etiology, post-MMC repair, choroid plexus hyperplasia, post-infective where the peritoneum has completely gone, where we cannot do a shunt, ETV, elective ETV, CPC, then in cases where we have to do a redo ETV. And these are the cases, around 49 cases of choroid plexus fulguration we have done. So initially I thought it's a video presentation. My presentation is basically on videos. So this is basically a teaching where all we go to do the choroid plexus fulguration when we start. We do a septostomy where the septum is intact in these cases. And I'll run through 2 videos actually in these cases. This was a case of hydrocephalus infected, recovering with a peritoneum completely gone, repeated shunt malfunctions. So in these cases, we used to do this. So this is the thulium laser which we use actually, set around between 10 to 20 watts. And it works in both ways, contact and non-contact way. And it's a 0.45 mm fiber. And so areas which can be dealt with rigid scope, we do with the rigid scope. And where we cannot, as we come to the, this is near the third ventricle. And this is with the flexible scope. As we go into the temporal horn, the atrium here, and down up to the temporal horn, the CPC is done. So I'll show you one more videos on this. So this case is a classical case of large choroid plexus hyperplasia. So in this case, what is happening, we first shunt was done. What did the child land up with shunt? Massive ascites. We converted to an EVD. The daily output of CSF was 1.5 liters when you put an EVD. So in this case also, you can see the choroid plexus hyperplasia here. So here also we did a complete, so with the use of laser, what is happening and good irrigation, our processes are becoming very fast. I can do a bilateral CPC and everything in just around maybe 75 to 90 minutes. We can complete the whole procedure, both sides. So this is a flexible scope, and we go on. This child, ultimately we did do a VP shunt, but by the time when we placed the EVD, the CSF output, we did a third ventriculostomy. Nothing works here. So we had to put in a shunt. The output was come down to 150 to 200 ml actually. So maybe a 70 to 80% drop in the CSF, these things. So this is the representative case. A 27-year-old male presented with progressive distension of abdomen for past 5 years, with on and off admission to hospital. Childhood shunt was done for this patient. Every case of ascites was ruled out, except that CSF. Cirrhosis, portal hypertension, nephrotic syndrome, everything was evaluated and ruled out by gastrointestinal team. No evidence of any hepatic or systemic cause. So past history revealed VP shunt at the age of, at 1 year of age was done for ventriculomegaly with previous ascitic episodes and hydrocephalus. He remained asymptomatic for 20 years, and this is how he presented to us, with massive ascites. So in these cases, when we did an MRI, we could assess that there is some amount of choroid plexus hyperplasia here. Shunt is functioning, but malfunctioning because of the ascites. So in that case, we did a contrast CT also just to see the choroid plexus, amount of choroid plexus. And this is the video completely you can see. We had made a animated so people can understand the location. This is a point which has to be followed where we are going to the choroid plexus coagulation. You can see the choroid plexus hyperplasia here. So this is the solid state bipolar which we can use, but initial phase only. Then we switch on to the laser. This is the thulium laser, again same. So these, as this dot moves, you can know the location of where we are doing the choroid plexus coagulation. So this is just behind the foramen of Monro. There is the septum is already deficient. This is bilateral fornicis, the right foramen of Monro. As we go down to coagulate, we go to the opposite side. This has gone to the opposite side. You can see the dot here. Same thing. Big choroid plexus. There is a left thalamic vein here. We have gone to the opposite side. It's near here, near the atrium now. As we go down. So this is the flexible scope which has been taken in up. Till what we can see in the rigid scope has been done with the rigid scope. Now we have gone into the, this is the left atrium which we are going to. You can see the dot here. And we keep on coagulating this. You can see the bulk of the choroid plexus here, the bulky, heavy looking choroid plexus. This is the left hippocampus going into the temporal horn. There is a temporal horn here. You can see here the dot here and coagulating it there. So if you physically coagulate all the visible choroid plexus which is seen, estimately you are doing 70 to 80% of the work. There's still 20 to 30% left over, which is fine. In these cases, you require good amount of irrigation because the moment you coagulate, there is a huge amount of debris which is thrown off. This is the previous shunt which is there in the temporal horn. So this is the temporal horn, both sides. This is the shunt which is there. This is the right temporal horn which you are coming to after the left temporal horn. You can see a complete, the rigid scope is placed to see the complete choroid plexus fulguration. Then what we enter after doing this, both sides adequately, then we have entered this is the fourth ventricle choroid plexus, you can see here. The fourth ventricular choroid plexus, this is the foramen of Magendie, both sides choroid plexus. The fourth ventricle choroid plexus also looks hugely bulky. This is the obex opening of the fourth ventricle. So the fourth ventricle choroid plexus is also coagulated. Same, this is with the flexible scope only. Because there's a large communicating hydrocephalus, so this whole fourth ventricle choroid plexus has been coagulated. That's the aqueduct dilated, which naturally, because of the communicating hydrocephalus. So that's the end of this surgery. And this is the post-op CT brain, where you have left an external ventricular drain. And after that, we converted, because the patient still required a shunt in these cases. So what we did was a VA shunt. Because output is low, then we converted to a VA shunt. And this is the post-op CT abdomen. Everything is fine, the ascites is gone, patient is comfortable and doing well. Thank you very much.
Thank you, Dr. Subodh. Open for discussion.
Professor Subodh, excellent talk as always. Why did you coagulate the choroid plexus in the fourth ventricle? Does it make a difference?
So I believe that for the total CSF output, the fourth ventricle choroid plexus is also responsible. And if you look at them, they have hugely bulky choroid plexus in the fourth ventricle. So I told you, even if you do physically 100%, what is visible, still then you have done 70 to 80% only. It's not 100%. So I think to completeness, I think you should do that also, fourth ventricle choroid plexus.
Any more questions?
A high output VA shunt is not great. I'm telling 1.7 to 1.8 liters, 2 liters of fluid coming out. It's not a great idea. A lot of fluid overload on that.
Thank you, Dr. Subodh.
Thank you.
With this, we come to the end of this session. Thank you, organizers.
Thank you.
Thank you to our moderators and speakers for such an enlightening session.
That was truly a deep dive into the hydrocephalus.
And the only pressure we enjoyed today was intracranial pressure, purely academic, of course.
Thank you, sir. That was a very high scientific session. So now we start with a fun quiz idea that I say doctors but humans. So I wanted to ask some questions from you guys that is not related to medical line, right? So my first question was from sir, what do doctors Google the most secretly? That is not including medical line. Secretly, sir.
Secretly, what do they Google?
Acha, I'll give you some options. So you can, restaurant review, your own name, vacation ideas, and nearby hospitals for the new opportunities.
I don't know. I'll take a wild guess. Maybe their own name.
Your name. Congratulations. Okay.
I think vacations and holidays.
Vacations are not for you. Of course, you have an emergency call everywhere. Acha. Now the next question is, what is doctor's biggest fear during off days, on leaves? What is your biggest fears? Emergency calls, no Wi-Fi, no tea or coffee, or relatives asking for free advices?
I think that question should be to the audience. That question should be to the audience.
Okay, so for the audience. Your biggest fear is staying at home. So that can be a controversial question. Answer. Sorry. So what about you guys, sir? For you guys.
I think wife getting angry.
Okay. And now, you guys watch movies. Yes. So I have a dialogue. You have to tell us the movie. Okay. I'll tell you the dialogue. You have to tell the movie name. Okay. बड़े बड़े देशों में ऐसी छोटी छोटी बातें होती रहती है.
दिल वाले दुल्हनिया ले
दिल वाले दुल्हनिया ले जाएंगे. ओके. एंड पिक्चर अभी बाकी है मेरे दोस्त.
शाहरुख खान मूवी ओम शांति
ओम शांति ओम. ओके. सो एक रैपिड फायर है सर, आपके लिए है, फॉर यू. ओके. मैं कुछ क्वेश्चंस ऑप्शन दूंगा, 2 ऑप्शंस है. यू हैव टू चूज वन. टी और कॉफी?
कॉफी.
ओपीडी या ओटी?
ओटी.
ओटी. स्लीप या फिर नेटफ्लिक्स?
स्लीप.
सैलरी या लीव्स?
पार्डन?
सैलरी या लीव?
लीव.
ओके. नाउ एक डेंजरस है, पेशेंट या फैमिली?
ऑलवेज फैमिली.
ओके. ओके. थैंक यू सो मच सर. थैंक यू सो मच. So now we move to the next session, that is Master of Master Gland. And for that, I welcome the moderators for the session, Dr. Hemendra Bhartiya, Dr. Vinod Sharma, Dr. Raghavendra Singh Chaudhary, and Dr. Hemant Beniwal. So please give a round of applause for the doctors. So we have Dr. Hemendra Bhartiya, Dr. Vinod Sharma, Dr. Raghavendra Singh Chaudhary, and Dr. Hemant Beniwal.
So let us start with the session.
Yes.
Okay. Because we are already late, and so what we'll do, because I seem to be the only chairperson here, so then we will reduce the number of papers. As I am the only chairperson, I will reduce it to 2 papers. Then we'll have the presidential oration so that can be done on time. And then we'll continue with the session so other chairpersons can get a chance. So let's start, and let me call.
Okay, thank you.
Yes, the first speaker, Dr. Ashish Suri, my friend, who would be talking on pituitary adenomas, surgical nuances, and pearls. And Dr. Ashish has tremendous work on pituitary, not only here, but in the lab also. He has been organizing some. So, Dr. Ashish Suri.
I thank the society and the organizing committee for the invitation. Thank you, chairpersons, my friends. We'll be talking about pituitary tumors. And we know the approaches are endonasal, microscopic, endoscopic, transcranial, conventional, or skull base. And this has been my personal journey. So whatever I'll be talking, it's a mix of everything. So I'm nearly close to 200 microscopic, both sublabial and paraseptal. And then nearly 500 now. This is 1.5 years old data, and of endoscopy. My number in transcranial also has increased because of the transcavernous So because that's the reason. So, but we found over time, I found on my personal experience that the vision in endoscopy where the microscopic ends, you can see the videos of 2008 and 2018, the vision begins in endoscopy. Why this happened mainly is because we started chasing invasive adenomas, which are responsible for 2/3 of giant adenomas, 1/3 of acromegalyx, and cavernous sinus cytoreduction. Do we have a pointer here? Cavernous sinus cytoreduction is important because once you reduce that cavernous sinus tumor, then you can give gamma knife radiosurgery better for the residual tumor. And thank you so much, sir. Thank you. Pointer hai? Not working. And for non-functional, these are functional adenomas and okay. This has been my policy. If it is between the 4 blue lines, it is standard endonasal endoscopic approach. It is beyond the 4 blue lines, subfrontal and cavernous NOS4, it is extended approach. Anything beyond that, that is subarachnoid extension, never endoscopy. So in this endoscopy meeting, never endoscopy for this. But we have to understand that there's biology of tumors also. These are tumors, despite whatever you do, microscope, endoscope, they'll still recur. They'll have higher rates of giant invasiveness, non-remission, post-op residuals, progression, recurrence, mortality. They are very humbling tumors. They are the new high-risk pitnet tumors. They're no longer pituitary adenomas, sparsely granulated somatotrope adenomas, lactotrope adenomas in men, Crookes cell corticotrope adenomas, silent corticotrope adenomas, and the PIT1 pluripotent adenomas. The standard approach, spine, we will see a lot of videos on that, infraumbilical incision for the fat. For the micro, macro, and the giant non-invasive, in the straight line of the endoscope, all these approaches are the same. Uninostril, binostril endoscopy, microscopic sublabial, paraseptal, they're all the same. I now do binostril, forehand approach. This is our result for our paper on Cushing's disease. We found that endoscopy had a much higher remission than microscopic, 88% versus 56%. And significant predictors of remission were endoscopic TNTS, day 1 morning cortisol, and ACTH levels. Our last publication, again on Cushing adenomas, the predominantly microadenomas, we found in 167 patients with 174 surgeries that adult patients did much better than pediatric. Primary surgeries, then the redo. Endoscopic TNTS is much better than microscopic. POD1, plasma cortisol and ACTH levels, and histopathological evidence of an adenoma and low IRS level of NR4A1 is higher remission rate of patients. We also studied MR negative Cushing's disease. This was last publication. We found that if you have an MR negative and still there's a high suspicion of central Cushing's, it's important to have an IPSS followed by a DOTA PET, a 3 Tesla perfusion MRI, and next you must explore the pituitary gland, go for the lateral cella, go for the cavernous sinus and the stalk. And we found this, that if you see this, we found the tumor in the upper end of the stalk here, the lower end of the stalk here, and the junction of the stalk and the diaphragma there. You see that? So this is not inside the pituitary gland, but it was beyond the pituitary gland in the stalk. Standard ETS for a macroadenoma central approach. I'll scroll these videos for the sake of time. Usually if the cella is large, make a ring of this bone, we can replace it back. Open the dura 5 o'clock to 7 o'clock. Take out the tumor which is posterior first, then the lateral, then the anterior. Watch the arachnoid bulge coming down. This was very frustrating when I used to do the microscopic approach, because then I didn't know what to do. And now with endoscopy, you can put a cotton patty, push this arachnoid back into the suprasellar cistern, also puncture this arachnoid sometimes and let the CSF flow. Rajesh also does it many times, and then this gives a better exposure, especially on the top of the tumors. This is, if you see this is in which the pituitary gland has been actually pushed, sorry. Oops. Yeah, the pituitary gland is pushed down, and very infrequent, and we're opening this, and then come up into the suprasellar cistern and deliver the tumor along with the arachnoid. I've done 2 or 3 such cases. Most of the time, the pituitary gland is pushed back or above. And then here you have to be careful because the arachnoid is coming along with the tumor. And there's no way you can make it go from below because the pituitary gland is there. And then you can see the gland down, and that we cut some more dura. And we can see the pituitary stalk. And that's the stalk, the last bit of tumor there. And that's the stalk, and that is the pituitary gland normal. That is the tumor. And these are difficult tumors. These are T2 hypointense tumors, and they have to be very carefully dissected with flat dissectors from the arachnoid. No pulling of the tumors from the arachnoid. These are very fibrous tumors. And if you want to remove them from the arachnoid, put a cotton patty on the arachnoid and then dissect the tumor from the arachnoid like that. So you have a complete excision. Anything beyond that, you will be avulsing the perforators. What about NOS3A? NOS3A does not require an extended approach. Standard endonasal approach, you need just a 30 and a 45-degree scope to watch between the 2 carotids there. 3B is slightly more difficult. Again, you don't need extended approach, but you need to drill down here because that is a blind area. You should not use any curette there because the inferior hypophyseal artery is there. What about extended approaches? This is maximally invasive. Do a middle turbinectomy or nasoseptal flap. Much more removal of the skull base. A nasoseptal flap has to be harvested. The dural opening is no longer a smiley 3 o'clock, 5 o'clock. It is an inverted T. You go above till the anterior intercavernous sinus like that. This is the normal incision, and you go up. Again, you go up beyond towards the optic nerves. Skull base repair is nearly 4-layer. First, you put a fat up there, and then Haddad flap or the nasoseptal flap. Again, some more fat there. This was a senior cardiologist from the NCR Delhi, and he has a subfrontal extension. We drilled the tuberculum sellae, and that's a 5 o'clock, 3 o'clock incision. We extended like an inverted T above. That's the sellar tumor coming out, and decompress the sellar component. Again, posterior first, lateral, and then we go for the anterior intercavernous sinus. We coagulate and divide it. Make an inverted T. Here an H is not required because it's not a meningioma or a craniopharyngioma. It's a small subfrontal extension. You can deliver that along with this. Look at the optic chiasm, the pituitary stalk. Complete excision was achieved. And look at the carotids and hemostasis, and that is the repair. First, a fat plug so that your Haddad flap doesn't go in the CSF space, and then an inlay repair of the fascia, then the nasoseptal flap, then some more fat, and then some buttressing there. Last subfrontal extensions, standard approach. You remove the subtuberculum cell as well. What about NOS4? Unilateral. Drill the sellar fourth floor beyond the carotid. I'll have to scroll it fast because of time. Take off the sellar, the lateral portion, then go lateral to the carotid, like we showed yesterday in the cadaver lab. And that is the important area. That is the anterior notch, close to the MOCR. And that's the lateral cut beyond the carotid. And no curette there. Once you're lateral to carotid, the perforators are there. Whatever you can take out, you take out. And NOS4, again, you lateral. Bilateral NOS4s are much more difficult. I've done 3 of such cases, very maximally invasive. There's no other way to do it. You have to do a bilateral turbinectomy. You have to do nasoseptal flap. You still may require a transcranial approach. So you drill under both the cavernous sinuses, sellar, suprasellar decompression. Then we go to the cavernous sinus on the left side, under navigation, under Doppler. Sorry for the video because there's less time left. And then the carotids cannot be left bare, they have to be covered. These are the bilateral. We've operated the tallest lady in the world. with whatever instruments we had. Multi-compartmental, these are very challenging tumors. Here, no role of endoscope. Please do not use endoscope in this. These are typical GOEL 3-4 and NOS4. They are beyond NOS4, subarachnoid extension. These are contraindication for any endoscopy. So you open the cavernous sinus, you can go lateral to it. All the compression has to be under vision. Cannot be a blind curettage because the perforators are there. You have to have control over the IC all the time. That is cavernous sinus exposure. There can be unilateral, bilaterally invasive, multi-compartmental. Recurrent ones, especially, these are the ones, again, no endoscopy. That is the cavernous sinus component being taken off, like we showed last time. And that is the suprasellar one. We do an intradural plus an intradural, extradural, both compartments, and that is the one which is taken off. There is no way that the endoscope can remove both the components, especially with the fibrous, and these are post-Gaiman knife functional adenomas. Again, this is the superior wall of the cavernous sinus. As you can see, that's the cavernous sinus component being taken off, and then intradural over the third nerve. That is oculomotor trigone opened, and that has to be taken off. My friend Goto is the only one who tries it with endoscope, but I still feel it is not the right approach because there's too much of handling with endoscope on the third nerve, and you can see the third nerve, that's the third nerve. So these are absolute contraindications for an endoscope. Giant invasive adenomas, better extent of excision with endoscopy, poor extent of resection with retrocellular, subfrontal, cavernous sinus, and if the MRI T2 hypointensity is there. We already talked about the Cushing's and the MR negative. And for the giant adenomas, endoscopy is better. Subfrontal endoscopy, extended endoscopy is better. Poor extent of resection already mentioned. This is what my take-home message is. If you have a NOS 3A, a 3B, GOEL 1, standard endonasal endoscopy approach, you don't need an extended approach. You don't need Haddad flap. If you have a small T2 hyperintense, GOEL 2, plus a subfrontal extension, plus an MR negative approach, you must do an extended endonasal skull base for the pituitary stalk, for the suprasellar, and for the lateral. But if you have a NOS4, large T2 hypointense, GOEL 3-4, never do an endoscopy. An anterior transcavernous plus a suprasellar towards the opticocarotid oculomotor trigone is important. Thank you.
Thank you, Dr. Ashish. It was such a wonderful presentation that it has left no room for any question.
Thank you, sir.
So,
but
I feel it was very clear.
Dr. Suresh,
the message was...
Ashish, very good presentation indeed. Just one very small, brief question is that, do you do combined, transcranial, transnasal approach in any one of these pituitary adenomas?
Sir, it's a very good question. I learned it from Andre Grottenhuis, I'll be very frank with you. And I did it in 2 cases. Both I landed up with meningitis. So, and I've stopped doing it. I do stage, but then I do it after a while, but not in the same, not a shake hand approach.
But does this approach give any advantage over the conventional approaches?
No, not now, because since I'm using both are extended. The endonasal is extended, and the transcavernous is also extended from the transcranial route. So I think it is a good thing.
Thanks.
Thank you. After we can have Ashish.
I need to add one thing. If you're doing a stage procedure just for the juniors, don't remove half of the tumor, you'll end up in another pituitary apoplexy and the patient will deteriorate. So that's lessons hard learned, So if you're doing staged, see that you have removed maximum of it.
Always when it's a giant tumor, it should be the first case in the morning.
Yes.
It should be the maximum excision, and you should plan it, and navigation really helps in that. Navigation doesn't help in the transcranial, but transcavernous and the endonasal really helps.
If you leave a big chunk, then the very night...
You'll come back at night with an M1 patient.
You'll get a call, the patient M1.
Thank you.
Thank you,
sir.
Dr. Ashish, for wonderful presentation. Next speaker is Wosapu Amano, current endoscopic transspheroidal surgery for pituitary tumors.
Okay, thank you, Chairman. Okay. So everyone know the historical background of TSS. Now is era of the endoscopy. So everyone know panoramic view is advantage of TSS, and furthermore, another advantage. So I converted to the from a microscope and the endoscope in my career of TSS. And so for 1,500 pituitary region surgeries I experienced, and I made so many innovations. What is needed for the advancement of TSS? Technique for overcoming movement restriction, and surgical innovation in instrument and technique. So we developed these instruments for tumor removal. These are all flexible or malleable or bending. And this is my revolution, HD endoscope 2011 we introduced. It has 7 times higher pixel than conventional type. Microscope cannot detect RBC, but the HD endoscope can detect the cluster of RBC flow. Since medical student, this is for the first time to see the RBC. So it changed my philosophy to the TSS, changed to the converted to the HD endoscope TSS. So it can get the close-up view. If we insert the endoscope to the suprasellar region, we can get such excellent pictures during surgeries. So I showed a representative case, pituitary adenoma. There was 2 adenoma, non-functioning and functioning. And these surgical indication is different. Non-functioning is a visual impairment, and functioning is a hormonal excess. So the purpose of surgery is different. So the way of surgery is different. We must think they are different tumors. How much tumor should we remove? Non-functioning to improve visual impairment, 50% enough, but to prevent postoperative intratumor hemorrhage, we must remove more than 90%. However, to prevent further hormonal dysfunction, we must remove less than 99%. On the other hand, functioning adenoma, we must remove 100 to 101%. So to remove totally in functioning adenoma, we should remove tumor shoot capsule and the tumor in the cavernous sinus. This is the CNOS 4 GH-omer. After removal of the main bulk, and we change to this is a 70 degrees endoscopic view, and using an angled instrument to remove the tumor. And under controlling venous bleeding, tumor far lateral side, and now the posterior part of the ICA was removed. And the shoot capsule was removed, and totally removed. Next case is CNOSP 0 or 1, but more difficult than previous case, because we must open the medial wall of cavernous sinus. It can detect in a close-up view. So open the cavernous sinus wall. Of course, there is so much venous bleeding, but controlling the So at the end of surgery, should the capsule become sick and become red, it means revascularized. After the surgery, his pituitary dysfunction improved. And after such techniques I use, deteriorated rate significantly reduced like this. But after the HD endoscope, of course, it's reduced, but not so far significantly. So think this case, no visual disturbance. 20 years ago, no surgical indication. But I recommend him the surgery, and after the surgery, his all pituitary dysfunction improved within a normal range. Rotic cleft cyst, this surgical indication. I recommend irrigation inside of the cyst and partial removal of the membrane. And I change the open side that depend on the location of the pituitary gland. And this is a 30 years old woman, rotic cleft cyst. Remove the cyst content. It causes the inflammation change, so we have to remove it totally. And inside the endoscope, inside of the cyst cavity, and irrigated using warm saline, 40 to the 55 degrees, and irrigated repeatedly. In this case, more than 1 liter saline we used. And after that, cyst membrane was removed partially for the pathological finding. And it looks recur, so the I suit the membrane to the dura to prevent the expand again. And next case is at the former hospital, 3 times open surgery that recurred. So I recommend TSS. This case, we need a multiple opening and the removal of the cyst membrane so that we make a flow of the CSF. So that open the membrane posteriorly and anteriorly and superiorly, and using such a bending ring curette or something a malleable instrument. And 5 years, no recurrence. And I think rotic cleft cyst inflammatory change is a very big factor, important factor to recur. So I show the paper inflammation change. Before that, we must do the surgeries. Craniopharyngioma, everybody knows the benign tumor, but it is difficult to remove totally without complications. So we need a multimodality therapy, surgery approach, monitoring if we need, and radiation therapy. Recently, we often use a Zapex, it's excellent, and we depend on the endocrinologist. And 20 years ago, we choose the TSS or open location of the chiasma. So this is a 15 years ago operation after the main bulk removed. Endoscope inside beer running tiles and 70 degrees endoscopic view and remove the tumor. But it took 8 hours, 10 hours operation. However, everybody knows craniopharyngioma originated from a stroke, so TSS is the ideal approach to the craniopharyngioma. So this is a 23 years old woman, a tumor between the chiasma and the normal gland was removed and dissected meticulously and from the surrounding structures and removed.
anomalies, vascular surgery, minimally invasive surgery, with several patents and several research articles to his name, and several firsts and several innovations to his name in these particular fields. His passion has been primarily in epilepsy surgery, and along with his wife, Professor Manjari Tripathi, who heads the Department of Neurology at the prestigious All India Institute of Medical Sciences, New Delhi, he developed a state-of-the-art epilepsy surgery program over there. He is par excellence microneurosurgeon and endoscopic neurosurgeon. With research, he has published more than 550 papers, including very high-impact journals like New England Journal of Medicine, Nature, Genomics, JNS, Neurosurgery, and mind you, the impact factor of some of these journals is more than 40. He has reported more than 20,000 citations for his works in various national and international journals. He has over 14 patents to his name, and he has completed or doing 17 extramural research project grants from the institute. I just came across his Google Scholar citations, and you can see he has an H index of 33. He has several papers with very, very high citations, which have modified and produced a gross impact in the advancements in the field of neurosurgery in various spectrums. These are some of his seminal publications, as you can see, in New England Journal of Medicine. In the concept, innovation, and techniques, he has really entrusted and promulgated the advancement of neurosurgical techniques through his wisdom and knowledge. Going further into research, he has a deep interest, and he has his own research lab with its own staff researchers, fellows, including PhDs from the country and abroad. His area of interest include neuron connectomics, GABA and NMDA receptors, microcellular neural connectivity, and genomics. Here is a glimpse of the Center of Excellence for Epilepsy, his brainchild. He has received a thoroughly generous grant for development of this, and we can see Honorable Health Minister of then, Dr. Harshvardhan, inaugurating his wonderful facility lately. He has a MEC facility, which is the only facility in the country at NBRC. He has been training at the P and Tendon Epilepsy Neurobiology Lab and has mentored and developed several programs in this Center of Excellence of his. Positions held in various societies. You can see a busy list over there, which are worth mentioning. He is the President of India Epilepsy Society, past President of Asian Epilepsy Surgery Congress, past Secretary of the General AESC, Chair of the Epilepsy Surgery Program. So no office in the epilepsy surgery which deals with the epilepsy surgery program is the one which does not carry his name over there. He has been the past editor of Neurology India, and I, as a part of NSI, can vouch for that he has taken Neurology India to great heights during his tenure while he was in charge of the Neurology India. Among the various awards, the list fell short. He has got a Pfizer Best Graduate Gold Medal in MBBS. He has Tudor Award for the ILAE, and he has AOEC Outstanding Life Achievement Award and various numerous awards, as you can read in this exhaustive list. He has numerous lectures and orations to his name and very well-known faculty in several international and national conferences. He has delivered more than 300 lectures nationwide and worldwide. He mentored the development of epilepsy surgery programs, not only in India, but also globally, going into several places and spreading the education regarding epilepsy surgery. And we can see, I was once visiting this institute at Surabaya, Department of Neurosurgery, and I was taken aghast and surprised and happier to see his photo among the mentors at the Department of Neurosurgery at Surabaya. He happens to be an adjunct professor at various institutes and the Department of Neurosurgery in India and abroad. These are some of the photographs with Professor B.S. Das and Madam Sarla Das, with Professor Majid Sami and numerous other renowned global leaders in neurosurgery. He has a very, very busy schedule which he intermixes with his surgical career and his surgical commitments, and he has a great passion to teach and to perform the surgeries beautifully. You can see him spending time with various renowned global leaders in neurosurgery. And here is the AIMS faculty, and we are so blessed to have him as one of the mentors and one of the leaders in neurosurgery, presently heading the Department of Neurosurgery at the prestigious institute of the country. He has been as a visiting professor to various countries, and not to mention, he is a pure vegetarian. And on his invited lectures to various Southeast Asian countries and abroad, they keep aside a special vegetarian food especially made for him. This is one of the photographs which he shared with me when he was at SMS Jaipur, the same city where he is delivering the presidential oration now, where he was for Professor Dharkar oration for epilepsy surgery. And here it comes, the Department of Neurosurgery, which he heads currently. It is another jewel in the crown of his. Now this introduction would have been incomplete if I don't mention about the wonderful contribution, the lady behind the man and the family behind the man. Madam, who heads the Department of Neurology, Professor Manjari Tripathi, is herself an accomplished researcher, an accomplished clinician. And not only this, I think it runs in the genes. In the family, their daughter, Dr. Prarthana, has completed her core psychiatry training at Oxford, UK. Now, she has been happily married to Krishna recently. His mother stays in Gopalpur on sea, which is a beautiful seaside village full of nature and scenic beauty. Unfortunately, he lost his father 3 years ago, but his mother, Dr. P.S. Devi, who is a reputed pediatrician, also now does free service and takes care of vaccination for 60 tribal villages in Odisha, which is a commendable job at this age she is carrying out with enormous sincerity. So Professor Dr. Sharat P. Chandra, who is known for his dedication, humility, honesty, righteousness, surgical craftsmanship, and innovation, and I have been blessed to observe him, to imbibe from him, to learn from him, in fact, attempting to learn from him whatever traits he has got. And this is one of my photographs way back about 10 years or maybe 12 years back in our institute's cadaver lab. And this is the other photograph we took yesterday at the cadaver lab at the workshop. Ladies and gentlemen, may I now welcome Professor Sharat Chandra and invite him to deliver the prestigious presidential oration of the 12th Annual Conference of Neuroendoscopy Society of India. Professor Sharat Chandra, please. Sir.
While they put up the laptop, thank you so much, Sumit, for that detailed, exhaustive introduction. I really don't know if I deserved it, but I was a shade worried that you're cutting into my oration time. I hope the chairpersons will be lenient enough to grant me that few extra minutes. And I hope the delegates will be patient enough to hold themselves between my oration and their lunch. So when I started preparing for this oration, which I did very late because there were so many things to be done, so I didn't have much time, but then I was able to pull up some slides. And I started thinking, what should I speak upon? Should I just go on showing what cases I did and then show on pre-op and post-op images and some videos? Or should I try to kind of convey some kind of a philosophical meaning? Because normally when people become presidents, I used to think it's a very big thing, but now I am on this side. I feel in a way people are telling you that, buddy, I think you're getting older, you should need to move ahead. So I thought maybe I should try to speak something. 1 minute. Isko. इसको प्रेजेंटर व्यू में डाल दीजिए. Yeah, thank you. At the outset, I would like to acknowledge my teachers here. I'm so happy Professor Sharma is here. I really respect him. Distinguished delegates, my dearest friends, colleagues from abroad. I would like to thank the Neuroendoscopic Society for giving me this opportunity to lead the society and deliver this oration for this year. The background for this topic is that we often believe that our greatest challenges in surgery are external, complex anatomy as has been shown earlier, limited access, unpredictable pathology. But what if the real barriers are internal? What if they lie in how we think, how we decide, and sometimes fail to question our own thinking? So putting that all together, I thought the word metacognition gives a proper meaning because it allows us to give the ability to see those barriers and break them. As is customary in most oration, it's important to acknowledge and express the gratitude of those on whose shoulders I stand upon. In my case, I may say that I have not only stood upon many shoulders, but I've also been lifted up by countless individuals along the way. I remain deeply grateful to all my teachers, my seniors, my colleagues, my friends, my students, and everybody who has helped me in this journey. Due to constraints of time, I can only mention a few. I would like to begin by expressing my deepest gratitude to our teachers of teachers, the founders of our department, Professor P.N. Tandon and Professor A.K. Banerjee, on whose I would also like to acknowledge my mentors under whom I had the privilege to work. Unfortunately, not as residents, but definitely as a junior faculty. And I was very grateful for that opportunity. Professor V.S. Mehta for his remarkable sharpness and extraordinary ability to grasp and concepts with clarity, qualities that strongly resonate with today's oration. Professor B.S. Sharma, very different in style, but yet equally brilliant and deeply insightful, grounded firmly in his concepts, again reflecting the essence of what I will be discussing today. My acknowledgements would not be complete without remembering the teacher who inducted me into neurosurgery, Professor B.S. Das, the late Professor B.S. Das, a brilliant surgeon, inspiring teacher, and above all, a very noble human being. Among his many sayings, one sentence stands out. And whenever people would go and ask him, what is your career advice, he would say, why don't you start being a good human being? That is the best career advice, and there is very little competition in that. In a world increasingly troubled by conflict and division, I believe this wisdom holds even greater relevance for all of us today. I'm forever indebted to my parents, my father unfortunately not there, and my mother. My wife, who's a highly accomplished neurologist herself, has been a pillar to our home, and together we've been able to raise our daughter with care and balance. Often we were worried that if both of us are so busy, who's going to take care of her? But then I'm really grateful that she has grown up well. And when I reflect upon this, I truly feel that none of this would have been possible without a sense of divine grace guiding us along the way. In neurosurgery, we spend years perfecting our hands, our techniques, our precision, our speed. But there are moments in the operating room when everything is technically correct, and yet something doesn't feel right. In those moments, the most important tool is not the instrument in our hands, but the awareness in our mind. We often believe that better outcomes come from better skills or better knowledge. But increasingly, we are realizing that outcomes are equally shaped by how we think, how we interpret information, how we handle uncertainty, how we respond under pressure. Every neurosurgeon in this room knows how to operate. But not every neurosurgeon knows how they're thinking while they operate. And the difference, subtle, invisible, yet profound, can determine the outcomes. Today I want to talk about that invisible layer, which is called as metacognition. And simply put, it states this: it's the ability to step back and observe our own thinking, even in the middle of crisis and action. what prevents metacognition generally? There is something inherently comforting about staying within our own comfort zone, and there is nothing wrong with that, especially on the surface. But the deeper human psychology tells a different story. The famous split brain experiments by the Nobel laureate Roger Sperry demonstrated this beautifully. In a patient who underwent a corpus callosotomy, when different images were shown to each half of the brain, a snowy landscape, for instance, on the right hemisphere and the chicken claw on the left side, and the patients were asked to explain how they could see both, and they created a fictitious story, which is the chicken claw goes with the chicken when you need to shovel the snow. This was obviously completely confabulated, but they were unaware that they were confabulating this, and this gave rise to the concept of the narrative self from the psychologists. And this narrative self is nothing but a bundle of fictitious stories which we believe them to be true. And because of these stories, we end up thinking that this is enough, it's not possible to do more, or one should be content with what one has. But often these are not truths. These are simply stories we have learned to believe. And these are the very stories that prevent metacognition from happening. We become accustomed to them, even attached to them. And in doing so, we lose the space to grow and evolve. So metacognition does precisely the opposite. It creates that space, a space to question, to step back, and to see our thinking clearly. And in that space lies the possibility of true growth. So metacognition is driven by essentially three forces: focus, awareness, and innovation. Focus allows us to direct our attention to what truly matters in middle of complexity, crisis, so many things going on. Awareness enables us to observe our own thinking, to what truly matters in terms of bias, adapting to real life. And innovation emerges from this clarity, allowing us to move beyond the routine patterns and discover many ways of solving problems. Together, these drivers transform not just how we act, but how we think we act. So my introduction to neuroendoscopy began in December 1998. Of course, this is not the photograph from that time. So Henry had a lot more hair, which was black, and I had a mustache, but I couldn't find those photographs. And it was just a few months that our department procured the neuroendoscopic equipment, and Professor Mehta, our head, then insisted I should leave in December itself. And I must admit I was apprehensive, not because this was my first trip abroad, but also because of the legendary German winter. So I flew from Delhi to Berlin, and we took a train to Greifswald. And when I finally stepped out of the snow, I sank straight into half a foot of snow. My wife had thoughtfully packed in a very large suitcase, which she bought from Sarojini Nagar, full of woolens. But the moment I stepped out, the suitcase handle broke and the whole thing, just sank into the snow. I looked for help, but there was no one. And unlike railway stations in India, it was looking like a ghost town. Somehow with great difficulty, I managed to get out of the platform and eventually found a taxi to get to the guest house. The guest house was comfortable, but again, there was nobody there. And the evening when I came for dinner, I found an elderly lady who was speaking broken English. And when I started talking to her, she told me something remarkable. The temperature in Greifswald was -10. So she said that she comes to Greifswald to escape winter because she comes from a place in Russia where it is -50 degrees. So I just said, God bless you. And I'm grateful that I'm not in a place which is -40 degrees. The next day I went to the department, I met Professor Gabb, Henry, and both were extremely warm and welcoming. I remain very grateful to Henry because he took a lot of pains to take me around. And at that time when I went to his home, I could see little Lota. She was born just then. And my period over there, I didn't see many surgeries. But what struck me during my time is something deeper. They did not have a large volume of patients, but for every single patient, there was intense thinking, careful analysis, and thoughtful discussion. It was not about doing more. It was about thinking better. And that perhaps was my real introduction to metacognition. The discipline of stepping back, analyzing our own thought processes and refining them. And that experience strengthened my understanding in neurosurgery. Understanding that excellence is not just in what we do, but how deeply we think about what we do. At that time, of course, both Professor Gabb and Henry never visited India, and I found it very difficult to explain them that I come from an institute which does 1,000+ surgeries a day and sees about 15,000 patients in the OPD. But obviously, when they started visiting India, they understood. And this was a picture which I took in 1998, the endoscopic equipment which I had at that time. We had a holder, it was not too good, but it did the job. And over the next few years, I performed high volume of all these procedures, the routine procedures. And then I soon understood the limitations of endoscopy, that mostly you could do an underwater endoscopy. Multi-port endoscopy is usually not possible. There's a limited control for bleeding. And then I came across this case, which I would like to illustrate. It goes back nearly 2 decades. I was faced with a giant colloid cyst. At that time, I was understandingly hesitant to attempt a pure endoscopic procedure. So instead of a burr, I did a small craniotomy and did a dry endoscope, which obviously is done by many surgeons nowadays, but at that time it was a new way for me. And in many ways, this was my first practical lesson in metacognition, not just performing a procedure, but observing how I arrived to that decision. And it created a road for me to attempt removing larger intraventricular tumors, and also to go for pure endoscopy to endoscopic assistance. Gave me new ideas for applications, and also gave me some kind of an idea whether I could do some kind of a multi-port systems. So these are the images generated from AI. So you can see they're not completely correct, but the idea was to, convey the meaning. And then I came across this tumor. It's a giant pituitary, and this tumor was extremely firm. And when I was dissecting the cavernous part, there was a gush of bleeding. We couldn't do much. We just packed. Even after packing, it was bleeding. The patient was shifted to the intervention. Unfortunately, we have a good team, and they immediately did a stenting. But the story does not end here. The moment raised several questions in my mind. Could I have anticipated this better? Was there something that I missed? Was I influenced by overconfidence? And so on. And these were the questions which came up. Could I have left that cavernous part? Could I have just given a gamma knife for that cavernous part? Was I influenced by seeing so-called success videos in conferences or reading some papers? Was I more concerned about showing my peers that I could remove the tumor completely, or was I really concerned about patients' welfare? The process of analysis of all these factors without bias overriding them forms the basic science of metacognition. Now, metacognition is powered by focus, awareness, and innovation. Focus sharpens attention, awareness reveals our thinking, and innovation allows us to transcend routine patterns and make better decisions. So speaking first about awareness, which translates to expanding the horizons of neuroendoscopy. The first horizon which I explored were intracerebral hematomas. So at this time, our department was part of the STITCH trial, and we contributed one of the largest cases for this trial. And all the cases in the STITCH trial were operated by me, and they were done endoscopically. So this is how I would do it. And the video, of course, is a relatively newer one, but the technique is exactly the same. I would put in a syringe, and then using that syringe, I would create a space and then evacuate the hematoma. And that gives excellent results, at least satisfactory results in terms of CT scan. And outcomes, of course, are not determined what we do. Ultimately, patient has to improve themselves. And then I thought I could then venture into colloid cyst. And this is what we did. Because, as we know, colloid cysts are typical prototypic tumors. They are not vascular, so that could be a nice basis to develop techniques for intraventricular tumors. But we have to understand that these are embryogenic cysts, and they are densely attached to the vein to the thalamostriate vein as well as the fornix. And I think from that perspective, it's not possible for us to remove it completely. For instance, I saw this patient who presented with a giant colloid cyst with severe hypoparathyroidism. And this kind of embryology gives us an idea that colloid cysts is almost like a true brother of craniopharyngioma. So the word total excision should be taken with a pinch of salt. So my objective when tackling colloid cysts was that I should be able to decompress it, remove at least part of the cyst properly, and then coagulate the remaining cyst. So I initially tried these two instruments through one port, and then I progressed, where I made a little bit opening on the burr hole, and then I would introduce another forceps so that I could get some kind of a multi-port access. That didn't work out well because this kind of converging ports, they don't work out too well. And then finally I settled to this technique, where I would puncture the cyst, aspirate it using controlled pressure aspiration, excise the major part of the cyst and cauterize the residual cyst. And this is a video to show that. So cauterizing the choroid plexus, puncturing the cyst, and it's not possible to aspirate the cyst contents by traditional suction. So to do that, I connect a three-way and it is connected to a 50 cc syringe, and my assistant provides a very good controlled pressure suction so that the entire contents of the colloid cyst can be completely evacuated. And once it's evacuated, I introduce a second port, cut at least a major portion of the capsule, and then cauterized the remaining portion so that the foramen of Monro is opened up completely. And I also do a septostomy so that both the ventricles are communicating. Now obviously these are the contraindications where the ventricles are not enlarged or you have these roof cysts, and these contraindications should be explored carefully. Few of my cases, pre and post-op, and of course large cyst, I take this transparent sheath and use it this way. I had a colloid cyst with a high pressure leak and we did both of them at the same time. And with this confidence, we thought we could tackle larger intraventricular tumors. And then of course we got this robotic system. So I thought this is an excellent system which can hold the endoscope because it provides a very good haptic feedback. So I can show you a couple of videos here, representative videos. So this was a cavernous hemangioma, which was just under the corpus callosum. So we're doing it endoscopic and we are doing it through an interhemispheric approach. It's an endoscopic assisted. So when we expose the corpus callosum, you can see that it is yellowish in color. We are now dissecting. Oh, we removed it. Okay, let me see. That's the cavernous and it's dissected everywhere, and then so that's a large recurrent neurocytoma. Again, through the interhemispheric approach, through the corpus callosum. Now we put gel foams both in the front and the back, and then they really help to open up the interhemispheric fissure widely. And that's the tumor which comes into view. Oh, sorry, I think I removed it. So that's, so moment it's removed, the bleeding stops, and you have an automatic hemostasis. So that's a large optochiasmatic glioma. He came in M5 and we had to take him up in semi-emergency. So again going through the interhemispheric approach, using an endoscopic assistance, opening the corpus callosum. So one has to do a compartmental resection, so if it bleeds in one place, I prefer to use wet gauze that really works very well instead of cotton, because one can very nicely use suction against it, and it also attains very good hemostasis. Now this is transcortical approach, and I found the best way is freehand. So this patient presented with this large tumor, which was highly vascular. And here I use the transparent sheet, which I will not advise. It really doesn't work. It looks attractive, but in practicality it doesn't work out well. So you can see the tumor was extremely vascular. But the advantage of intraventricular tumors is you just need to remove the portion which is visible And as you do, the more peripheral portions of the tumor starts falling back into the cavity. And you just need to keep on continuing to remove the tumor and not be overwhelmed by the bleeding. And at one stage, you'll find you have reached the gliotic plane and the bleeding stops suddenly. And that's when you know that you have reached to your end of excision. So I'm running it on a 2x speed. So you can see I have reached to the gliotic plane. And the bleeding is now reducing, and that's the rest of the ventricle. So that's a post-op scan. So this is a large meningioma, and Jitin here was with me at that time. Again, extremely vascular, but we did an endoscopic assisted transcortical approach. The tumor was very firm, so the technique is again straightforward. Expose the tumor, start patiently decompressing the tumor from the center. Don't try to go to the periphery, and as you keep on doing, the tumor from the adjacent sides will keep on falling into the center of your operative field, and you need to just keep on patiently removing it, and you'll find that suddenly the bleeding reduces and it's over. And I found this one of the safest techniques, more than craniotomy. You have a large opening, it doesn't help. These are really nice and safe techniques. So few of my examples where I've done an endoscopic approach: supratentorial ependymoma, choroid plexus carcinoma, central neurocytoma, that's a post-op, another pre and post-op. So what are the drivers of metacognition? So the next driver is innovation, which is not separate from metacognition. It's a natural outcome of it. When we become aware of our thinking, we begin to question the established patterns and challenge assumptions. And we create a space, and that space allows new ideas to emerge, transforming the routine practice into creative problem solving. So my first dip into innovation was, when I saw Henry doing a lot of carpal tunnels there. So I thought, could we design indigenous carpal tunnel? And then I came up with this set where you would only require 2 sutures. It's a very simple set, but this was done way back in 2000. And then we published some papers, and those of you can also read the chapter in Ramurthy and Tandon's textbook about this. And we did more than 1,000 cases of that. And then when I dipped into pituitaries, I was almost always convinced that most of this equipment are not actually required. They are industry driven. And I always felt that pituitary tumors form 80% of the endoscopic endonasal procedures, and you need to have a more simpler approach. And I was always against a binasal approach because it never felt justified for me to destroy this pristine surface. This is a patient who was operated earlier, and when I did a redo pituitary, I found there was severe septal necrosis with atrophic rhinitis. And this patient had lost her complete sense of smell. So obviously, biportal is something which I was not very much in favor of, and I thought that nasal morbidity is something which is overlooked because it's not visible in the garb of minimally invasive surgery. And then I thought I should take up a transseptal approach. And if you know, this has been discovered by Hirsch way back in 1940s, but it was given up because of septal necrosis, because of this large retractor which was kept in it. But I thought we should have a relook at it. So I thought maybe I could do a transseptal approach if it is tethered to a robotic system. So in theory it looks good, but when I actually did it, I found it very cumbersome. It was not working out very well. Then I thought perhaps I could develop a customized retractor, so I made a patent for it. I called it even an easy track. So the whole way that the retractor is put is, you create a submucosal flap, push in a retractor, take out the wire, and the moment you do it deploys, and you can do a septal fracture, go to one side, and then of course you come across the usual anatomy and you can do the removal of pituitary. But then I came across the best retractor, which is a dynamic, flexible, non-reflective, and zero cost. And what is that? just a plain MRI film. Get it sterilized, cut it properly, shape it nicely, fold it into V shape, and that is what I do for all my pituitaries. Now create a very nice submucosal tunnel, go right up to the base, up to the sella, pass the retractor there, the telescope goes in the 12 o'clock position, you can fracture the septum, and then you come across the usual anatomy, and it's zero cost. I know it can never be patented, but the fact is it doesn't cost anything and it forms a very nice system. And these are some of the cases which I did using just this technique, uniportal using an MRI film, some more pre and post-ops, again another pre and post-op. That was a giant which I operated. We of course designed a special retractor for him. And then finally we come to focus. So focus is the last vertical. And for this I would like to state the Warren Buffett's rule which says 5 out of 25. I don't know how many of you have heard about it. But what Warren Buffett says that you can write down 25 of your most important goals in life. Choose the topmost 5. Exclude with diligence the rest 20 goals. They may look attractive but avoid them at all costs. Pursue only for the top 5 goals. Because he felt that we fail not because of lack of focus, but we become distracted by good but less important things. And for neurosurgery, I think it is very important because excellence is not about doing more, but it is about doing less much better. And here, for some time, I was searching as to which ocean I should swim in. So if you read this book, which is Blue Ocean Strategy, it metaphorically divides our society into 2 oceans in terms of our career pursuit. One is a red ocean, which is red because the sharks are eating each other and there is blood being spilled. And these are existing or established specialties, lot of competition. People are paradoxically more happy to swim here. Blue ocean is new or emerging specialties. You are your own competition, but people still are hesitant to get into this ocean. But the bottom line is you are free to swim in whichever ocean you want, provided you have that clarity and ease. And for a long time I struggled for my own clarity and ease. And then I read this book of poems which was written by my daughter when she was in school about clarity, where she says, it's not always about blue skies and crystal waters, it's about freedom. Even in this messiness and murkiness, you are allowed not to know what lies at the end of staircase and take it one step at a time. And easy, it's important to find your own easy, to break open, fluid and free, to carve your own art and trust where it takes you. And it's important to choose your own easy. And I found in epilepsy both clarity and ease for several reasons. The important one, of course, is it gave me an opportunity to bond with my wife and give an additional purpose to our lives. So we started sincerely working in the field of epilepsy. You're aware of these 2 world-class randomized trials which have more than 3,000 citations. And we contributed towards the 3rd RCT, which has more than 1,000 citations, which was an RCT for pediatric drug-resistant epilepsy. And then I thought it's time to bring in the endoscope into the field of epilepsy. So I started initially with disconnections. So there was this patient with a parieto-occipital who required a parieto-occipital disconnection. So I thought, let me do it endoscopically. So I put a burr hole here and then pushed in an endoscope here. And then we did a disconnection. And then I got the Sturge Weber, where again we did an endoscopic guided assisted disconnection. And we published our data. So 75% of our patients who underwent TPO and parieto-occipital disconnections were those with bilateral perinatal insults. And this was the only publication where it showed even in bilateral pathologies, if you do unilateral TPOD, we were able to gain almost 60% seizure freedom. And then we came to mother of all surgeries, an hemispheric disconnection. So this was the first case which I operated, a child who came in 2002, who was having 200 to 300 seizures a day, was intubated in the emergency. You can see the incisor is lost. And then I had to read up and next day go and perform the hemispherotomy. And then this patient came fully grown up individual. One of the first hemispherotomies I've done, She's done her master's in computers in San Francisco. She walks with a slight limp, but is completely capable just with half a brain. And then we published our first series of hemispherotomy, but there was definitely a challenge. Most of these patients were kids. They can lose blood, they can become hypothermic. So the idea is, could we apply an endoscope to do a hemispheric disconnection, which seemed almost impossible at this stage, but then we worked upon it, both in the cadaver as well as in other places, and finally we developed the technique of endoscopic hemispherotomy. And we have published various papers, and now I know at least 6 or 7 more surgeons who are following this technique, and it's also there in chapter 219 of epilepsy, which is considered as a Bible for epilepsy by Professor Jerome Engel. These are a few examples. It's a hemispheric cortical dysplasia. Through a small opening, we were able to do an hemispheric disconnection. This patient I operated in Malaysia, who had a very complex pathology, hemimegalencephaly with aplasia of the frontal horn. Again, endoscopically we lost 40 cc of blood. And Vairavan was jubilant. He sent me this email saying that she is doing absolutely well and totally seizure-free. Then we used endoscope to enhance our hemispherotomy failures, because we were able to describe the temporal stem which was placed anterior to the amygdala, and a technique on how it could be resected in hemispherotomy failures using an endoscope. And then for hemispherotomy failures, for instance, this patient and a hemimegalencephaly, this portion was still disconnected. So when he came to us, we did an endoscopic approach, and in 15-20 minutes we were able to finish the connection and patient was seizure-free. And this is briefly the technique. It's there on the YouTube, so I will hurry it, but just to show what could be the possibilities which is available. So that's the kind of opening we do. Then under hemisphere, the process is absolutely similar to what I have done for tumors. We retract the hemisphere, go interhemispheric, expose the corpus callosum, expose the A2s, start dividing the corpus callosum from the splenium, take it along till the genu, and you could see the A2s going around the genu. And then we start doing the anterior disconnection, which goes in a coronal plane in front of the caudate head. It goes laterally. And then you start with the middle disconnection, which passes along the anterior disconnection and connects the lateral ventricle with the temporal horn till it goes back, till it becomes a single chamber. And the final part of the procedure is where you disconnect the tail of hippocampus along with the fornix. All this done through an opening of 3 into 4 centimeters. And we clearly showed that these patients had a lesser hospital stay, much less morbidity and better results. And using this technique, we created the first ever technique of endoscopic corpus callosotomy, combined with anterior hippocampal and posterior commissurotomy, which provided much superior outcomes to Lennox-Gastaut syndrome. And the technique is absolutely the same as we have seen it when we cut for hemispherotomy, when we cut the corpus callosum, except that once the corpus callosum is cut, we go forward, cut the anterior commissure. So that's the anterior commissure being divided. It's vital to divide that. And then we go back and then cut the posterior commissure, which is a bundle of fibers. So you can see that's the aqueduct. So go in and cut it. So we are doing a pan commissurotomy combined with a corpus callosotomy. And these were being done by Glur years ago, but they have been forgotten. And these are the two techniques which we developed, endoscopic hemispherotomy and corpus callosotomy, and both of them provided hope for children with this terrible malady. But if you look at nature, it's always evolving, it's always improving. For people who remain stagnant, it is death. So we too decided to evolve. And then we evolved to the world's first percutaneous bloodless hemispherotomy, which we have done 30 cases. And here we evolved from a hole to a line in the brain. And it's a made in India technique. So it's fundamentally same as endoscopic technique, except that we target radiofrequency electrodes for corpus callosum through 4 holes. And then through a single twist drill, we do a complete hemispheric disconnection. And then finally, we disconnect the amygdala and the posterior connection. So few examples where we have done it. And I will run this video very fast to show how it is. So it's a very boring technique because nothing much is happening. The only thing what we do is we drill, open the dura, calculate the distance to target, and keep on cauterizing all the electrodes. So we do about 100 to 150 burns. There is no bleeding, nothing much happening. So I ask my fellows to do most of this procedure. So that's how it goes on. But the best part is absolutely no blood loss, and we have converted a hole into line. And at the end of surgery, you just put band-aids, that's it. So patient comes out with just band-aids. And we were happily going along, sailing, till we reached the 30th case, when we realized there was a danger in this corner. So we got this child who was having 30 to 40 seizures a day, hemimegalencephaly. And then the T2 image revealed the DVA on this side, and we decided what to do. And we thought, say 30 to 40% of these patients have DVS. So let's go ahead. And when we did, this patient developed a large venous infarct. So we did a decompressive. Unfortunately, we couldn't save him. And this became our first mortality. So it gave us very important lessons. What could we have done? Could we have avoided the DVA? Could we have done an open hemispherotomy? Could we have done an endoscopic hemispherotomy? And if you look in the literature, almost 35 to 40%. So whenever we do hemimegalencephaly, one has to be very careful because these can really get onto you, both by open as well as by radiofrequency. So you can read more about this technique from these two textbooks, Textbook of Epilepsy by Professor Jerome Engel, and our own textbook, where we have contributed 18 chapters, which was started by none other than Professor Ramamurthy and Tandon. And in our series, we have shown, and currently this is the only hemispherotomy which we do, which is a percutaneous hemispherotomy, and we have shown an outcome of 75%, which is equivalent to that of an open hemispherotomy, but absence any blood loss, absence any fever, absence any infections. So we have contributed towards development of epilepsy programs in various countries, including Indonesia, Malaysia, Morocco, and it has been a busy journey. And the technique of Roche, we were very happy that we had a full team coming from Israel who learned the technique, because in the technique, the planning is the surgery. The surgery itself is nothing. You just need to go on coagulating. The entire thing is to plan how can you do an hemispheric disconnection. And they stayed with us for almost 1 week, understanding how this planning can be done. And now they have done 5 cases in Israel. And now I have heard later is that they're going to implement this nationwide. And this quantum of work would not be possible if it were not for a huge team, particularly my wife, Manjari, and then my colleague, Ramesh, Ajay, so many people. Sometimes when I'm showing these results, I feel as if I'm some kind of a speaker, outsourced speaker, speaking about it. But the major quantum of work has been done. So finally, we understand that metacognition is not about awareness of thinking. It's monitoring our decisions and ability to pause and calibrate. Most of us understand this intellectually, but in real life situations, especially under pressure, we often fail to apply it. And why does this happen? Because there are powerful forces acting on our mind that override awareness. But before we explore why metacognition fails, I will urge all of you to read this book by Daniel Kahneman, who was a Nobel Prize winner. He was trained as a psychologist, but he received Nobel Prize for economics because of his groundbreaking work which revealed how our mind operates in different situations. And he described 2 distinct modes of thinking, System 1 and System 2. System 1 is called as fast thinking, which is intuitive, automatic, pattern recognition, experience-driven, useful in routine and some emergencies. But System 2 is a slow thinking, analytical, deliberate, logical reasoning used in uncertainty and complex decisions, requires effort and time. And if you see, a lot of expert neurosurgeons always prefer to run on System 2. But the really expert neurosurgeons have a capability of switching seamlessly between system 1 and 2, knowing when to trust instinct and when to slow down. The difference between a good surgeon and a great surgeon is not knowledge. It's knowing when to pause and when to think. And these are the factors where metacognition can fail. You can have an anchoring bias, which is a first impression trap. Oh, this is that tumor, I have so much of experience, it cannot be anything else. That's the first trap. Second is confirmation, where we will look only what we expect to think. There is a very famous saying, say that your eyes will see only what has your mind been taught. But that is failure of metacognition. You should always be open to think of any kind of possibilities which can appear. And of course, when you have overconfidence, time pressure errors, automatically you switch from the system 2 to system 1. And that is where you can actually make mistakes. So metacognition fails when system 1 dominates and system 2 shuts down. Now, metacognition fades not because we lack knowledge, but because we stop questioning. When focus is lost, when comparison replaces reflection, because when you start comparing yourself with your peers, that is when there is a loss of intelligence. When you conceal your errors, you don't show your complications, and you accept literature without any due scrutiny, because you have to understand, at the end, the papers are published by some people who just want to show some technique. And metacognition is not lost suddenly, it erodes gradually over time. The attrition is driven by subtle but powerful forces. A lack of focus fragments our attention and prevents deep thinking. Together, these forces slowly diminish our ability to observe and refine our thinking. So you could enhance metacognition by creating an environment where thinking is shared in a team. It's questioned and refined collectively. You actively seek team input to bring diverse perspectives that challenge your assumptions. Flattening hierarchy in crisis ensures every voice, regardless of seniority, can contribute without hesitation, especially in critical moments. Encouraging combined team brainstorming fosters open dialogue, allowing ideas to evolve and blind spots to be identified. In such a culture, metacognition is no more an individual effort, it becomes a collective intelligence. So final thought, the best surgeons are not those who know everything, but those who know when they might be wrong. And I'm still a traveler, very much along the beginning of the journey. But I think if we follow this road, we can say that we are on the right track. So I'm really grateful for your audience, for this opportunity, for allowing me to think beyond technique, because it has been an honor for me to share this journey of thinking beyond technique. And my sincere thanks to Neuroendoscopic Society of India, and appreciation to all my mentors, teachers, colleagues, and trainees who shaped my thinking. Thank you so much. Ghano Abar. Thank you. Thank you so much.
Thank you. Thank you very much, Professor, for having this brilliant oration today for the Endoscopic Society of India. So we really appreciate it, and before going ahead with the remaining formalities of this oration, I would like to have the comments from my friends and co-chairpersons. So this is Dr. Bansal.
Thank you, Professor, for such a wonderful, enlightening thing which you have spoken. We all are very blessed to listen this, your presence and your talk. Thank you very much.
Dr. Subodh.
Thinking about thinking is the greatest thing what you told us. I think that helps us a lot. Thank you very much for the wonderful oration.
Thank you so much, sir. This is all what we can say, and we've been blessed to learn from you for so long. And it's been a wonderful journey, and we hope to continue this journey for further also. Thank you.
Thank you, sir, for the truly inspiring thoughts Now we will proceed with the felicitation ceremony by Dr. Samir and Dr. Joyce Chin Oratal. Thank you so much, sir. So, ladies and gentlemen, it's time for a well-deserved break. Lunch is served at the green lawn from till 2. Please enjoy the meal and be back on time for the afternoon session. Thank you so much.
देख नॉइज आ रहा है.
कभी कभार नॉइज ना अनु क्या दिक्कत आ रही थी अरे वो हवा ये इसकी आ रही है भाभी इसकी बाहर का माइक खोल रहा है टाइप सी तेरे पास टाइप सी पोर्ट है तेरे में ये पे ये ले अभी इस पे लैपटॉप पे टाइप सी पोर्ट नहीं टाइप सी नहीं 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 साउंड कार्ड की गड़बड़ तेरी एस्टीमेट आपने बहुत मिल दिया एस्टीमेट में हटा दी इसको वापस में डाल हे आ रहा है ओ है उसमें उंगली मत कर यार हे 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 स्ट्रीम में तो आ रहा हुआ ना हे स्ट्रीम चेक करते रुक जा हे 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 हे
Dr. Arun. Mungti. Dr. Gaurav, Dr. Aryan, and Dr. Vamsi. So for this session, we have 4+1 speaker, 4 that you have on the sheet, and 1 is an additional gift from Dr. K.K. Bansal. So first speaker, I'll like to announce Dr. Prakash Nair to please come on the stage.
So a very good afternoon to all of you. I apologize for sounding like Amitabh Bachchan. This is not my real voice. This is as a result of some upper respiratory infection. But I shall be talking to you about the extended endonasal procedures in pediatric in children, and deal with some anatomical constraints and some technical difficulties that one encounters when we do these procedures. And I acknowledge many of my fellows and residents who have helped me with this presentation. So for a very long time, this was a contraindication which is for endonasal surgery itself. Small children, very small nostrils, a conchal type of sella or extension of tumors into the planum or beyond into the clivus. And this was considered to be an area where you cannot go. There are certain natural anatomical constraints that one encounters when we do children. And they include the non-nematization of sphenoid sinus. So it's very common to see this conchal type of sella without a lot of bone in between the sella itself and the sphenoid sinus. That pyriform aperture itself can be very narrow. So this is a bony constraint for any bimanual procedure inside. Now, when one has these extremely dense and conchal type of sella, you don't see familiar landmarks like the middle opticokerotic recess or the optic prominence that can guide you into dissecting within this region. And most importantly, the intercarotid distance between the internal carotid arteries can sometimes be very narrow. So these are all anatomical constraints that exist in children. So we looked at some of our radiological study where we looked at the natural obstructions that we encounter when we approach the skull base. So one of the typical features that occurs is the sphenoid sinus nematization. This occurs from the anterior to the posterior extent. So anteriorly, initially, with the first 6 years, there is no nematization, but then the nematization proceeds in the posterior manner. You have a precellar type of nematization here, and then nematization can often extend into the clivus. So the dorsum is extremely uncommon and unlikely to nematize. The thickness of the bone also changes with age. So when we look at these graphs and plot them for age groups, you see that in very young children, between the first 6 years, the extent of bone thickness is quite significant. But as the child grows, you can see that the anterior bone here becomes extremely thin. And the volume of the sphenoid sinus, the true space in which we operate, is initially quite small, but it increases in size. Most importantly, you can also drill the sphenoid sinus and create a lot of room for surgical intervention. Surprisingly, when we looked at the intercarotid distance at various points, at the proximal dural ring or at the bifurcation or within the sella, we found that even in very small children, children of less than 6 years, we never found that the intercarotid distance was less than 10 millimeters. A number that has been quoted in literature as a contraindication for endonasal procedures. In fact, even in this age group, we found that the distance between the ICAs at the level of the distal dural ring was nearly 13 millimeters. Obviously, these are some of the common appearances. You have the prominence of the ICA or the optic nerve, which are not commonly seen in children. And this is a point that we need to discuss about. This is a pyriform aperture. The pyriform aperture is the boundary of the nasal cavity and the nasal vestibule. And this is a limiting factor in children. But interestingly, when we look at the distance between the sella and the nostril, we often found that because it was shorter in children and smaller in children, the angle that was created was much more favorable. So even though the pyriform aperture was a constraint, the short distance between the nostril and the sella did not kind of circumvented this obstruction. So then we looked at our own data in the last 10 years for children who are less than 18 years. And in this group, we had nearly 119 patients. So 23 patients who had purely non-neoplastic etiologies like CSF rhinorrhea or other congenital anomalies, and 87 patients who had various tumors, including craniopharyngiomas, which are the most common set of tumors. As you would notice, this is a slight difference between the adult and the pediatric population, where craniopharyngiomas can be much more common than pituitary adenomas themselves. They're not very common in children. So when we looked at the numbers, we had a mean age range of around 10 years for our craniopharyngioma patients. And of course, uncommon conditions like fibrous dysplasia, chondrosarcomas, or even granulomatous conditions, which form the other bulk of the numbers. When we looked at craniopharyngioma themselves, we were able to see that we were able to get gross total resection in a fairly large number of tumors. So nearly 78% of patients who had gross total resections. And of course, in germ cell tumors, where the aim is never a gross total dissection but a biopsy, we had 2 patients where patients had failed medical management and had only partial remission after medical management and required resection to complete their treatment. So another interesting factor is the presence of CSF rhinorrhea. Now, unlike the adult population, CSF rhinorrhea in this group was often because of congenital anomalies that we should be talking about later. Now, when we looked at their outcomes, we saw that, even though this is a mix of population, so this is probably not a very good comparison. 66% of patients had a significant amount of improvement in vision after surgery. With diabetes insipidus happening in nearly 44%, almost all of them were craniopharyngioma patients. And we had a very small number of patients who had recurrences following surgery. When we looked at complications, we were able to keep our CSF leak rates to a very small percentage, only 6%. And infective complications like meningitis to 7%. With one patient who died, and this was a patient of craniopharyngioma who had had 6 prior surgical procedures and was probably not a very good candidate for surgery. So another finding that we had was this extent of nematization. So the most common pattern of nematization, this conchal pattern, was not seen in a very large number of patients. Only 6% of patients had this conchal nematization pattern, which has been often quoted as a contraindication for surgery. Most of these tumors had a cellar or a pre-cellar nematization, which is a very favorable anatomical pattern for surgical resection. And we also saw that the nematization pattern extended from anterior to posterior. So in very small children who were 2 years or less, the nematization pattern was very anterior, but then it proceeded by 14 to almost invariably include nematization of the entire sphenoid. So these are certain examples, some case examples of how it works in real life. So this is a very young child, a child who was only 18 months old with a large craniopharyngioma extending from the suprasellar cistern all the way filling the third ventricle. Now, these are children, we see this procedure when the flap has already been elevated, and a certain significant amount of drilling that is needed for creating this surgical room. But once we drill the sphenoid sinus and identify the sella and the clival recess, we can open the dura just like we would do for an adult patient, and then start dissecting the tumor and the walls of the tumor. Once we've identified the superior hypophyseal artery here by the capsule, the tumor can be slowly dissected off the other perforators. Now the perforator that arise from the PCA that lies slightly more posteriorly. Now the dissection is then taken to the superior part, which is beneath the optic chiasm and the part that extends into the third ventricle. So the very systematic dissection. You start at the periphery, decompress the tumor for inside, and then dissect the walls. And we come to this part, which is where the stalk is. Now, stalk preservation, you can see the stalk here, is a very important goal of surgical resection. You may not be able to achieve it all the time, but it should always be attempted. And in this manner, using microsurgical techniques, going millimeter by millimeter, one can dissect the tumor away from the walls of the ventricle. Naturally, the dissection proceeds by combining it with decompression. So at the end of the procedure, one can see the ventricle walls very clearly. And as you can appreciate, this is working in a very tiny space. You have a small amount of tumor now attached to the ventricle. And the endoscopic approach gives a very unique perspective onto how you can dissect the subpial plane of the ventricular wall. So now you have the tumor that had extended all the way into the posterior third ventricle, which has been completely resected. You can see the posterior third ventricle and the choroid plexus at the back. And then we reconstruct the sella in the same way that we would do in adults, multi-layer resection, multi-layer technique, using duragen, fascia, fat. And you'll be surprised to notice the size of the flap that you can get for a child like this. So when you place a nice nasoseptal flap, you get very good coverage of the entire skull base. And this is because the nasal septum is almost the same size in proportion to the sphenoid sinus. So children grow and you get large flaps that can be used for reconstruction. So this is the result at the end of resection. So at nearly a year of follow-up, child continues to do very well. So these are other examples. You have a pediatric Cushing's where anatomically the sella appears to be unfavorable, but then you drill the sella very nicely. You get resection, and then at the end of 8 years, you still have the patient who's in remission. The important thing being this wide, extensive drilling to create room and exposure of the gland itself. So this is another example of a child. Now CSF rhinorrhea, surprisingly, is not uncommon, but this doesn't happen because of race pressure or other conditions. This happens because of some congenital anomalies. So this is a very unique condition. This is called a primitive craniopharyngeal canal, where you have a defect between the pre and the post sphenoid cartilages of the sella, and you have this large meningoencephalocele in a child, which was again repaired using a purely endonasal technique. So the entire tract can now be dissected out. This is the tract of the craniopharyngeal canal, and the craniopharyngeal canal can often contain tissue that can either be tumor or even dermoids. So it's very important to resect the entire canal there. And then reconstruction is done using a large flap. So another child, a large follow-up, a similar case, we encounter. So this is another example of a child who had a very large fibrous dysplasia, again managed using the endonasal approach. So in conclusion, the technical challenges encountered include a narrow pyriform aperture or nasal developmental difficulties, which can be to a certain extent dealt with by adequate surgical technique like drilling and use of adjuncts like navigation and Doppler. And the aim is to convey that the extended approach is a very useful surgical approach in young children. It can be used to achieve a very high rate of resection with an acceptable rate of CSF leak of 6%. And it can be amenable to very young children, even children less than 2 years of age. It allows the surgeon to access skull-based pathologies directly, and it avoids morbid craniofacial resections. And in patients where it is possible, you can even preserve normal pituitary functions while resecting tumors. Thank you so much.
It's an excellent talk, Dr. Dr. Nair. Yeah, there's a question from Pathak.
I don't know whether you heard the name of Professor Harold Hoffman from Canada.
Yes, sir.
He was the man who would remove all craniopharyngiomas transcranially. The issue is craniopharyngioma is not the complication that you discussed, it's the cognitive decline, which is the most morbid thing in this patient. Other things can be managed. So do you have a preoperative cognitive assessment followed by postoperative cognitive assessment in your patient because you're peeling off from the hypothalamus?
Actually, it's a wonderful question. It's actually a very important part to be discussed.
The actual true question which one needs to understand, because once you have a cognitive decline, you wreck the life of the patient.
So in the morning, one of the papers in the award session was our data on craniopharyngioma. One of the findings that we have now, with good follow-up, is that when you preserve hypothalamic walls, you get very good cognitive outcome. Our own argument would be that if you can avoid radiation in a very young subset of population, then you can actually give them better cognitive outcomes. Because radiation over a long period of time definitely causes cognitive decline, especially when you radiate the central skull base, which has the hypothalamus there. The point of the procedure is that you get resection. When you see the hypothalamic walls, you're able to assess whether the tumor is actually resectable from the hypothalamus or not resectable, because you can actually see the wall. And in cases where there is pial infiltration and tumor going into the hypothalamus, there is a definite role of leaving the tumor there.
Yeah.
But I would argue that when you do when you have patients with predominantly retrochiasmatic tumors, you have an extensive amount of frontal retraction. In fact, in Hoffman's series and in the series of Pierre Kahn, which was published around the same time, one of the biggest problems was patients who had retraction-related injuries and seizures. In our series, we have almost no patient who's had seizures. Now, we have a very high rate of hypopituitarism. But it starts with the fact that most of our Indian subset of population have hypopituitarism. So our preoperative hypopituitarism rate is nearly 70%. So it's also important to remember that our data is not probably always
No, the
comparable with
preoperative
Western
cognitive
data.
assessment, how far is it, how extensively is it done? That's important
How
issue.
extensive is?
Preoperative cognitive assessment, how extensively, how deep you go into
Sir,
that?
see, cognitive assessment is limited and is not possible in very young children. But wherever we've been able to do cognitive assessment, we compare their outcomes to their current scholastic performance. And we find that in patients who, in a significantly large number of patients, they're able to retain a significant amount of scholastic performance as appropriate for their age.
Yeah, anyway, thank you. Thanks a lot, Dr. Nair. Hypothalamic invasion in craniopharyngioma is definitely some challenging and controversial topic. Thanks for the talk. And the next speaker is Dr. Rajesh Chabra, professor from PGA.
Good afternoon, and thank you organizers for the invitation and the opportunity. Today I am keeping my talk very simple, arachnoid preservation in pituitary adenoma surgery. So basically ETSS or endoscopic surgery fundamentally is extra-arachnoidal surgery in pituitary cases. The arachnoid is a boundary, not the target. So we should upstream the prevention of the arachnoid rather than focus on reconstruction. So most of time, I mean, I am not saying that it's possible in every case. We will discuss in detail in the following slides. But the thing is, as much as possible, if we can keep the arachnoid intact, that is the best thing which we can do. So my talk will focus on basically upstream on prevention. So as we know, it helps in neurovascular protection, CSF containment, complete tumor removal, and fewer complications. So in our series, we operated more than 1,200 endoscopic surgeries and more than 1,000 pituitary adenomas. We do since 2016. So these are the different surgical mix of the cases. So arachnoid membrane of the supracellular regions. Basically, if you see in pituitary, mostly we come across with the membrane of the chiasmatic cistern. The other membranes usually we don't come across, so these are more for the craniopharyngioma surgeries. So how can we predict arachnoid breach risk before incision? So it depends upon the grade also. The grade, the smaller the grade 1 and 2, if you see the grade 1 tumor confined to cavernous within the sella, the chances are high that you can keep the arachnoid membrane intact. With the increasing grade, there is chances of arachnoid breach increases. At the same time, if in the MRI, if we see irregular humps and bumps, means subarachnoid involvement, narrow cellar neck, then again there is a difficulty in preserving the arachnoid. And if the T2 hypo intense signal is there, it shows that tumor must be formed too hard, then even again we have some difficulty in keeping the arachnoid intact. And paracellular extension, multi-compartment growth, prior surgery or radiation again limits the preservation of arachnoid. So if you see, so the green part is NOSP, early NOSP grade, T2 bright, smooth dome, and at the same time the red flags are NOSP, higher NOSP grade, T2 dark, humps and bumps. And for this, you have to prepare preoperatively. For standard, this thing green signal, there is no need for the nasoceptor flap harvest. The fat donor site should be prepared. Standard consent is enough. For the yellow this thing group, this is we have to have proactive preparation, fat donor site prepared, discuss NSF possibility. Whereas in the red flag, we should be harvest the NSF flap at start and extend. We have to take the consent for extended stay in ICU or in the hospital. So these are the things which I want to emphasize, that in the intraoperative we can follow the traffic light algorithm. Grade 0 to 1 green, standard. If the leak is grade 0 to 1, then it's a standard closure is enough. Grade 2 fat plug, if required, lumbar drain. If it is high flow, if it is low flow, lumbar drain is not required. Grade 3 red, in this use nasoseptal flap and lumbar drain. So if the arachnoid tear occurs, then you have to customize the treatment as per the requirement. So every case doesn't require the similar kind of treatment. So this is the basically how to preserve, how to create a arachnoid plane. So first we have to do the central debulking of the tumor, and then we have to identify the capsule. Usually I prefer, after removing the tumor, then we go anteriorly towards the tuberculum sella. There it is very easy to create a plane in the anterior part. You can see here you can find create a plane between the capsule and the arachnoid, and remove the capsule, extracapsular, or even you can leave thin wall of capsule outside for better pituitary functions if it's required. So this is we are removing and keeping the arachnoid intact posteriorly. So if we keep the arachnoid intact, then the chances of the complication and CSF leak are significantly reduced. So then the role of cotton patties. Cotton patties are very important while doing doing arachnoid separation. It can while doing suction always keep a cotton patty on the arachnoid. It can act as a traction buffer. It can act as a micro retractor. It can create a plane, and it can act as a hemostatic scaffold. So this is a case in which central debulking, removal of the tumor, and you can, if the bulge is there, you can use the cotton patties and create a plane of and separate it from the arachnoid. So if the premature bulge occurs, then what we can do? Again, we can push the arachnoid with the help of cottonoid, and if required, we can a controlled puncture is a better option rather than allow it to tear while doing suction or anything, or with the force. So in this case, when the arachnoid bulge was continuously, even after putting cotton, we were not able to push it supracellular area, then we electively puncture and release the CSF, and then this arachnoid goes back, and this, if we create a small defect or cut, give a sharp cut, it automatically get closed. After some time, the tragicity of this arachnoid start appearing, and now we are very comfortably seeing the tumor, and we can remove it. So if at all then the tear occur, so there is either you can say plugging the diaphragm defect, or you can say this is bath plug type of repair is important, which was found to be very effective and useful. There was successfully 21 cases plugged, escalated, and however, in unplugged case, there are chances of CSF leak were comparatively high. So in this, when this defect is defined, you can take free fat and put it there, half in, half out, like the tubeless tire puncture we see. So this plug-in, if it is effective, immediately the CSF leakage will stop there and then in front of you, and there will start CSF accumulation, and arachnoid tragicity will come. You can see it there intraoperatively. If you see your tumor is going anteriorly in the frontal area, it means there is a subarachnoid extension. So in this case, it will be not possible to keep the arachnoid intact. So after removing of the tumor, then we have to again put the fat plug and fat as well as the fascia and nasoseptal flap. So in our page, if we see in the grade 3 leak rate by tumor invasion, the preoperative risk stratification data, in the non-invasive versus giant tumor, there is a significant increase in the arachnoid tear. So this is our data of the different patients in last 200 patients. So what are the cellular reconstruction options now? The fat, everyone knows that fat plug, overlay, inlay, graft, dural suturing, bony reconstruction, nasoseptal flap. So this is the different options which you can use. So in our case series, the postoperative CSF and rhinorrhea was seen in 3% of cases. Redo repair required in 2% of cases. Lumbar drain switch was done in 1% cases. 1% means switch means initially we decide that lumbar drain will not be required, but later on we have to convert it into lumbar drain. And grade 2, when plugged adequately, chances of leak was nearly 0%. And in the growth total resection non-invasive adenoma, there is more than 85% was achieved, and meningitis rate was less than 1%. So what does we understood is ATSS is extra-arachnoidal surgery in pituitary cases, and arachnoid preservation reduces CSF leak, and fat plug is the central technical maneuver, and selective lumbar drain protocol validated, and it can be avoided in if in the early grades, but in grade 3 or grade 2 with high flow, we can use lumbar drain. Our CSF rhinorrhea rate of 3% is at or below published meta-analysis. So with this, I would like to say thank you.
Thank you, Dr. Chabra, for a wonderful thing, wonderful lecture on the arachnoid CSF leak thing. We'll take the questions towards the end. We are already running probably. We'll take the questions towards the end of the session. Okay. So, because it's already pretty late running. The next one is Dr. Samir El Baba.
Okay, good afternoon, ladies and gentlemen, and thank you again for the opportunity to be with you here in Jaipur today with this wonderful group of friends and colleagues. Shifting gears from talk about fetal intrauterine spinal bifida, talking into what we always do every day, which is brain tumors in children. The focus of this talk will be look at different strategies, endoscopic versus endoscope controlled versus endoscope assisted techniques for pineal region tumors in children. It doesn't matter what we do, endoscopy, microsurgery, assisted control. What matters is we do the right thing for the patients. Specifically when we deal with deeply seated lesions, should always think about any endoscopy we do, especially in the ventricles, should think about the gray matter we're damaging on the way in, the white matter tract we're traversing, ependymal surfaces around those pathologies. We always talk about eloquence. We talk about speech areas, motor areas. We talk about corticospinal tracts, somatosensory thalamocortical tracts, optic radiations. But I remember early in my career as a junior attending in Little Rock, I had the honor of working next to the father of microneurosurgery, Professor Yassergol, and I got to operate with him in a large number of cases as an assistant. And he used to always say there's nothing called eloquent. The whole brain is eloquent. Every time you put an endoscope to do an ETV, you're damaging something. And I started thinking about it. The gray matter entry point, the white matter tracts, and it matters. The whole brain should be eloquent. When we talk specifically about endoscope-assisted microsurgery, a technique described by Professor Pernetsky as a minimally invasive technique with maximally effective treatment. Terminology-wise, for the junior colleagues or residents in the room, we have to differentiate between those terminologies. Endoscopic, when we use the working chow of the endoscope to do the work, like an ETV. Endoscope control, the endoscope is used primarily for visualization, like in transsphenoidal surgery. Endoscope assisted, when we're using the endoscope, different parts of the microsurgical procedure. Endoscopy is picking up beautifully. Why? Because it's giving us different angles, 0, 30, 45, even 70-degree angle endoscopes. It doesn't matter if we do a semi-sitting craniotomy and with microsurgically versus endoscopic. It doesn't matter what technique we do. If you have both technologies available, have them both in the operating room. And that's what I do actually in every case. Every microsurgical case I do, there's always an endoscope in the operating room. When we talk about the pineal region, specifically in children, it can be challenging making the decision making. The three traditional approaches, supracerebellar approach, posterior into hemispheric transtentorial, or posterior transcallosal are the most commonly used. We can go median or paramedian. We can go supra or infratentorial. Again, what matters is the patient selection. Above all, the anatomy. External landmarks are essential. Navigation can become irrelevant in those cases, and nothing better than the anatomy. The venous sinuses. Think about which venous system in the posterior fossa we can sacrifice and the ones we can preserve. Early on, when we deal with the inferior vermium veins, they're safe to sacrifice exactly at the midline. But when we go lateral, you start thinking about posterior fossa syndrome. And actually, if we think about most complications in posterior fossa surgery, actually they're venous complications more than anything else. Selecting the approach can be critical. We'll go through some cases. Looking at the MRIs and look at the tentorial angle is very important when we decide. Professor Ertel and his group in Germany started talking about doing semi-sitting position for very young children. In my practice, we can do semi-sitting position down to the age of 2 years old. We have a protocol. We do a CT scan to see which parts of the skull are the thickest for the pinning. We do an echocardiogram to look for PFO or any cardiac anomalies. We do intraoperative TEE, transesophageal echo. But we have to remember, over 50% of pineal region tumors, they're germ cell tumors. So getting an endoscopic treatment, like in this 7-month-old baby with a large pineal tumor, as we all know, we do ETV and we do biopsy. It doesn't matter what we do, a single burr hole or 2 burr holes. What matters is we do the right thing. In this case, we use the second burr hole at the anterior hairline. Here, we're looking posteriorly at the third ventricle, massa intermedia, coronal plexus roof, third ventricle. This came back as pineoblastoma resected via supracerebellar infratentorial approach in prone position because this is only 7-month-old baby. 16-year-old boy, headaches, upward gaze palsy. You can see I always plan to do 2 burr holes, but when I go inside, I decide if I'm going to use 1 or 2. How? After doing the ETV, and I feel good about it, the next thing, I look at the choroidal fissure. I look at, can I take a look at the tumor without manipulating the fornix or the choroidal fissure or the choroidal plexus? In this case, I felt good about it. So I went in and I did the biopsy through a single burr hole, although I went in planning for 2. In this case, it came back as germinoma. Adjuvant therapy melted the tumor. How about endoscope-controlled approaches? This is a 14-year-old girl with a pineal cystic lesion. I followed for almost 1 year, thinking it's a pineal cyst. Then it started changing in size, and you can see proteinaceous contents are different from the classic pineal cyst. The classic approaches were considered. Decision was made to proceed with a semi-sitting position craniotomy. Semi-sitting position, we marked the lung incision, but we opened only the top part. In this case, after doing 10 years of microsurgical and endoscope assisted, I felt comfortable transitioning to endoscope controlled. After sacrificing only the midline inferior vermium veins, now we're looking at this view. And it's extremely important to identify the anatomy. Right thalamus, left thalamus, vein of Galen, right basal vein, left basal vein. And now we're doing a combination of sharp and blunt dissection of the mass from the right basal vein of Rosenthal. Again, this is very important. Tentorium tumor or the mass is removed in a piecemeal fashion. And now we're looking, we put the endoscope, again, zero retraction injury, and here we're looking at the posterior third ventricle. Very small craniotomy and zero retraction injury in the cerebellum. Optimal positioning is key. For the last couple of cases, how about lesions in the mesial temporal lobe, like this child with medically intractable seizures and this enhancing mass in the posterior parahippocampal gyrus. Sarah probably would think some people do laser ablation and people would think differently. This was done 10 years ago. So think about this case. What is the best approach for this lesion in the posterior parahippocampal gyrus in a child who's cognitively completely normal with a normal visual fields exam? In this case, I started looking at the FLAIR and T2 signals. You can see here where the problem is. The goal is not to do epilepsy surgery. The goal is to go and resect the mass and leave the rest of the temporal lobe alone. Think about the supracerebellar transcensoral approach for the mesial temporal lobe. It allows us access to the mesial temporal lobe without any retraction injury or resection for eloquent parts of the temporal lobe. In this case, I elected to go for supracerebellar transtentorial approach to the mesial temporal lobe. Patient was placed in the semi-sitting position. This technique I learned personally in Istanbul from Professor Toure, but it was described by Professor Yashergil, by Professor Oliveira in Brazil, and many mentors in the field. Child in the semi-sitting position, 45-degree, TEE in place. We start by doing paramedian incision. After doing the craniotomy and opening the dura, it's extremely important to start by opening the cisterna magna. Now the cisterna magna is opened sharply. After the cisterna magna is opened sharply, cerebellum will sag, and now I feel most comfortable with the endoscope, not the microscope. Bring the endoscope. Now we bring the endoscope during the transcensoral opening. Always think about the anatomy of the trochlear nerve. Yesterday at the workshop, all the participants were able to see the trochlear nerve under the under the tentorium. And now we go and we do now transcensoral resection of this mass using the aspirator. And this was done microsurgically. After this was completed, now you can see it's a calcified lesion. After resecting the mass via the transcensoral approach, I felt that I did a good job. So I decided to put the endoscope after removing the mass, and then I found that I did not do a good job. When I put the endoscope, I found that I left a good-sized residual lesion lateral to the P2 segment, P2, P3 segments of the posterior cerebral artery. And this is the view the microscope did not show me via transcensoral opening. Lateral to the PCA, I was not able to see it. This was resected, now endoscope controlled, the PCA is intact, and now we can see after the tumor was resected, patient was seizure-free, and most importantly, we left this eloquent temporal lobe, dominant temporal lobe, completely normal, and all the edema in the hippocampal gyrus was gone. For the sake of time, this is the last case, a case with pineal tumor. The patient had a PFO, patent foramen ovale, in the echo. We did it in prone position, microsurgically, and after identifying the precentral cerebellar vein, doing resection microsurgically, then we put the endoscope to take a look at the resection. Not only at the resection cavity, but to look at the venous anatomy. Here you can see right basal vein, precentral cerebellar vein, left basal vein, vein of Galen in the midline, and now we're looking at the posterior third ventricle completely resected. If you look at the post-op MRI, I actually don't look at the tumor resection. I always look at the venous anatomy. You can see the venous anatomy beautifully identified here as intact, including the precentral cerebellar vein. Complications can happen. We've had zero mortality with semi-sitting position in pediatric population, had one intraoperative air embolism, clinically insignificant, and had one epidural hematoma. Other techniques we've used are the removing posterior thalamic lesions via posterior interhemispheric subsplenial approach, which can be used also using an echo. Welcome to reference this paper look at the extreme lateral supracerebellar infratentorial approach. We publish with our colleagues from different centers in Europe. I invite you all to become members of the IFNE. It's a great society, and we'd love to have you joining us. In conclusion, semi-sitting position is safe and essential approach for pediatric patients with complex pineal, CP angle, or mesial temporal pathologies. It doesn't matter if we do microsurgery or endoscopy. What matters is that we do the right thing for the patients. But endoscope-assisted microsurgery has a major role to play. At the end of the day, surgical planning, essential partnership with colleagues from anesthesia, anatomical knowledge will lead to best outcomes. Thank you so much. Thank you.
Dr. Tadashi Watanabe, and he'll be talking about instrument selection and dissection techniques for endonasal surgery.
Good afternoon, everybody. I'm Tadashi Watanabe from Nagoya, Japan. And I'm very happy to be back in India. And Dr. Bansal, thank you for invitation. Okay, so today my topic is about surgical tools. This is my standard setup for endonasal surgery. We use this kind of pneumatic holder, and standing on the right side, the two neurosurgeons do the surgery. And the approach is done by ENT team. And this schema shows the concept of the endoscopic surgery. There always be an endoscope itself inside the surgical field, so there is always be a confliction of the two tools and the endoscope. So there always be an invisible wall like this, so you cannot touch this area if the scope is upside here. And maybe you may experience the, once you bend the tip of the tool, you can easily touch to the place. So I prefer this kind of curved tools, and also rotating action is very effective in endoscopic surgery, and also the malleable tools. So we, in these 10 years, I have been doing, developing the tools, and this is my sketch for tools, the malleable tools. It can be bended two directions, vertically or horizontally, with this kind of wavy design. So, and after the model-based verification, like this, and we have developed this kind of tools, the dissectors, which have the two bendable point, which has this kind of wavy design. It can be bended two direction, and it is malleable but tough. And I have got a patent by this design. And also this ring dissector have the transection of this ring is like a triangle, so it is good for dissection. So I show you some example. So by bending the tip, it is easily touched to the point where you want. This round dissector make the border first, and followed by a ring dissector. The ring has a wide area, so you can push the pseudocapsule away from the normal tissue, normal gland. And this is another one. The semi-sharp dissector can cut the tiny tissue between thin wall of a craniopharyngioma and chiasm. This is an example of a normal pituitary gland. Actually, I prefer at the initial stage of the surgery, we find a border. Just after cutting the dura mater, we find a very thin normal gland, and shoot capsule. So now I'm dissecting the plane, surgical plane between shoot capsule and the normal gland. And after the compression will remove. And once you get the border, it is easy to follow them using such a kind of ring dissector, and we can remove all the tumors. So we don't be anxious about the postoperative hemorrhage. And in this case, there are no CSF leaks, so we packed with Duragen and the suture, and we use Duragen onlay and bony reconstruction and sphenoid mucosa replacement. Regarding the suture, I used to use this kind of blunt ring dissector, but I developed this kind of a heart-shaped one. It is easy to catch the one string, and it is easy to do a knot, slide a knot from outside to inside. Actually, this is the data from National Survey of Neuroendoscopic Surgical Technique. Last year, we have done this. And in Japan, we have 190 facilities which is doing endoscopic endonasal surgery. And among them, most of them are doing suturing, even Esposito Zero patient. So we are really used to do suturing. These are our series of my the bendable tools. And this is an example of a very firm tumor. And now I'm using a ring dissector. And using this rotating action, it is useful to push the tumor off the normal structure. In this case, right optic nerve was compressed, so we are dissecting tumor off the optic nerve. And we didn't have any fine forceps for a long time, so we have developed the new one. And we wanted a very fine tip, and rotatable and malleable, and many things I requested to the craftsman. And this is the first generation of a prototype. And after improvement of some prototype, finally we have developed this kind of fine forceps with a ring handle. It is malleable and rotatable. And it is useful when you make the border in the microadenoma. If you don't see the border, but you can make it by using this forceps. And it is useful, especially for this kind of craniopharyngioma, dissecting the very tiny SHA from the wall of the tumor. And this is a case of a meningioma. Actually, the SHA is running inside the tumor. So to dissect the very tiny vessel inside is really difficult. But using this fine forceps, it is feasible. It is possible to identify the vessels. We can follow this really small arteries, dissecting the artery. So finally, we could preserve this vessel. And this is the recurrent craniopharyngioma case. A tumor was hardly attaching to the right optic nerve, and visual function is deteriorating rapidly. You cannot see the border But now I'm making the border just between optic nerve and the wall of the tumor. So using these fine forceps and the dissectors, we could successfully dissect the tumor from the optic nerve. Okay, so next. The visual function improved in this case. And at the end, at last, I show you my new one, the robotic forceps. It may be better. It move inside the surgical field. It's like a robot. It's like a Da Vinci system. But it's not a Da Vinci system. It's just a tool. You can control the tip movement by moving thumb with this this one. So this is the case of the recurrent vestibular schwannoma. So inside internal meatus, I am using this robotic forceps. Usually it is difficult to go into the meatus, but it is, you can touch the tumor inside the meatus. Okay, and I show you another one. Another example. This is the recurrent choroidoma at the right posterior clinoid, and it is very small, but it was a recurrence. So we decided surgery, and by cutting the inferior 5 fissure artery, I retracted the pituitary gland and removed the tumor inside the posterior clinoid. And beyond the IC, it is usually difficult to remove because there is an IC. We have to respect the IC, not to injure. So in such a case, this tool was really effective. I'll show you how to do it. So this is, now I'm using a robotic forceps, using a 30-degree endoscope. It's like using my hand. Beyond the IC, I could catch the tiny fibrous tissues after removing the main mass. So I'm just cleaning the fibrous tissue around the tumor, which may contain the tumor cells. Okay. So, okay, thank you so much.
Next talk is by Dr. Mr. Dandapani, and he'll be talking about endoscopic management of giant pineal region tumors.
Everyone, I would like to thank Dr. Bansal for this wonderful opportunity. My talk was supposed to be in the other hall because I have to leave. I requested him to accommodate here. Thank you. So I'll be talking on endonasal endoscopy for NOS4 ICA encasement. So whenever pituitary tumors invade cavernous sinus, sometime back we had done a meta-analysis and noted that when the surgeon's experience increases in relation to cavernous sinus exploration, the likelihood of gross total resection increases like in this manner. So cavernous sinus invasion, it can be of various types, but it is possible sometimes when it uniformly expands the cavernous sinus, even with a simple approach without any kind of transpterygoid, to view with angled endoscope or even with 0-degree endoscope all the compartments of cavernous sinus. As you can see here, this is the ascending segment, this is the posterior geno, this is the horizontal segment, and this is the anterior geno. and this is the sixth nerve in the lateral compartment, and inferior, posterior compartment, superior, this is the roof, and this is posterior clinoid. So third nerve lies superiorly and laterally in the interdural space, while sixth nerve is intracavernous. So there are two kinds of cavernous sinus approaches. One is medial transcavernous, in which from medially you try to go as much as lateral as possible. So in that way, you don't get into the area where sixth nerve is there. Lateral transcavernous is when you give incision lateral to the carotid artery and you get into the cavernous sinus. So so we routinely use navigation and angled optics, and we have noted that especially that whenever cavernous sinus invasion is there, even 1 millimeter extra bony exposure, it increases the likelihood of gross total resection. And we try to give incision as laterally as possible, just medial to the cavernous carotid artery based on navigation. And the most important image to see is the parasagittal cuts, not the mid-sagittal ones, where you can see the cavernous carotid artery, and this is the inferior compartment, this is the posterior compartment, and this is the superior compartment. So based on this, we decide which compartment is predominantly involved. As you see that this is the medial transcavernous exploration, and this is the lateral transcavernous exploration. And because the space here is, this is the furthest away from the carotid artery, posterior entry is, we do as a routine as the first, and then we get into different compartments as the tumor leads. So this is a kind of, I think I'll skip these videos so that I can directly go for surgical videos. So basically we have two different types: medial exploration, lateral exploration, and antero-inferior exploration. For the antero-inferior and lateral exploration, we do tailored transpterygoid approaches. For medial exploration, we don't need. And these are the stages we routinely do. First, we remove the tumor in the cellular portion, and then in the right medial transcavernous, left medial transcavernous, then the supracellular. The reason being that getting from medial to lateral will be impeded if the supracellular portion is removed first. Sometimes the diaphragmatic descent will impede the way. So we get into the medial transcavernous compartments on both sides, and then we get into the supracellular area. Once we have done that, then we go for lateral transcavernous exploration on both sides. And the subarachnoid invasion, whenever the tumor is invading into subarachnoid space, that is the last we dissect, because that is the area where you can leave behind little bit if there is a kind of, if there are lots of vessels and there is a kind of invasion around perforators and such things. So these are the stages which we routinely do. So this is a kind of typical illustrative case of a NOS4 cavernous sinus invasion. So we routinely take a flap, and here we do a tailored transpterygoid exposure depending upon CT angiography navigation. So a wide lateral exposure is important. As you see that based on navigation, we have kind of opened up, we have that did bony exposure, all kind exposing the cavernous sinus, and we give incision in the dura in the beginning itself laterally, and the posterior portion is the safest to cross from the cellular portion into the lateral. But the anteriorly we have to be extremely careful. Here the carotid artery is very close. So you have to, this area you have to be extremely careful, but posteriorly can be so. So we make a flap, and we routinely send the dura for histopathology for grading. So once we raise the flap, and the posterior portion, the cellular portion, we start removing first, and once the cellular decompression is good, then gradually we go into the other compartments of cavernous sinus one by one, the posterior compartment, and then when we have done it here, whenever you go lateral, sixth nerve is here, so we'll have to do the, we'll have to kind of, it's, I think, have they kind of timing it for video session? Yeah. So once we kind of sixth nerve monitoring is very important, especially when we are going lateral to the cavernous carotid artery, and then gradually all the compartments can be connected. Only the tumor which is just superolateral is very difficult, Otherwise, most of the tumor can be gently curated out, and here the diaphragm, arachnoid, everything is preserved, and then we pack the area like fat, fascia, then flap. So this is the kind of outcome of this patient. So many of these tumors are functional, so we have to be very aggressive in functioning tumors. For non-functioning tumors, we can be conservative. This patient has already undergone cellular kind of portion removal somewhere else and came with us. So giant tumors, we followed a kind of staged resection sometimes, and kind of this is the kind of tumor. Sometimes the cavernous sinus is expanded, means opened up, so that all the cavities are connected. This is one of the easiest cases in which we can go around the carotid and then kind of explore and remove these tumors. So these are some of the kind of, and sometimes we, along with cavernous sinus invasion, we have subarachnoid invasion also. So I have already told that subarachnoid invasion, we have to be extremely careful under vision, and we can leave behind some portions which are stuck, especially firm fibrous tumors which are stuck to the vessels, we can leave behind, and so that we can give gamma knife kind of later on. So the main principle is whichever tumor is easily accessible in medial transcavernous, we are very aggressive. Lateral transcavernous, depending upon the consistency of the tumor and whether it is functioning or not, we can decide to leave behind and give radiosurgery later. So because of lack of time, I would like to end here. Thank you.
Thank you so much. If there are any questions for all the four previous speakers? Yes, Dr. Patel.
Just a comment for Rajesh, Professor Rajesh Chavda. Large tumors, there's one trick which I have learned from my mentor in UK, is that we preoperatively introduce a lumbar puncture, and then when I'm debug the tumor, I inject 20 ml of saline, and the whole thing easily comes down. I don't have to breach the door, I don't have to make a hole. It's a technique which works in most of my cases, and I'm very comfortable with that. Just I want to add that.
Dr. Sir.
It's a question to Dr. Samir. Excellent presentation. My question is, I mean, it was a very small mesial temporal tumor. Could we not have split the ciliary fissure and then gone medially and then removed it instead of going supracerebellar transtentorial?
Thank you so much. Even in my own department, there are three different opinions how to target this lesion, the posterior hippocampal gyrus on the dominant side in a child who's completely normal, normal cognitive, normal visual field testing. We thought about it. When I thought about getting to that tumor doing transsylvian, this will require resection of at least the hippocampus all the way into the mass. And when I looked at the FLAIR and the T2 images, I got the message that all what I need to take out of the tumor and not to go after the hippocampus and mesial temporal lobe. I felt in my hands it would be a long reach to resect the mesial temporal lobe, as well as transcortical was not an option. And I felt that transcentoral will get me to the mass, get the job done, and hopefully help with the seizures, and it worked well. No tumor recurrence, zero retraction injury, zero deficits, cognitive or visual field testing, and cured from epilepsy. Could I have done it transsylvian? Absolutely, but I felt transcentral would be better. How would you have done it, Sarah?
Well, I guess you're right, because I didn't see the full MRI images. So whatever images I saw, I thought it's coming onto the surface on the mesial temporal. But you're right, I mean, if you have to go on the dominant side through the hippocampus, and it's a tumor resection, it's not for epilepsy, so it's always better to have approach which makes you reach to the tumor rather than going from the cortical surface.
Dr. Sankla.
I think the approach which you chose is probably looks like one of those readily available approaches, and one should use it. We use it for other tumors also, all the posterior medial thalamic lesions.
Thank you. At the end of the day, it doesn't matter what we do. What matters is that we have the right team to work with. Our skills as neurosurgeons are irrelevant if we don't have the right anesthesiology team to partner with to do those cases. We're only able at our hospital to do a large volume of semi-sitting position pediatrics because we have a great anesthesia. I have a cardiologist who, when I tell them I need to do an echo and I want to do TEE during surgery, and they're available, if they're not available or anesthesia are not comfortable, then we shouldn't be doing it. But I found that supracerebellar transsartorial approach for mesial temporal pathologies is very useful. It's safe, effective, and knock on wood, we have not seen any major complications. Thank you.
And regarding the supracerebellar infratentorial approaches with the endoscopic assisted,
Yes, sir.
endoscopic control, that's what you call.
Yes, sir.
So you said like venous anatomy is the one which actually determines the outcomes at some point. Like, so quite often like the venous anatomy is not so comfortable. So how feasible is it with the endoscope that we don't have to even coagulate anything and the corridor is good? The tumor is vascular particularly.
I can tell you, every time we do supracerebellar approach, if you, with the microscope, it's like a cave, and you have a little bit light at the end of the tunnel. With the endoscope, you have beautiful view. I found it in our experience that venous anatomy, you see it better, you save it better endoscopically, and that's why I transitioned. I start the case with the microscope, then put the microscope aside, bring the endoscope, but with experience started doing them completely endoscope controlled, like in the case I showed in other cases. Thank you.
Dr. Sankla.
Dr. Dandapani, my question is, how do you manage those pituitary adenomas which are functional and obviously not infiltrating the medial wall of the cavernous sinus? How do you manage?
Sir, for functioning tumors, we tend to be a bit more aggressive in the first surgery itself. If the tumor has actually invaded into the cavernous sinus, we get into the cavernous sinus and try to remove as much as possible. Medial transcavernous, always. Lateral transcavernous, occasionally. But if the tumor is not radiologically getting into the cavernous sinus, then we only peel off the medial wall and then we stop there. So depending upon the radio.
Fine. Thanks.
Thank you so much for the discussions. I think we are end of the session. Thank you.
Okay, thank you so much, sir. Now we begin our video session, the Pixel Perfect, where precision meet innovation. So for the session, the moderators are Dr. Sanjeev Chopra, Dr. Sharad Pandey, Dr. Fuminari, and Dr. Abhay. Can you please come on the stage? Sorry. For the moderators, Dr. Sanjeev Chopra, Dr. Sharad Pandey, and Dr. Abhay. Are there any? Yes, sir. I'll add. So I'll add two more moderators, Dr. Pankaj Arora and Dr. Manish Agarwal.
Good afternoon. Hello. Good afternoon, everyone. I think we're going to start the video session now. First presenter is Dr. Ashutosh with unilateral biportal endoscopic posterior cervical foraminotomy for a calcified disc. Are we ready with the presentation?
Good afternoon, everyone. There's a question. How comfortable are we to address central cervical disc herniation with a posterior approach? I think unanimously everyone would like to address a disc which is central as well as calcified to be addressed by ACDF. But when we are doing ACDF, the problem is we are giving away something. What is it? We are giving away a motion segment, as well as there is an added cost of the implant. So good afternoon, everyone. I'm Dr. Ashutosh Kumar. I'm assistant professor at SGPGI, and I'll be discussing one of the techniques which is rapidly evolving, called as the unilateral biportal endoscopy for posterior cervical foraminotomy to address such kind of problems, and we'll discuss the feasibility as well as limitations of the technique. We had this case where it was not only complicated because of the presence of the disc, which was also calcified, but present of a conjoint nerve root that had narrowed the anatomical corridor. So this was a 45-year gentleman who had presented with right C6 radiculopathy with features of cervical compressive myelopathy due to an extradural pathology. So this was the MRI. He had a C5-C6 central disc bulge with a right paracentral disc herniation. On imaging, there was T2 hypointense signal that was suggestive of either calcification or the fibrous nature of the disc. There was no instability on dynamic X-rays. So we planned him for C5-C6 posterior cervical foraminotomy and discectomy by a unilateral biportal endoscopic technique. So this is a position where we have positioned him prone, and contrary to ACDF, here we have to position him with a neck slight flexion. This is the docking ports. It is done a little bit away from the midline, but not too away from the midline, otherwise the ports may not function. So the docking is confirmed on lateral and AP views. The very critical point is that we have to make the working port in same line as the disc level. So here we have landed onto the spinolaminal junction, and then we will work our way laterally to the V point. V point is the most important anatomical landmark in posterior cervical foraminotomy, and it is the junction of the two lamina where the facet starts. Only after this we have to proceed, and then we widen the interlaminar window by drilling the lower lip of the upper lamina. In this case, we are drilling the C5 lamina. Because it is the right side pathology, putting a Carrison upcut is difficult. So what we follow is the technique of fine drilling, wherein we drill the 3 layers of the cortex one by one. The root of the spinous process must be drilled for a contralateral access. Here, the third layer, that is the third cortical layer, the second cortical layer, it is drilled fine to expose the ligamentum flavum. Now, with the help of dissector, the ligamentum flavum can be easily detached from the undersurface of the lamina. For the whole technique of UBE, the critical understanding of the anatomy of ligamentum flavum is very important. We follow what is called as the Z sequence for exposure of the ligamentum flavum, where we work along the margin of the ligamentum flavum, starting first from the same side, then going to the contralateral side. Here the root has been drilled, and what we are seeing here is the median cleft of the ligamentum flavum, which is another important anatomical landmark for orientation. So this is called as the Z sequence. Now, working from the caudal lamina, we reflect the superficial ligamentum flavum. This is something we usually don't follow in open technique, but in endoscopy, this is very effective, because the moment we remove the superficial part of the ligamentum flavum, the working space increases significantly. Afterwards, we work along the border of the upper edge of the lower lamina, wherein we detach the lower margin of the ligamentum flavum. This is the beauty of endoscopy, where we can even see the extension of the ligamentum flavum that attaches it to the undersurface of the lamina. This is again something which we see only in endoscopy and not in open surgeries. So ligamentum flavum is completely removed, the canal is free, and then we go laterally for the exposure of the nerve root. Bleeding from the epidural venous plexus is a very important problem that is faced during UBE in these cases, and that is controlled with RF coagulation. So we worked along the axilla of the nerve root, but instead of finding the disc, we were seeing something which was rubbery and was not of the consistency of a disc. So we extended our bony exposure to the caudal pedicle, and then again we worked from caudal to cranial to find another nerve root. So this was a case which was further complicated by presence of a conjoined nerve root that significantly reduced our anatomical corridor. So in these cases, we had to modify our approach and work along the shoulder of the nerve root, and sequentially we decompressed from the cranial as well as the caudal end of the nerve root. So this allowed us to completely decompress the two nerve roots. However, as we can see, because we had to struggle with the decompression, the patient in the post-op period had some paresthesia along C6 nerve root. However, in 1 week time, it completely resolved, and the VAS scores were significantly reduced from pre-op to the post-op status. So this is the post-op MRI. Again, here we can see there is still some residual disc is there, but the patient was asymptomatic now, and on axial sections we can see the large part which was present in pre-op has gone. So this case not only highlights the feasibility of UBE in addressing these pathologies, which is quite evolving, but it also highlights the current limitations and the possibility in future that we can actually address these kinds of discs which are presently contraindications by UBE. Thank you very much.
For want of time, I think we'll not have discussion. Dr. Dandapani to present his work on endoscopy for giant pineal tumors.
Thank you. So, what is the main advantage of endoscopic for supracerebellar infratentorial? We have already heard from Professor Samir El-Baba, but I would like to show one of our illustrative case. So basically with endoscope, you can see all the tributaries of the deep veins in a single view, and you can preserve the precentral cerebellar vein. As you can see, in a single view, you get the internal cerebral vein, you get the basal veins on both sides, and then precentral cerebellar vein, all of them joining to form the vein of Galen. So this is the biggest advantage. This is one of the reports which we had published some time back. This was the first report in literature of a kind of endoscopic assisted keyhole approach for gross total resection of a giant pineal tumor. So this is the position, sitting position. I think these things has already been highlighted. So under navigation, we do a small craniotomy, and then initially we do surgery with exoscope, which is 0 degree, or you can do it with 0-degree endoscope. And incision is always given inferiorly and laterally to begin with. And if like this was a giant tumor, so we had to sacrifice the precentral cerebellar vein. And otherwise, in some cases, you can preserve. Then you do internal decompression in the center with 0-degree view. And once the central part has been decompressed, once you have enough space, then we put in angled endoscope. Once we put in angled endoscope, you can rotate the angle and see the different kind of corners. And under vision, this was a very kind of fibrous, rubbery tumor. And we had to do internal decompression, and gradually we had to dissect from all the venous structures. So because we were doing this in the angled optics, initially we keep the endoscope down and we keep the instruments on the top. Then gradually we rotate and we go to the other side, so that for looking at the right side, we keep it on the left side and turn the angle. So like that, with gradually all the veins are identified and tumor is dissected from the veins, and total removal was done. So when you see superiorly, posterior superiorly, we get into the tumor, where once the tumor is decompressed, we can see the internal cerebral veins. We have to preserve all the layers, and every vein has to be preserved. This is the most important advantage of endoscope, because you tend to look at the corners which is not otherwise visible with microscope. And you can see the tumor invading into the thalamic area, and this is the aqueductal area where kind of tumor and as well as the blood clot has been kind of sucked out. And at the end, this is the kind of, this is the, and then we, whichever area we find that there is invasion into the thalamus, we kept Surgicel, and all the veins are identified once again to make sure that everything is intact. And this is the closure. So this is the post-op end result. So this technique we have used for a wide variety of tumors, for meningiomas and for giant meningiomas, where we have removed the infratentorial portion, supratentorial small portion we gave gamma knife, and giant posterior third ventricular epidermoids, the pilocytic astrocytomas, kind of exophytic from the brainstem. So this technique is elegant and can be used for a wide variety of indications. Thank you.
So any question from the audience? Thank you. So next speaker is Dr. Bansal. Please start your presentation.
ये कौन सा लगा दिया? Good afternoon, everyone. Thank you very much for being here. And I'm presenting a very interesting case. This is a small boy. I gave the title Flopping Floor, Relieved Surgeon, Rejoicing Patient, Controlled Complications and Eventual Triumph. So the history is that 17-year young boy presented with the seizure that was temporal lobe epilepsy, and he had a mild headache. The MRI shows this is in a left medial temporal lobe lesion. It was reported as a cavernoma, but when I operated this tumor, it came out as a IHC shows that it's a WHO grade 1 low-grade glioma. So after 1 month, he started having hearing loss. The audiometry shows that he has a sensory neural hearing loss. So the MRI shows that there is an obstructive hydrocephalus and the aqueductal stenosis. There is a turbulence you can see at the aqueduct, here in the aqueduct. So I did the ETV. So the ETV was done successfully. ये आगे कैसे जाएगा? So even immediately after ETV, you can see the flopping floor, and I'm happy, and patient is also happy. So the stoma was dilated, and the ETV is completed. So the patient was conscious, otherwise conscious and relieved. He had a non-stop vomiting since after the surgery, so till morning. We gave him dexamethasone, then it stopped the vomiting. And the next morning we saw a small extradural hematoma at the site of the burr hole, in front of the burr hole. And then patient was okay. The hydrocephalus is relieved with the ETV. And after 24 hours, the CT shows no increase in the size of EDH. After 1 week, he started hearing few words, and after 1 month, his hearing is quite improved, that he can have this serviceable hearing. So finally, surgeon is happy. Thank you.
Rather too quick presentation. Questions from the house? I have one query. How do you explain the clinical symptomatology with his progression of the disease?
Our vestibular nerve and cochlear nerve are very sensitive nerves. So when there is an intracranial pressure rise, the first of all these nerves are getting involved, or like they get affected. So if you relieve the hydrocephalus, the pressure over the nerves improves. That's what my theory is. I don't know, many big people are sitting here, Dr. Barnan can tell me.
No, the question is acute ductal stenosis being detected a few days later.
Before that, in first MRI, there was only tumor, there was no acute ductal, there was no hydrocephalus.
So how do we explain that correlation?
Maybe, yes. After the surgery? Or after the ETV? Yeah, yeah. But here, no, I didn't saw. I just punctured the stoma, made the stoma, puncture the floor, and then when it starts flopping, I'm happy.
Okay, thank you so much.
Thank you.
Yeah, next presentation is by Prakash Nair. Extended endonasal dissection of large calcified craniopharyngioma.
So good evening once again to all of you. Should be showing a video of a large craniopharyngioma with calcification and vascular invasion. So technically, craniopharyngiomas in the supracella region can be challenging when they become calcified, because the calcification makes decompression of the tumor difficult, and it also tends to be very attached to the adjacent structures. And in this particular case, we show a similar case where the tumor is extremely calcified and also has attachment to the PCOM and the PCA, which makes surgical resection very difficult. And at every point of time, the surgeon has to carefully consider whether he needs to proceed or whether he needs to stop and abandon the procedure at that point of time. So we had a 30-year-old male patient who had presented to another hospital with signs of raised ICP. And that point of time, he was diagnosed to have papilledema and hydrocephalus and undergone a ventricular peritoneal shunt. He was also found to be hypothyroid and had hypercortisolism, so he was started on replacement. And he was referred to a center for definitive surgical resection. So this is the tumor. You have a large supracellular tumor extending from the upper aspect of the pituitary gland, involving the anterior aspect of the hypothalamus, the large cyst extending into the third ventricle. The tumor has a lot of T2 hypointense areas and also has a presence of extensive calcification. The tumor also extends just onto the interpeduncular space here and the prepontine space there. And on CT, you can see that the tumor is quite extensively calcified. So it's a dense, hard tumor. The endonasal anatomy itself is quite favorable. So you have a very wide and pneumatized sinus with a central septation. So we start this procedure with turbinectomy on the right side, and then we go on to harvest a very large nasoseptal flap. So to extend the corridor itself, we do a posterior ethmoidectomy, and the posterior ethmoidectomy gives us a wider view of the suprasellar area. So the nasoseptal flap that we harvest is very wide. We go onto the floor of the nose so that we get a very wide flap. And once this flap has been elevated, this is the anterior cut that we're taking. The submucopericondyal plane is found and the flap is harvested and then placed in the nasal cavity. So once this has been done, the skull base is now exposed. So we need to drill the skull base very widely and make the bone very thin and then slowly take off the bone chips using the dissector, using the upcut like a dissector, not as a rongeur itself. So you can see the optic nerve, the middle part of the optic nerve has been decompressed. You have the anterior intercavernous sinus, the IC on both sides, and the pituitary gland which has been exposed. Now the division of the anterior intercavernous sinus is the next important part. So we open both above and below the anterior intercavernous sinus. The anterior intercavernous sinus can be extremely troublesome at points of time. So you can have very significant amount of bleeding. And this is one way of getting some degree of control on the anterior intercavernous sinus. So the other way of doing it is to make a small nick anteriorly to inject surgiflow inside and then coagulate it so that you don't have a lot of difficulty after you've done this. So now the dura is being opened and then we come to encounter the tumor as such. Now opening the upper part of the diaphragm gives you a direct view of the stalk itself. Now visualizing the stalk is very important because now you know where the tumor is and what is the extent of stalk involvement. So you can see that the stalk seems to be extremely thinned out by the tumor. After the arachnoidal dissection, you can see the middle aspect of the IC on both sides. Now we go on to see where the superior hypophyseal artery is. So that's the first step. Before that, we get into the tumor and decompress it. Now, one of the things that you can see here is that even though the tumor is extremely calcified on CT, it doesn't appear to be very formidable or very hard as such. But that is just the beginning. So we go on to initially decompress it. You can either use 2 suctions or you can use a CUSA for decompression. So as the tumor gets decompressed, the peripheral dissection becomes more easy. So you can slowly start to manipulate the arachnoid away. And the technique of dissection is microsurgical dissection, where you want to preserve the microvasculature, see the microvascular anatomy, and you can see the PCOM here. So you have the PCOM and the perforators that are rising from the ICA and stuck to the walls of the tumor itself. Now we go on to further decompress the tumor. You have the chiasm here, and this is a purely retrochiasmatic tumor going posteriorly into the ventricle. Now we go towards the left side, and this is where the challenge is. So a part of the tumor here is extremely adherent to the PCOM. And this is a part that is also very densely calcified. So we'll go on to dissect this part later on. Now the tumor is slowly taken out of the third ventricle. There is a cyst extending into the third ventricle. And at all points of time, we keep decompressing it. So the tumor is dissected from the walls of the ventricle, and it is also decompressed so that the dissection is done at consistently in all planes. Now, as we go more posteriorly here, now here at this point of time, we are dissecting the tumor away from the membrane of Lilliquist. That is the inferior dissection. One can appreciate the membrane of Lilliquist there. And once again, because it's a hard tumor, because there is calcification, we carry on. Now the tumor posteriorly is much more calcified compared to the part that we saw anteriorly. And so technical difficulties are much more significant. I'll just finish this in another minute. So one can now see the PCOM there. This is the calcified part that is extending between the chiasm and the third ventricle. And this is a part where you can injure the lateral part, that is the medial nuclei of the third ventricle. So once again, this is a pile dissection being done, and the small cyst that is extending into the ventricle is slowly delivered down. So you can see the cyst that is, so you have a pile plane against the third ventricle which can be identified and then divided slowly. And in this manner, that cyst and the cyst capsule that extends into the ventricle can be slowly delivered out. So once this is done, the third ventricle itself is free. And now you have the tumor that is located on the more inferior part that we have to now deal with. So that is the difficult part here. So as we dissect on the lateral part, this is the part that I had shown earlier where there is some degree of invasion of PCOM. So you can see the PCOM here, and the PCOM goes and melds into the tumor itself. So from the proximal part, you can see the basilar bifurcation here. So the basilar bifurcation here, the PCA here. And as we bring the dissection anteriorly, we are able to see the part where it is very tightly attached. So the dissection, so you can see this part, which is where the attachment is very tight. Now here, the surgeon has to now consider whether to leave a part of the tumor on the vessel itself and then leave the residue and send the patient for RT, or attempt, as I did in this case, to slowly dissect the tumor. So the technique here is to not to dissect on the wall itself, but to start by dissecting the arachnoid slightly far away. So once the arachnoid is trimmed, you can try to attempt and slowly peel the tumor away from the vessel itself. This would be the same technique that I would follow when I'm doing a microsurgical resection. And here I'm using the tip of the scissor to slowly dissect it away, and then the dissector to remove the tumor from the vessel. And in this manner, the entire calcified tumor has been dissected and removed. So you can see the third ventricular floor. These are the mammillary bodies. This is the bifurcation. You can see the superior cerebellar artery and the third nerve on that side. And then the reconstruction is carried out using the gasket seal technique with 3 layers, multiple layers and a graft. So this is at the end of the section. This is the MRI done at 3 months. Shows good resection, preservation of the mammillary body. This is the shunt without any presence of hydrocephalus. Intact walls of the ventricle. And at 3 years, the patient does not have any recurrence. So this is to compare the pre-op large calcified tumor and the post-operative cavity. Thank you so much.
Thank you. So we are behind the schedule. Next speaker will be the Sampada Orchid. Sorry. Here.
She'll be talking on endoscopic transnasal bilateral optic nerve decompression for fibrous dysplasia. Over to you.
Good afternoon, everyone. I'm presenting on craniofacial fibrous dysplasia with bilateral optic nerve decompression. Our patient is a 17-year-old female with complaints of bifrontal headache for 2 months, blurring of vision with reduced color brightness and nasal congestion. And on examination, she had visual acuity with finger counting at 5 feet bilaterally with temporal visual field defects, bilateral optic pallor, and mild left-proptosis. She also had, on imaging, she had, we can see, diffuse craniofacial bone expansion, ground glass appearance with lytic lesion, bilateral optic canal narrowing, and because of which she had progressive visual deterioration secondary to the nerve compression. She underwent endoscopic transnasal transsphenoid approach with bilateral optic nerve decompression. Here, bilaterally, the nasal cavities are decongested, and right inferior turbinate is lateralized and middle turbinectomy is done. The right superior turbinate mucosa is debrided. The right maxillary antrostomy is done, and middle wall of the maxilla is debrided and mucosectomy is done. The maxillary sinus is opened here with its posterior wall which is exposed, and adult flap is being raised. Now the posterior septostomy was done, and unique compartment of nasal cavity was achieved. The drilling was continued bilaterally till because there is concha sella and there is no pneumatization of the sphenoid sinus. So the drilling was continued bilaterally till the medial wall of the orbit was exposed. It was also extended medially, bilaterally, posteriorly, and superiorly to expose the optic nerve sheath. As we can see, this needed extensive drilling to see the endoscopic landmarks. The right medial wall of the right orbit has been exposed to expose the right nerve sheath on the right side. And the drilling is continued in the midline and towards the left side as well. The drilling of the anterior cranial fossa, skull base, and we actually are removing a strip of bone along the optic nerve and the chiasma to achieve the decompression of bilateral optic nerve. And it is continued on the left side towards the lateral wall of the left orbit. This was done under neuronavigation guidance to achieve the reconstruction of the bony landmarks. So here we can see the bony strip in the midline has been removed. The dura over the chiasma has been exposed, and bilaterally the optic nerve have been decompressed. There was an inadvertent grade 2 CSF leak noted over the left optic nerve. Which was later taken care of. This is showing exposure of the bilateral optic nerve and the dura, and extensive drilling is still continued. The hemostasis was achieved, and the dural defect which is there was plugged with the thigh fat, augmented with the fascia on the right side, and as well as the Hadad flap reconstruction was done. And later it was augmented with glue and gel foam. This 17-year-old lady with polyostotic craniofacial fibrous dysplasia with bilateral optic canal stenosis underwent endoscopic transnasal transsphenoid approach and bilateral optic nerve decompression. And post-operatively, she had subjective visual improvement. And post-operatively for 6 months, she's been on follow-up, and she's shown significant visual improvement. The histopathology was also suggestive of fibro-osseous lesion and presence of woven bone. Thank you.
Thank you. One or two comments from the house?
Could we have done VEP for this patient, and was it done?
VF was done. Patient was cooperative.
Post-operatively, how will objectively find out the patient?
Objectively, post-operatively, after the recovery, we will ask for VAVF again and fundoscopy examination. And immediately, just subjective improvement on hand movement or finger counting. Yes. Yes, sir.
What was the plan for fibrous dysplasia? At times they bleed a lot. What was the plan for that? Okay, thank you.
Thank you.
No, thank you very much. The next speaker is Dr. Paspala, the laser in cranial endoscopy.
Good afternoon, everyone. Before he opens up my presentation,
I would like to ask one question to the audience. How many times you saw the tumor on intraventricular tumor on endoscope and got frustrated that you are not able to remove it totally? Can you raise your hands? Yeah, how many people got frustrated when you see the tumor beautifully in the endoscope, intraventricular tumor, and you are not able to remove it totally? Yeah, I get frustrated a lot. So that's why I was always trying to look for a tool which will help us in removing these tumors. If you look at the history, it was in 1917 the concept of laser came into practice, but it took almost more than 50 years for the utilization in neurosurgery, particularly for the ventricular surgery, and even for ETV. So basically, like the laser has the energy which is delivered to the chromophore. Most of the energy gets absorbed on the surface, like almost 90%, and 10% gets absorbed at the depth. And it has photochemical, photothermal, photoablative, and photomechanical effects to remove the tumor. Of all the types of lasers available in the market, thulium evolved as a gold standard for medical practice, particularly for neurosurgery, based on main two characters. One is the depth of penetration, which is around 0.2 millimeters, and flexibility of this probe for the utilization in the ventricle. This is one patient who is 43 years old lady, presented with episodic headache, vomitings, and giddiness, and blurred vision since last 3 weeks. This is the pre-op MRI, which is showing a small tumor in the posterior third ventricle here. And this is the endoscopic procedure. I did the endoscopic third ventriculostomy first, and you can see the tumor, which is beautifully looking here. I took a biopsy from that tumor, and then I tried to took out the tumor with a small feeding tube by aspirating the tumor, which was not at all satisfactory. Probably when we had no laser, probably we just ended up removing some more tumor, and based on the histopathology, we might have gone for radiation and chemotherapy, and probably ended up with a shunt in the ventricle. But here you can see beautifully how the laser is helping us in removing the tumor. See that blue tip? It is like ablating the tumor and evaporating the tumor. And using this laser, I did almost the gross total resection of this tumor. And we can even see the aqueduct at the end of the removal of the tumor. And this is the post-op scan here. I left one a reservoir in the third ventricle here, the tip of the reservoir. And the hydrocephalus is not there. And this turned out to be an ependymoma, grade 3 ependymoma. And this is another case, a 28 years old male patient. He had headache, giddiness, and CSF rhinorrhea. And he was operated elsewhere with an endoscopic third ventriculostomy and a reservoir replacement. But he came back with the same symptomatology after 1 year of the previous procedure. Then I operated on him. This is the pre-op scan. Here there is a perimesencephalic cyst which is projecting into the ventricle here. And this is the endoscopic procedure what I did. I did a left-sided parietal burr hole and put in the endoscope. You can see the tip of the reservoir in the ventricle. Here. And this is the cyst which is projecting into the ventricle here. And you can see that the cyst wall is very tough here. I just wanted to show how tough is the cyst wall. I tried to puncture it with a needle. Like I was not very confident because you may come across some vascular structure on the opposite side of that wall. So then I tried with the Fogarty catheter. It was very tough. We were not able to negotiate. And then I brought in the laser. And even with the laser probe, I tried to just poke into that cyst wall. It was very tough. We were not able to puncture that cyst wall. Then I delivered the laser energy to puncture the cyst wall and made a small opening, and then tried to look what is there on the other side of that tough wall. I just enlarged that opening. I tried to enlarge that opening with the Fogarty, not very successful. Then I enlarged that opening. After seeing what is there on the opposite side, then I just enlarged that opening, and as much of the cyst wall I could remove, I removed the cyst wall. And this is the post-op scan here. The cyst is decompressed, and to be on safe side, because he has come with recurrent symptomatology, I left a shunt on the right side. This is the last case.
I think, we've run out of time.
Yeah, just 1 minute. This is the last case. This is a 72-year-old male patient. He came with a cyst in the ventricle. You can see the cyst in the ventricle here. And with a parietal burr hole, I kept the endoscope, and we just made opening in the cyst wall and tried to shrink the cyst into the ventricle. And went on making a small openings and then connecting all those openings, and then tried to remove the cyst as much as possible. You can see that the cyst is shrinking slowly, and you can see that the wall is getting evaporated. So definitely this procedure, even though the success rates are, I'll just go to the last slide. See, even though the success rates are not very different compared to endoscopic procedures without laser, definitely it will be a technical advantage for perforating tough membranes, even in whether it is a cyst wall or the floor of the third ventricle. And in the intraventricular tumors, the frustration of the surgeon will be addressed definitely with the advent of the laser. And the gross total removals, even the total removals of the intraventricular tumors was phenomenally better when laser was assisted with the endoscope technique. Thank you.
Thank you. In your second case, did you not consider, because of previous procedure, it was a looking compensated multiloculated kind of hydrocephalus?
No, it was not multiloculated. There was only one cyst. There was only one particular cyst.
But previous procedures could have led to that kind of picture.
No, he had that cyst even in the previous imageology.
Thank you so much. We go to the next presenter. Yogesh Gupta is here. Yeah. Yogesh Gupta will be presenting his work on unilateral biportal endoscopic spine surgery, the modern evolution of conventional spine techniques.
इसके पहले वाला होगा, इससे पहले वाला होगा, ये नहीं है। योगेश गुप्ता ना, ये योगेश सावरकर है। हाँ, इसमें जैसे आगे कैसे बढ़ेगा ये, ऑटोमेटिक चलेगा। हाँ, यहाँ से ठीक है। ना बैक बहुत इसी से होगा। Good evening, everyone. Today I am presenting a case. This is a female patient, 36-year-old, complaining of severe low back pain. Pain is radiating in her right lower limb. She is suffering for last 1 year with this pain. All conservative measures are failed. After clinical assessment and MRI, paralysis spine was done. That's suggestive of L5S1 downward migrated disc, which compressing S1 right side traversing nerve root. We discussed with the family all the available surgical techniques like the microdiscectomy and biportal endoscopic discectomy. Then we opt the option of the UV surgery for this L5S1 downward migrated disc. This is an advanced technique, comparatively low morbidity as compared to microdiscectomy. This is a new technique. This is the MRI of the patient which suggestive of L5S1 extruded disc, then migrated in L5S1 and compressing the S1 right side nerve root. This axial picture shows compressing the right side S1 nerve root compression with inferiorly migrated disc material. Position of patient is the prone, same as in microdiscectomy. Use the craniotomy trap to avoid spillage of the saline in the theater. Marking of the port is very important in UV surgery. In this technique, because this is the right side disc, I have three options. Surgeon stood on the left side of the patient, make a port either on the left side of the spinous process or either on the left side of the spinous process. Third one option is the right-sided UV. These are the three methods. I opt second option, where I stood on the left side of the patient and make the portal on the left side of the spinous process. This is the marking of this process. This is a midline at the spinous process. Then marking of the pedicle of the L5 and S1 at the these are the two transverse lines which intersect the medial pedicular line. This is our port making site. It's on the left side of the patient. Sorry, right side of the patient. After making an incision, fascia cut in the cruciate manner. Then put a serial dilator and make a triangulation at the L5S1 spinolamellar junction. Confirm the triangulation in AP view of the C-arm. Then put a serial dilator and dilate making a working portal. Incision is around 7 to 8 mm for working portal, and for endoscopic portal, incision size is around 4 to 5 mm. After triangulation confirmation, we put a endoscope. This is a RF probe. We use clean the soft tissue dissection from the lamina and expose the L5 lamina with spinolamellar junction and spinofasciate junction. After cleaning of the all soft tissue, drilling of the lower border of the L5 lamina with the spinal drill. It performed, then cutting the laminotomy performed with the Carrison punch. Upper limit of the laminotomy is the cranial attachment of the ligamentum flavum. This is our cranial extension of the laminotomy. When ligament flavum is free from lamina, flavotomy done in piecemeal manner. After our endoscope put inside the ligamentum flavum, which causes the hydrodissection. It causes the pushing the dura ventrally and create a plane between the ligamentum flavum and dura mater. Remove the complete ligament flavum in a piecemeal manner, and we can see dural thecal sac is visible. After removing the ligament flavum, you can see here is the S1 root is visible. This is the S1 root, S1 nerve root, traversing nerve root. This is the thecal sac. Migrated disc material is present in the axilla of the right side S1 nerve root. This picture shows clearly this is the S1 nerve root. Little bit ligamentum flavotomy done over the S1 nerve root. Then we try to remove the disc material from the shoulder of the S1 nerve root, but it's not performed. So remove the disc material from the axilla of the S1 nerve root with the help of nerve hook and ring curate. Retrieve the disc material successfully. After removal of the disc material, nerve root become completely free, mobile, and it's looking and red and hot. Remaining disc material, free disc material removed from L5S1 disc space. After completing this, hemostasis achieved with the RF probe and our surgery is complete. The as compared to microdiscectomy, UB is the latest technique which causes to preserve all the posterior element like supraspinous ligament, interspinous ligament. As compared to it's a future technique as compared to in these cases like one-sided discectomy. Even UB is now perform the T-lift surgery also with this technique, with 2-hole technique. Thank you. Thank you very much.
Thank you for a beautiful video. So we are behind the schedule, so we have to go to the next speaker. So our final speaker in this session is the Yogesh Sarkar. I extended the endoscopic endonasal contralateral approach to orbital tumor.
लेजर पॉइंटर चालू करते हैं ओके ठीक इसे इसको
Good afternoon, respected faculty members and delegates. Thanks, Bansal sir and the organizing team. I will be talking on extended endoscopic endonasal contralateral approach to the orbital tumor. As neurosurgeons, we know the dictum that cranium is a pathway to the orbit and vice versa, which can be demonstrated by these figures that orbitocranial approaches, some orbitolateral orbitotomies or medial conjunctival or medial orbitotomies can lead into the cranial compartment. Whereas secondly, we have cranioorbital approaches in which lateral craniotomies, Styrian craniotomies, frontotemporal craniotomies, osteotomies, and supraorbital craniotomies can lead to the orbital compartments. We have a very fantastic model of round-the-clock approach as published in Journal of Neurosurgery. It's a UK publication in which the orbit is divided in a clock from 6 o'clock to 1 o'clock. We can approach with a lateral microorbitotomies and frontotemporal craniotomies and cycotic osteotomies, whereas 1 o'clock to 6 o'clock can be approached with an endoscopic approach or a medial conjunctival, transconjunctival approach. So the medial orbit can be approached by a contralateral nose through the penetration of ethmoidal lamina papricia, and it relies on the medial rectus and the inferior rectus corridor, whereas the ipsilateral inferior orbit can be approached by the ipsilateral inferior approach to the maxillary antrum in between the inferior rectus and lateral rectus muscle corridor. So these are various orbital pathologies. For the want of time, we will just keep it. They are classified as intrachronal and extrachronal various pathologies. We will just go on to the case. I had a case of 35-year-old male patient with unilateral gradual vision loss with proptosis. Since 2 years, only perception of light was present in the right side. Then CT scan of orbit, axial cuts, coronal cuts showing the tumor almost occupying the orbit. I have not put the T2 scan. It was almost iso-intense on the T2 scan. So firstly, a uninostril approach was done. A medial turbinectomy was done. Bulla ethmoidalis, hiatus semilunaris was identified. Ethmoidal air cells were identified and debridement was done. Just medial to this, that is the lamina papricia and the orbital wall. So further debridement of the ethmoidal air cells were done. So medial or orbital wall was identified and opened gradually. So that is the periorbita wall identification and opening the periorbital fat. We can see it was gradually dissected off with dissectors, hooks, and a grayish tumor was identified. That is the rectus muscle which we have retracted. So posterior septostomy was done for having a binostril approach, and it was enlarged to have a binostril forehand technique. The scope came from the opposite nostril, and we could use both the nostrils for manipulation. The retraction of the medial rectus muscle was done superiorly. Tumor capsule was coagulated, identified and opened. Gradual piecemeal decompression of the tumor was done. We had used CUSA for debulking of this tumor gradually. It was little fibrous on fibrous side, so that CUSA was not very useful actually. So we had to do blunt dissection of the margins. Ideally, the CUSA should be a main tool in this cases. So blunt dissections of the margins was done. Piecemeal decompression of the tumor was done gradually, and so optic, at the end of the surgery, there was optic nerve identification, and some part of the tumor we have kept over the optic nerve. Almost near total excision of the tumor was done. This was the optic nerve. So further hemostasis was achieved, and and the nasal packing was done. So there was almost a near total removal of the tumor, and patient post-op had mild improvement in vision, but had developed medial rectus palsy, which was further treated with steroids. The problem of the medial rectus palsy was that the medial rectus, nerve to the medial rectus from the inferior division is very small, and it mostly have a neuropraxia during the surgery. Histopathology was surprising. It was a transitional meningioma, and the conclusion and take-home message of this case is endonasal endoscopic approach is a robust approach for medial orbital tumors. Detailed study of imaging and relevant anatomy is essential. Uninostril approach followed by a binostril approach can be used for complete exploration. It requires highly coordinated effort between the ENT surgeon and the neurosurgeon. Final goal is the maximum tumor clearance, and endpoint of the surgery is optic nerve decompression. These are my references. Thank you very much.
Thank you. Thank you for good presentation. Any comment from the audience? Professor Singh from Japan, you are the top neurosurgeon in orbital tumor in Japan, so please have any comment or something.
Thank you very much. Nice presentation.
Thank
I just have one concern about the manipulation of the optic nerve, because some tumor is very adherent to the optic nerve. In that case, we usually use a very sharp dissection, like scissors, micro scissors, or the very sharp dissector. In that case, how do you manage the tumor when the tumor is strongly adherent to stick to the optic nerve?
So we try to take out the tumor in piecemeal, slowly and slowly, achieving hemostasis gradually. And CUSA was also used for the gradual decompression. So the point where we identified the optic nerve, we tried to delineate it from the further tumor. Hardly any tumor was left. So rather than progressing further and achieving a gross total removal, we said that it is better that he has already lost his vision, but only PL was there. But if he had dissected more, there was a chance of injury to the optic nerve. So that's what there was. That's what the end point of the dissection was there. So we decided not to proceed. We could have proceeded, as you say, with a fine dissecting sharp scissor. It was a very good option to dissect it off from the optic nerve, but it was almost a complete near total excision, sir.
Yeah, I agree. I think the most important thing is the preservation of optic function. Thank you very much.
Thank you, sir.
So thank you very much. So we conclude this section. Thank you very much.
Thank you so much, the moderators and the speakers. Now it's time for engaging panel discussion. So our panelists are Dr. Jayesh, Dr. Anand, Dr. Prakash Nair, Dr. Ashish, and Dr. Masha. Yeah, sorry.
बाहर ही पड़ा है, डेस्कटॉप पे ही पड़ा है, मैंने डेस्कटॉप पे दे दिया था। 426 में है ना? नहीं, that is 450. डेस्कटॉप पे जाओ, एक बार डेस्कटॉप पे जाओ। ये रहा पैनल। Yeah.
Good afternoon, everyone. So I know it's been a long day, and till so far, I mean, all the scientific program has been phenomenal. And now Bansal sir told me to prepare 3-4 case scenarios which we usually encounter in our routine practices for pituitary tumors, residual lesions, and recurrent lesions. So around 3-4 scenarios we'll discuss one by one, and we have our expert panels over here. My friend Dr. Jayesh, Dr. Nand, Dr. Prakash, and Dr. Masha. So we'll start with the first case scenario. Okay, so this is a 50-year-old male who came with vision loss since 1 year with headache. He had a bitemporal field defect initially. He underwent transsphenoidal surgery in 2022 outside. The post-radiology was not available. Patients showed that there was vision subjectively improved after surgery. The final biopsy report in the report has shown to be pituitary adenoma at that time, but it was not prevalent at that point of time. The K67 was 2%. Patient was doing fine till 6 months when patient had complaints of again visual deterioration. The right side vision was 6/36 and the left was 6/60. Patient was having tunnel vision. There was signal tunnel vision. The prolactin level was 150 nanograms per ml. This is the radiology at present. A 55-year-old male. At that point, he was 51-year-old. So radiology is showing. Can we have that pointer? Can we have pointer? Four years. So patient doesn't have an interval radiology. Now patient has come with deteriorating vision. Okay. So this is the radiology, which is of course showing large cellular supracellular lesion, which is going up to the lateral ventricles, pushing the A2 above, and there is multi-septations as well as multilobulated. So I would like to start with Anand sir. Sir, what would be your opinion? So we'll start with cabergoline. Is a possibility one, as prolactin is 150 nanograms per ml. But do you think it's prolactinoma? Do you think you will go for redo TNTRS, transsphenoidal surgery again, or you will go for a transcranial approach? So I would like your opinion, sir.
From the level that is seen, I don't think it's a prolactinoma. It looks
Yeah.
more like stock effect.
Agree. Yes.
It's eminently resectable from a transsphenoidal approach, and I think I'll go for a transsphenoidal resection again, and probably the intraventricular, the highest part, is probably encircling. We are not sure with all the images, but that may be the only difficult part. But I think it will descend down with more and more resection. If required, I'll use introp imaging, like introp MRI, to know how much is descended down and how much I have to chase. But definitely, I think redo transsphenoidal is indicated. Lateral extension is not much. Usually, superior extents come down.
Okay, sir. So this bottleneck around here, sir, would you think that you require extended approach? Would you like to remove some part of the plenum as well?
Yes, I think extended approach, drilling out the plenum will give us more space even to go upwards and go a little posteriorly. So
Okay,
anteriorly, to do a little more bone work will be prudent.
Okay, and so this part of the lobule which we are approaching near to the lateral ventricle going up to. So do you think that this approach will be able to descend it down with the scope of transsphenoidal surgery?
It usually descends down if you
Okay.
remove the central core of the tumor. And
Okay.
the intraventricular, the CSF itself pushes it down.
Okay.
So it's not very difficult unless it is invaded and it is invasive. It
Okay.
has just gone through the foramen. I think it will come down easily through the foramen.
Okay, sir. Thank you. Dr. Prakash, sir, what's your opinion about it? Do you agree with sir's point?
I anticipate, so surgically, first, if it is possible, you will get a review of the biopsy.
Yeah.
Because we also do transcription factors. So it's very important to see what lineage it is, whether it is T-PIT, PIT1. But for this tumor, immediately, yes, surgery will be needed. Prolactin also, repeated prolactin in dilution, because sometimes what happens is
agree.
the prolactin value that you get is not in dilution.
Agree.
So prolactin in dilution sometimes might be very high. So once those things have been taken care of, plan for surgery, endonasal surgery, yes, but two caveats. One is I would prefer to place an EVD for this patient at the beginning of the procedure. The second is I'll keep supraorbital incision always available in case I need transcranial access. There are other centers where they might plan for a combined approach. This is in case you're not able to tackle the part that is very high up. One cause of concern is that the posterior aspect of the ACOM complex is involved. This is the part from which you have perforators that arise and supply the diencephalon. And that is also the part that causes the maximum number of cognitive and neurological dysfunction in patients while being operated. So that is the point which has to be done in a very careful manner. Strokes can happen, especially perforated retrain.
Okay. So, Masha, your opinion about it. So, what if you do a prolactin dilution? So, what levels do you think that is the level that beyond which you would like to start cabergoline, or below which you think it's just a stock effect?
I think the most important thing is, this is large tumor, so it is very difficult to remove one time. So how we mix the staged surgery, plan the staged surgery. And if I do this surgery, first I go the transsphenoidary, then we remove only the sphenoid part, not go into the pituitary part, or not touch the cavernous sinus part. Then second surgery is going to the transcortical transventricular, and the 1/3 of the part which is exposed in the ventricle is removed. And third surgery, maybe we have to go the combined surgery from the sphenoid sinus and also the transventricular. And because if we touch the component in the pituitary gland and the pituitary cellular part, and also simultaneously touch the cavernous sinus part, which broke the venous drainage of the tumor venous drainage, so that caused the massive hemorrhage. So in my opinion, I think we should separate the surgical procedure little by little. Then the last one must be the largest one.
Okay. Dr. Jayesh, your take on it?
So if you see here, it's a residual plus recurrence, we can say. So it's a very large, we can say it's a giant tumor. There are three possibilities that after surgery, if you do transsphenoidal, if you could not come out with a complete resection, the residual tumor will end up with the hemorrhage, and that will be a big mess, number one. Number two, if you try to decompress the midline, of course the ICA is separate, but it's a recurrence. There is a chance of invasion of medial wall of ICA. There is a chance of ICA injury, chance of optic nerve injury as well, and the cross CSF leak. So practically, if I go with the terminal approach, very well versed from right side, I can open. That is the only approach in which you can go up to the ventricle. You can remove the tumor well. You can remove the tumor wall from the sphenoid sinus, and I would say I would decompress both the optic nerve and the vision very well. So I would prefer in this the terminal.
Okay, thank you. Yes, sir. So, Mr. You would like to give some comment on it?
There are many ways to bell a cat, right?
Yes,
and this is a perfect example of that. Another caveat is, don't forget, this tumor has been attempted by some other surgeon.
Yes, sir.
Never underestimate that surgeon. And he has left with this massive tumor again. So, and the third caveat is that if you go from below first, there are chances, high chances, at least in my hands, that I will be leaving a big residue there, leading up to a post-operative pituitary apoplexy and subsequent fatal outcome of my patient. So in my opinion, my approach would have been to take out from the top first, maximally debulk it, maximally decompress or remove it as much as I can, for two reasons. Because if I am able to do so, the chances of apoplexy will be approximately nil. There will be no residual tumor probably
if I go from the top first. And then the sphenoidal component can be taken out anytime as a staged surgery. So this is the best and the safest approach in my hands. Having said this, it depends on the expertise of the surgeon. If he is able to take it from down, go ahead. But it has to be sure, 101%, that there should be no room for leaving the tumor with subsequent pituitary post-op apoplexy.
Thank you, sir. Thank you, sir. So though we as a unit are a big fan of transsphenoidal surgery, but considering that the surgeon has attempted outside already, so we went ahead for transcranial surgery in this case, and we could get away with the tumor excision in this case. It came out to be PITNET 1, K67 was 4%, and IHC was negative for all markers. The patient is doing well. Okay, so we'll put a second scenario.
How did you remove the nasal part from transcranial?
Sir, I mean the interoptic space, it was a post-fixed chiasm. So we could find an interoptic space was wide, so we could get away with the tumor from that side.
There's a lot of tumor in the sinus, sphenoid sinus.
Yes, sir. The follow-up radiology is yet to come, but I think we'll review a radiology.
Not showing the sinus.
Sir, the tumor at the top was suckable, but as sir said, that it was attempted initially, the deeper part was really hard. So we really had to core in, but because of the wide interoptic space, we could get away with that. Probably otherwise, not have been able to do that. And this follow-up MRI is still waited. I mean, at 3 months, we'll do it. Okay, so second case scenario I would like to hear. So 51-year male came with progressive vision loss. The right side was 6/36, and the left side was 6/9. Again, TNTS was attempted in 2018. Came out to be pituitary adenoma. PITNET was not reported that time. KSXM was 3%, IRC was negative. Follow-up scans were clear, and vision was 6/9 bilaterally. Patient was doing well till the last follow-up. Patient came to us with a follow-up of deterioration of vision for the past 6 months. Right side was 6/36 and left was a 6/39. And patient was U hormone. So we could see a lesion here, which is encircling the ICA, slightly going up to the Sylvan cistern, and there is a small nodule going separately. So the lesion is on the side with pushing up of the stalk. Patient is relatively vision down for the past 6 months. So what approach you would like to have, sir? I would like to ask for your opinion. So will you plan to redo transsphenoidal surgery? Will you go in for a transcranial surgery in this? Will you go for a gamma knife or for an observation? I would like to start on Prakash sir first.
I think prior to deciding on this, one important factor is to see what type of optic visual deterioration he's having.
Okay, sorry for that. Patient was having a right-sided temporal feedback, left was fine. And the first scan was clear. It's a clear-cut recurrent disease. And there's a new onset vision deficit, along with the right-side temporal field defect.
More on the right side.
More on the right side.
Any evidence of any optic atrophy or?
There is no evidence of optic atrophy at present. Patient is relatively able to do all his routine work. But yes, he is having a significant deterioration of vision from 6/9 to 6/13 within a span of 6 months.
In view of the fact that he has progressive worsening of vision, and it is not a prolactinoma.
This is not a prolactinoma. IHC markers were negative for all markers, and there is patient is U hormonal.
Go ahead with a reroutine case.
So any different approach you would choose, sir? Standard transsphenoidal surgery or anything like to explore transsphenoidal, transcavernous as well, you think? Yes. It is slightly encircling the IC as well. It's NOS 3B, I guess.
So there is a part which is going beyond the cavernous sinus. This is what is called the oculomotor tracking. So this is the nerve going into the tumor going into the cistern along the path of the third nerve. Since he has a non-functioning tumor with intact, vision is good and the aim is to preserve vision, I will not chase that part. The aim would be to decompress the chiasm and the optic nerve very nicely.
Okay, and if there's some residual disease left, then would you go in for an observation or for a gamma knife? If at all, after second surgery, you have like 5 to 10% of the tumor left.
Narrow this, if there's the high-risk PITNET, that is silent corticotop tumor, right cell adenoma, crook cell tumor,
atypical,
or lactotrope adenoma in males, or
or K67 more than 4%, yeah, 3%. Okay, okay. Dr. Masha, yeah, please.
In my case, in my opinion, I think I also recommend the patient redo transnasal surgery, transsphenoidal surgery. Then, if the tumor is very strongly adherent to the surrounding structure like optic nerve or so, maybe we can let it leave it, and maybe we just observe if his vision is improved or not. And after surgery, after that, maybe we prescribe the conventional fractionated radiotherapy, not the gamma knife, because it's much more soft than the gamma knife surgery, I think.
Okay. Dr. Jesh, you would like to comment upon?
So it is a recurrent tumor. So in recurrent tumor, three things is important. So one is location by nose. If it is recurrent, which if it is nose 3 and 4, so relatively inaccessible, not for every surgeon, right? It's relatively inaccessible. Second is behavior. It is rapidly progressive. You see, it's in couple of years, it's progress again, it's compressing the vision.
Yes.
Biopsy is also important. If you see Ki67 is more than 3%, and the chances of progression is again high down the line of 4 and 5 years, and the patient is young. What I suggest, I would go for again transsphenoidal, remove the relatively as possible as the cavernous, not cavernous, but cellar part, relatively cavernous part, that part which is in cavernous sinus. The same setting I would go for gamma knife if biopsy shows somebody, more
Atypical
aggressive
disease.
disease. There are two factors, I gone through the literature, and there are two factors. One is if Ki67 is more than 3% and P53 is positive, there is a very high chance that there will be very aggressive tumor in future, whether it is a functional or non-functional.
Okay. Anand sir, your take on it, sir. So even if K67 is around like 5% supposedly, and remove the tumor totally, still you would like to go for a gamma knife therapy, or you would like to wait and repeat a scan after some point of time?
After total resection?
Yeah.
No, after total resection, I wouldn't consider.
The K67 is 6% supposedly. So will you, approach the patient differently?
Do a repeat scan and then follow, close follow-up.
Closer follow-up than the treatment. Okay. And if there is small residual, and
if
the
there is
K67
residue,
is...
definitely this is a recurrent tumor, so I wouldn't like to wait.
Okay.
I would definitely go for a SRT, not a gamma knife.
Okay.
Fractionated SRT.
Fractionated one. Thank you. Okay, so we did a repeat transsphenoidal surgery and patient is doing well.
Point that a lot of radiation oncologists mention over and over. When we plan RT immediately after surgery, the gross total volume is normally calculated around the existing tumor.
Yeah.
When it is done on follow-up, that is, for example, at progression maybe at 1 year, then it is only done for the enhancing residual, which means that the GTV is often much smaller and the radiation dose can be planned.
Fractionated and reduced.
So there is always, for pituitary tumors, there is always some benefit of waiting for some time before initiating radiation. So slightly different from the other.
Okay. I'd also like to consider the function, other hormonal function. If the patient is having hormone status and not on replacements, and if there is hardly any residual tumor, I would prefer to wait a bit.
Okay.
Because otherwise,
Okay.
you will definitely be making the patient go for hypopituitary.
Okay, sir. Right. Thank you. So we did a transsphenoidal surgery. The patient is doing well. It came out to be pituitary adenoma with K67 of 3%. Patient is doing fine. Okay, this is a case of a 50-year female who came with features suggestive of acromegaly, acral enlargement, hands, prognathism. The growth hormone was 50 nanogram per ml and IGF-1 was 985 nanogram per ml. So we did a transsphenoidal surgery, midline transcavernous approach. Impression was gross total section and intraoperatively. Post-op, there was remission, growth hormone level reduced to 0.63 nanogram per ml and IGF level reduced to 101 nanogram. Patient was doing fine, but after 1 year, patient came with ptosis of the right eye and with third nerve palsy. Vision on the right side was 6/36 and left was 6/9. The growth hormone repeat came out to be 50 nanogram per ml with IGF levels of 800 nanograms per ml. So what is the plan? So we'll go for redo transcavernous approach. Will we go for transpterygoid approach? Will we go in for GKRS? Or will we go for midline subtotal followed by a GKRS? Or any other approach you would like to have? Would like to start with Dr. Masha first.
I think the tumor is rapidly increasing, the recur. So first thing, we at least require the histological verification, like changing to the aggressive nature. So anyway, if I do the surgery, I think I do the transsphenoidal surgery again. And I think we do not need the transpterygoid because the tumor is not very far from the lateral margin of the internal carotid artery. So if we open the anterior wall of the cavernous sinus, we can directly see the tumor component, lateral tumor component.
But sir, will you think this part of the tumor you will be able to remove from a midline approach?
Yeah, I think so. Because, you know, that is the anterior compartment, inferior compartment of the cavernous sinus, so which means we can directly see, just open at the entrance of the sphenoid sinus, we can directly see that, I think.
Okay, Dr. Jayesh, your take on it? So, would you go
functional recurrence
Yeah.
definitely requires a multimodal therapy rather than choosing one.
Yeah.
So I would do midline plus transpterygoid. I would not able to completely resect the cavernous, I'm very much sure. Some part left, patient will again end up with little bit increase in the growth hormone. So based on the post of MRI, would take a call of gamma knife in the same sitting because it's the acromegaly functional.
Same sitting, I mean in the same admission?
Same, means post-op.
Okay.
And we'll put on somatostatin analog. It's a very good result in post-op recurrence acromegaly. So it's a multimodal treatment.
Okay, okay. Anand sir, your take on it.
What's the time difference between the two?
1 year, sir. 1 year. 1 year.
Quite
Patient has
short.
come after 1 year. I have
Very
chosen some
short.
little aggressive
Another
tumors.
comment on the cure. The first time I don't think it was a real cure, though it was less than one.
So
Lot of
IGF
controversy
at 12
there.
weeks were like
Yeah, there's a lot of controversy there.
Okay, sir.
Less than 0.2 to be absolute, or if you're in doubt, if you see the images closely, did you go back and see the images closely? Was there a cavernous?
Yes, sir, we
component?
saw
Because
that. There was,
recurrence is-
because, sir, see, why we didn't, because the growth hormone came less than 1. I mean, and OGDT we consider to be less than 0.4. That's what we follow.
Suppressed value of less than 4.
Yeah.
And age
Yes.
adjusted normalization of IGF.
But IGF at 12 weeks, I mean, according to the age, was below normal. That's what we thought.
But with growth hormone, sometimes they
It's a
will go
pulsatile
into
manner,
ovulation
yes.
afterwards, and within 6 months, their value will start.
Yes, agree. So what you would, sir, answer?
Yeah, so as he said, we'll go for transphenoidal. for
There's
sure.
no doubt.
We
What
do-
approach you will choose, sir?
And
Midline
I
task
feel-
cavernous,
I feel-
task,
I
or
feel the inferior
transpterygoid?
compartment will come out, most probably. And post-operatively, definitely this is going to require
Additional therapies for that. Prakash, sir, you're same, or transpterygoid you would like to?
Components. There's one component in the cavernous sinus, there's one supercellular component. And you can see the middle wall, which is, there. I will try to do as radical excision as possible. Do a transpterygoid resection.
Because this
And,
part, I would still skeptical that whether you will be able to.
Primarily because while it is likely that most of the tumor might come out with a midline approach, the inferiormost aspect where you have the genu of the eyes, below that,
Even this one.
there. So that
And this
is
one, yeah.
that is the part where the tumor is behind the vertical segment.
Yeah.
It's always easier to mobilize it if you are able to drill that much more bone.
Yeah.
So that is the reason why I think a transpterygoid on that side will be useful.
So we perform the transpterygoid approach in this, and but I mean there was post-op residual enhancement here, and the growth hormone has not been normalized yet. So we plan to give a gamma knife therapy to this patient. That is what it is. So last case scenario I would like to, which is very practical scenario. This is a patient has not come out to normal, so it is 5, and IGF is still high. So we plan to give gamma knife to this patient. That is what the plan is.
Second interesting question is, when you give gamma knife, what will you target?
That is a problem, sir. Of course, we'll add on to the deficit, sir. I think we'll give to the left side lean, enhancing lean. That's the only thing which we can add on. Otherwise, we'll add on to. So 55-year male came with vision loss and ataxia. Patient had vision of right side only, hand movement close to face, with left side of 6/36. Patient was U hormonal after correction. I mean, patient was hypothyroid and hypocortisolic. Patient had significant ataxia and hydrocephalus, so VP shunt was placed outside. There was effort to us with this. Transfemoral surgery was done. Patient intraoperatively tumor was soft, suckable, but anterior small part was not reachable. So patient was doing fine in the postoperative period, but the post-op scan showed a residual tumor bleed in the superior part as well as anteriorly, with increase in the hydrocephalus. So what is your likely plan in this? Well, we'll do a redo surgery in this. This is the day 3 scan, same as day 1 scan. If redo surgery, then by what approach? Transsphenoidal or transcranial. This is immediate post-op. Patient is doing same. Patient is conscious. There is increase in hydrocephalus. You can see again. We'll show you the scan again. In the pre-op scan, you can see. Sorry, Yes, the right side shunt was placed outside. The right side ventricle is compressed, but left was still enlarged. But in the postoperative period, there is tumor bed hematoma, as well as there is hydrocephalus increase on the both sides. Patient is clinically stable till day 4. Today is day 4 actually. Patient is still in the ward. Okay, so what approach you will choose? We'll do a redo surgery by transsphenoidal approach or transcranial approach. If by transcranial, then what approach? Transsylvian or interhemispheric? You'll do a VP shunt and wait, or you will just observe for both. Anand, your take.
I think this is post-operative only CT. So if I want to do anything, I would still want to have an MRI contrast to see how much is blood and how much is real tumor.
Okay.
I feel most of it is looking like blood. I would wait. I would not rush for doing anything as long as patient is asymptomatic. If there is visual deterioration or patient has raised ICP issues because of hydrocephalus, then I would really rethink my strategy, do MRI, see where the problem is coming from, and then try to adapt.
So the right side ventricle was chinked, I mean compressed. Now it has come up again. So if at all you would like to do a shunt, on which side you would like to go for? You would like to revise the right side, or you put a left side shunt? Biventricular shunt, I mean. Because there's a foramen of mono blockage, I mean. That's the point which is there.
I don't know whether the shunt is functioning, the original shunt.
Yeah, probably the blood has blocked it.
Yeah. So if we can remove the clot which is blocking the foramen Monroe, because if you actually see, the extent of the clot is higher than the extent of the pre-op tumor. There seems to have been some bleeding within the ventricle which is blocking. So I would even plan maybe an endoscopic clot removal if it is all clot, and if the path is open and foramen Monroe is open, I will leave it alone. He may not even need a shunt.
So you will go for a redo TSS only, so transphenoidal surgery only?
If that is the cause of
if
problem.
patient is deteriorating.
Just for relieving the hydrocephalus. I wouldn't be worried too much about the pituitary. I think we'll revisit it after a 3-month scan or a 6 months.
Okay. Now, Jayesh, what is your?
So the bleeding is inside the capsule, right?
Yeah.
Because there is no intraventricular hemorrhage. So very less likely that there is an intraventricular hemorrhage. Whatever happens, it is inside the tumor. So very difficult to say how much tumor has been removed. So it means still there must be some optic deterioration. Not possible that there is a residual tumor, it's bled, and optic vision is okay. Very less likely. So more likely that vision either deteriorate the same day or on next couple of 1 or 2 days, then definitely I would go again same, because if there is a hemorrhage in the tumor, everything is, I would go with the terrenal approach, will exercise complete.
Okay. Prakash sir, what's supposingly this patient deteriorates, okay, I will give another scenario. With this kind of lesion, patient is deteriorating, so what we'll do now?
One caveat for these patients is when they deteriorate very rapidly. Very rapidly.
Yeah, that's what.
I have seen that happen. So
exactly.
I think
particularly day 3 and 4.
Size, definitely go for an EVD upfront. And
EVD.
then wait and watch. And if the patient gets sick further, re-explore the patient, go in transventricular.
Transsphenoidals. Transcranial. So what transsylvian or interhemispheric, sir? What approach you will choose in this? Interhemispheric. Not much what's your take on this? Okay.
I think in this situation, the patient have 2 problems. One in the residual tumor, it causes a hemorrhage. And then the second problem is the blockage of the CSF pathway. So if we do the residual tumor, I think the quantity of the volume of the residual tumor is not big. So most of the mass is consisted of the hematome. So I think this is the ideal case of transventricular surgery. So go into the ventricle, then remove the residual tumor.
You mean transcortical transventricular or interhemispheric?
Yes, transcortical
transcortical transventricular.
Then
okay.
I think that we can see that there is little hematoma inside the subventricle. So if after the removal, we open we put the septostomy, then we verify the opening of the foramen Monroe, and I think that also simultaneously resolve the CSF problem.
Would like to keep a EVD postoperatively after doing a transcranial no, not required. Okay, sir. Avdesh sir, your take on it.
I completely agree with Dr. Masaharu Shin.
this tumor now can be addressed very well with transcranial, precoronal keyhole, as well as endoscopic excision, transcardiac approach. You will encounter the tumor, you can take out the hematoma as well as the tumor, decompress the Perron-Monroe, and the problem will be solved.
Okay, sir. Thank you, sir. With this we conclude the session because the time is already up. And
What did you do?
sir, we are waiting. We're just waiting. This is done 3 days back, actually. Patient is doing well at this point. This is day 3 scan as well. So, yeah, that's what we are. Okay, sir. I agree to that, sir. I mean, the post-op apoplexy patients really, when they deteriorate, then they don't give time. We have burnt our hands as well. So, yeah, we have done a shunt as of now. So this is the, I didn't put the scan, sorry. We'll wait because patient was slightly drowsy. So we to put patient is extubated, is doing fine. Today is post-op day 4. That's what it is.
When in doubt, better to take it out.
Yeah, agree, sir, agree. Yeah, we will put a left side shunt. Sir. We put on the left side. The right side shunt was able to put on left side shunt. That's what we have done. Since it's a contained hematoma, as Dr. Jayesh has told, so that's what we have, because there's still air for that. That's why we kept waiting. But of course, I think we are keeping a low threshold. But as Sarah said, waking up at 4 a.m. in the morning, it's better to. EVD. Yeah, okay. Done. Thank you. Thank you.
What an engaging and insightful discussion.
So many perspectives. It felt like multiple neural pathways connecting beautifully.
And thankfully, no conflicts. Just smooth synaptic transmission.
Now, it's time for a quick break, in which we'll do some fun exercises. After all, like our brain, even our body needs some serotonin jolts.
अब थोड़ा OPD से OT तक वाली practice कर लेते हैं.
सबसे पहले नेक रोल करेंगे. ओके, अब सबको साथ में करना है बिकॉज दिस नीड्स टू बी एंगेजिंग. अगर हम अकेले करेंगे तो इट्स नॉट गोना वर्क. ओके, इन 3, 2, 1.
Now we'll do shoulder rolls just to release our stress. Roll your shoulders. Change your direction, opposite direction.
Next, we're going to stretch our arms. पहले ऊपर, back, side, back.
Next is plenum 7, extended endonasal, do more from less.
Moderated by Dr. Jaskaran, Dr. N.C. Punia, Dr. Masahiro Shin, and Dr. Sushant Sahu. This plenum is going to be 13 plus 2 minutes each. First of all, we have Dr. Bhagat Singh.
Dr. Bhagat Singh will tell interactive MRI for complication avoidance in the extended endonasal approach for pituitary skull-based giant invasive tumors. Dr. Bhagat Singh.
Good evening to everybody. Respected chairperson, first of all, I thank Professor Bansal and the organizing team of the NEUROENDCON 2026 for this opportunity. I am Dr. Bhagat Singh from Madurai. My topic is avoidance of complications in the pituitary surgery. Exactly, the very easy for me. Previous discussions about the recurrent tumor. My focus more, all the stages have the complications. There is no surgery without complication and pituitary surgery also. So my topic is very easy, as recurrent tumor discussed very elaborately by the previous discussions. So my topic is about use of intraoperative MRI. I don't have intraoperative suit, but I shift the patient and do the MRI intraoperatively and find out any residual tumor and re-go and remove the tumor. I did it for a couple of cases. I go ahead with the avoidance of complications of pituitary surgery. So these are all the approaches, transsphenoidal, transcranial, various approaches are there. I have total of 250 plus and more than 200 endoscopic cases. So this is what the pituitary is exactly located, surrounding by the rich vascular system for internal carotid artery and cavernous sinus, optic nerve, and all important structures are there. Anything injured, the final outcome and result of the surgery cannot be established as assured to the patient before surgery. So these are all the standard approach. Binostril forehand technique is a standard approach. Nowadays for the extended endoscopic, most of them are binostril forehand technique. So all phases, nasal phase, sphenoidal phase, cellular phase, and pituitary and cavernous phase and skull base reconstruction after the resection are all have the own complications. My focused on the pituitary tumor phase and cavernous phase that deal with the tumor resection and avoidance of complication in that. So these are all the steps. So anatomic structures encountered, that is a very important. All the complications are related to the distorted anatomy or difficulty in understanding the anatomy and removal of the tumor from the exposure, tumor removal and basal reconstruction. So these are bony landmarks, nasal, sphenoidal and cellular, and what are all the structures surrounding it. So turbinates, very important. So the enlargement of the turbinate causes some hindrance in the passage of endoscope, and nasal septum and cribriform plate, iatrogenic injury to the cribriform plate during the endoscopic approach caused postoperatively, and these are all the structures. Sphenoid sinus, care should be taken during the dissection. The branch of the spinopalatine artery cross the inferior border, used to keep the instrument inferior and medial for the dissection. So sphenoid ostium, landmarks. So these are all things. I skip this video. Cellular floor. After the nasal and sphenoid phase, we entered in the cellular floor and the landmarks. So in normal size cella, the cavernous carotid arteries are separated 13 mm to 17 mm, and medial extent of the ICA and lateral surface of the pituitary gland are separated very close, and it is less than 2 mm. The meninges cavernous dura indistinguishable from cellular dura, and transition is reliable. The liability to recognize this and transition vascular injury, both cavernous sinus and ICA can happen. So skip this video, normal video. So non-invasive pituitary macroadenoma, our aim of the surgery is to remove the tumor with all corridors and routes with successful remission. So in the morning, as is sure is told, the endoscopic resection up to 80% remission. So still there is a chance for 20% leaving the tumor or any form of hindrance to avoid the total removal of the tumor. The skull base repair is very important to avoid the postoperative complications. The giant and pituitary adenomas, I concerned about the skull base anatomy. The location is a transsphenoidal approach, the epicenter and all structures related to it. These are all discussed by the previous speakers, and basic is the cadaveric dissection. There is no other way. We have to learn this technique through the continuous learning of cadaveric dissection. So again, pituitary adenomas, 5 to 14% of all pituitary adenomas, the size more than 40 mm in any direction, less than 6 mm from the foramen of Monroe and more than 30 mm above the tuberculum cellae, multi-directional spread more than one directions, and 40 mm from the midpoint of the jugum sphenoid. These are all the definition for the giant pituitary. And giant pituitary adenoma, why there is a need for surgery, crash total or near total cytoreduction, life-saving, vision-saving, pituitary and hypothalamic saving. All speakers agreed. The subtotal resection lead to the life-threatening postoperative complication of apoplexy. So the complete tumor removal should be the aim in non-functioning adenomas. Invasive pituitary adenoma, invasive to the cavernous sinus, bone and sphenoid. The invasiveness does not include the supracellular extension, MRI-based classification. Cavernous sinus inversion in 22% of all pituitary adenomas, 60% in gained adenomas, and 33% in acromegaly functioning tumor, 21% in prolactinomas, and 12% in Cushing tumor. So classification on the radiology, NASP grading, and this is the ideal classification, the Goel classification. Grade 1 confined within the dura, and grade 2 transgression of the medial wall of the cavernous sinus. Grade 3 is a elevation of the superior wall of the cavernous sinus, and grade 4 is a supradiaphragmatic and subarachnoid extension. So it include both giant as well as invasive. Only classification that shows both giant and invasiveness is Goel classification. The invasive pituitary adenoma, cavernous sinus extension cytoreduction, the better results with the gamma knife. The last discussion are clearly shows what are all the use of various techniques. These kind of tumors, some are observed, some are go for surgery, some are through the transnasal and transcranial as well as the gamma knife. And these 4 options are there. So definitely there will be a complication. There is a need to care to avoid this complication. Better results with the medical therapy in functional tumors and relief of the severe headache. The extended endonasal approach. So these are all the surgical steps. So exposure is very important, and reaching the cavernous sinus tumor removal are very important in giant tumors. So navigation is useful in the early cases. Injury to the ICA optic nerve that will affect the outcome of the surgery, and cavernous sinus invasion by the tumor, and without removing the tumor, the postoperative remission, the remission can't occur. The recurrence lead to the further complications and difficulty in the recurrent surgeries. So the dural opening, there are some of the tumors we operated. These are without navigation and intraoperative MRI. In the early time we operated. So to avoid the complications, these are all the tools: intraoperative CM, intraoperative CT, intraoperative MRI, intraoperative ultrasound in the form of carotid Doppler, and intraoperative MRI is useful, as well as intraoperative ICG to find out the vascular structures intraoperatively. So these are ideal thing. I don't have this kind of MRI are now planned in existing newly coming hospitals. So this is one of the tumor, giant pituitary tumor. I go through it. This is an intraoperative video. It shows when you're doing intraoperatively, we cannot confirm with total removal. So when the bloody field and the tumor consistency is very good and not easy to come up, so we have difficulty in confirming the total removal of the tumor intraoperatively. So this kind of gain tumor, when we are not sure about the total removal, and we are subjecting this patient to, this is what we do. When nasal packing is done, the patient is shifted to the MRI. We informed in the previous day about that case, and we need the intraoperative MRI. The MRI should be ready, and no cases are posted for more than 4 hours during that surgery, and we shifted the patient there. And after doing MRI, the patient is shifted to OT. So this is intraoperative MRI, shows some residual along with capsule. So we go ahead again, and the tumor was removed. The remaining part of the tumor is removed. This is the intraoperative MRI. So again another tumor. This after the intraoperative MRI, we removed the tumor and removed tumor totally, and we are happy with intraoperative tumor removal when using this intraoperative MRI is used. So again the intraoperative ICG is useful. Initially I did 50 cases, initially used to preserve the posterior pituitary, but that is not possible because of the bloody field and not able to find out the normal gland from that abnormal tumor tissue, and residual tumor somewhat it is helpful, and the identification of the tumor, especially the functioning tumor, it is very useful, and also identification of the vascular anatomy very clearly we can identify, and tumor invasion of the dural structures are nicely identified. So these are all some of the tips of the resection. So nasoseptal flap, that is very important. Postoperative leak is there that lead to the various kind of complications in up to meningitis and mortality and morbidity. So skull base repair with fasciolata, hadad flap, as well as the fat in the empty space, and gel foam and surgi gel is packed over the flap with glue and other things. So my experience, so these are all complications. So we have a CSF leak in around 21 cases. The vascular injury up to now 10 cases. Most of them we have a vascular shoot. We shift the patient to angio, and then according to that, based on that, we can manage it. Most of them we are able to manage, and other complications also. So even the continuous advancement in the technology and skill development, their gross total removal or the rate, most of the series of gained and invasive are not %. All the phases had a complications, and these pituitary tumor surgeries are not predictable, and functional tumors to be removed in total for the best cure. Postoperative endocrinopathies are visible, variable, still not able to predict. The meticulous skull base repair is definitely decrease the CSF leak and its complication, and epidural lumbar drain is a crucial handle and care without additional complications. So thank you for the opportunity. So to avoid the complication, all sort of available techniques as well as gadgets are used to avoid this complication in the pituitary surgery. Thank you.
Thank you very much. Then, because of time, we move to the next presenter, Prof. Professor Kosaka Amano, but Dr. Dwarakan Srinivas is, are you there? No, he's not there. So, Professor Kosaka Amano, please start your lecture. The comprehensive strategy for preventing CSF leakage in transsphenoidal surgery. As the previous speaker said, the CSF leak is still a matter of problem, so please start the lecture.
Thank you, Chairman. My topic is leakage. Everyone knows TSS was once abandoned, out of use because of the complications. We must know such a historical background, and we must accomplish the no complication. So there is these 8 major complications during after TSS, and CS leakage is most important. And Dr. Silik reported USA surveys, and they showed the running cap in complication of TSS. And I also reviewed 10 years ago complication of transsphenoidal surgery, and national survey demonstrated average only nearly 4% CS leakage occurred. Now I tried so many methods to prevent CS leakage because my mentor was so tough and scold me. So I established these 8 strategies to repair the cell tower care. And my policy is no lumbar drainage because I have 2 experience. One patient become arachnoid meningitis and walking disturbance, and one patient vomit blood because of the stressive state. So in children, it is difficult to keep in bed 1 week or 10 days. So I don't like lumbar drainage. So these 3 are key to repair the cell floor. Maybe nobody experienced CS leakage after open surgery because we suture the dura watertightly, replace the bone flap, and suture the skin. Why not you do same in TSS? So my policy, same procedure as in open surgery. First, suturing technique. Its purpose is promoting a union of the dura, making a tension to the dura, and if we can, watertight closure. But most important thing is it become a practice. Of course, its procedure is so difficult, so tough in a narrow and deep corridor. But if you can suture in TSS, you can do everything to dissect the tumor from surrounding structure, preserve the SHA. It becomes easy if you can suture. So I recommend. And after stitches, there is another problem to deliver the knot smoothly to the cell and tighten the knot firmly. So we developed this instrument, knot tightener, like this. Longer arm is same function as a pointing finger. So like this, it is easily tighten the knot. And I also consider how to open, how to inside the dura, and how to close. And traditionally, we used this close incision, but I tried so many ways how to open the dura, and I reached H-shaped. After that, some Japanese neurosurgeon reported this paper, calculate using calculus. So incidentally, my method, H-shape, is shortest length of incision. That means a small gap. So I recommend H-shaped. And after change to the optimized incision, there was no shear leakage increasing. And like this, H-shaped and other straight, combined Y and up-down T-shaped, sideways Y-shaped, we tried. And mainly we use the H-shaped. And extended surgery, we use the combined Y and upside-down T-shaped. And during surgery, we do dural tenting using a 6-0 nylon. It has a functional and strategic significance because to widely open the dural window and ensure clear view of the interior and supracell region. Second, to prevent the dural flap from fluttering and interfering with the procedures. And third, is most important, it becomes a round mark. When we use the angled 45, 70 degrees endoscope, it is difficult, but thread become a round mark. And particularly in situation involving massive bleeding, at the time we become panic. But if I can detect the round mark of anatomical structure, we become relaxed. So that this case, dumbbell-shaped, non-functional adenoma, H-shaped is like this, very useful. And small tumor and rotoclef shift, we don't need to open widely, so Y-shaped and straight incision is enough. However, extended surgery, we need a Y-shape and the reverse T-shape is best. So the first vertical line I made, and if I reach the level of the chiasm, we made a Y-shaped. And cerebral reconstruction using rigid buttress, I think it's important too. It prevents delayed shear leakage due to the pressure of shear pulsation. So the autologous bone is ideal, and 3 months later, we need a drill to open the cellar. And if the window is wide, and we need 3 and 4 and 4 pieces of a septal bone, and like a puzzle, we reconstruct the cellar. And everyone knows gasket sealed is an ideal method using a rigid batteries. And I reported maybe nearly accepted. We use these instrument materials to make a rigid reconstruction, and we started it 2007, and we realized rigid reconstruction prevents shear leakage, and mainly use autologous bone more than 90%. And like this extended surgery, this is a spherical cell meningioma opened widely, and the drill was so small amount, but stitches 2 or 3 is enough if you use the fat. And after water closure, and this case 2 pieces of bone used, one wedged into the bone, but outside of dura. And after the surgery like this, cellar floor was constructed. So after using a rigid reconstruction, shear leakage reduced from 2.9% to 0.47%. But however, recently we removed the tumor aggressively, so the grade 3 shear leakage occurred more than previous group. Pedicle flap. Everybody use nasal septal flap. I don't like it. I seldom use, because it changed the anatomical structure in nostril. Patient complained something uncomfortable after the surgery. We routinely use the sphenosinus mucosal flap. It just peel off the mucosa from the cellar floor and just replace again, not change the structures, anatomical structures. So I recommend these procedures. And like this, some cases use relocation of the sphenosinus mucosa, but mostly they peel off and replace again. And the most important thing, this is the best way to, as a pedicle flap, it promotes the natural healing process. Maybe 1 week or 10 days later, it adheres to the cellar floor. So I recommend these procedures. So representative case, this is a craniopharyngioma, opened widely, and suture the dura with fat, and the septal bone wedged outside of dura, inside of bone, and tapping the using suction and not move, we confirmed. And the sphenosinus mucosa flap covered the windows, and it fixed this case using a fat, and this is an integrin packed and compressed, and using a fibrin glue, and finished operation. So shear leakage, it's most important complication. Recent our case is less than 0.5, and extend TSS 0%, because I take a break after the tumor removal. Extended TSS, we exhausted. So keep going on the shear repair is so difficult. So take a break and restart another new surgery, shear repair. I think that's important. So what will you do if shear leakage occurs after TSS? No lumbar drainage. Immediate repair is best for the patient and us, because lumbar drainage, I said, it was a torture for the patient. 1 week, 10 weeks, bedridden is a torture for the patient. And also, such a patient in the hospital, every morning I become depressive. So immediately repair is the best way for the patient and for us. So to prevent shear leakage, determine how shear leaks, and use appropriate multiple method as open surgery. complete prevention of CS leakage enable radical tumor resection. Some doctors said, oh, we don't need suture. Some doctors said, oh, we don't need rigid restructuring. But they do all things in open surgery. Why not do in TSS? And God make a bone in the cell floor. It's usual prompt method to repair CS leakage. Thank you for attention.
Thank you very much, Dr. Amar. I just have a question, and is the suturing technique is difficult for every neurosurgeon? How do you think?
Difficult, but fundamentally, all neurosurgeons have a good hand. So if they trained, maybe everybody can do that.
I just want to have the same question to Professor Jaiswal. I just want to have the same question. How do you think the suturing technique, is that difficult or not?
In the last week of January, I visited 7 days with Dr. Masaro Sen, and then I especially went to learn suturing. And I believe that suturing is extremely important. All those people who are interested in doing endonasal endoscopic surgery are extended approaches. They should learn it. It's not difficult, but you have passion to learn it. And if you learn it, definitely I believe that CSF leg will be minimized and maybe even 0%. Thank you.
I think the suturing is actually first time difficult, you feel difficult, but if you practice only a few days or only 10 times, 15 times, you can surely master it. So, thank you very much.
And I often talk about the other Asian country. European people cannot, but we Asian people has good hand. So I recommend these procedures.
I think
Thank
if
you.
they practice, they can surely do that. Thank you very much.
Thank you, Professor Kashiku. Now I invite Dr. Riju Nita Gupta. She will speak on optic nerve sheath fenestration in idiopathic intracranial hypertension.
Thank you, chairpersons. And I thank Dr. Bansal also for the invite. So I'll be speaking too much of pituitary than craniopharyngiomas, so this topic is a little different. So this is my tertiary care institute, PGI, Chandigarh. So we get all these idiopathic intracranial hypertension cases from neurology OPD and neurology ward. So we do optic nerve sheath fenestration as a last rescue procedure when it gets exhausted with other procedures and other medications. So as I know, all of us know that idiopathic intracranial hypertension, they develop sometimes blurring of vision, they come with that, decreased vision and loss of vision, and 50% of those are there. So out of those, 10% they have pronounced visual field as well as visual acuity defects. So various treatment modalities, as we know, they are there. And like weight reduction, identification, withdrawal of various associated medications, diuretics, steroids, repeated lumbar punctures, then VPS, VP shunting, and last of all, the patient comes with us for the optic nerve sheath fenestration. So what is the mechanism behind of IH is raised ICT, which leads to increased optic nerve sheath edema, which in turn leads to increased pressure on the optic nerves, and perioptic CSF, when it gets filled up, it leads to visual blurring. So ONSF, it is useful endonasal, endoscopic, we do optic nerve sheath fenestration, which reduces the pressure on the optic nerves and reduces nerve sheath edema. And usually when the patient comes to us, they are always investigated from the opthal department, from neurology department. So we see the visual fields, VEP and MRI. You can see the optic nerve sheath, perioptic streaking, and you can see the partial or complete empty sella. So when patient comes to us, we have to get the CT scan to get a good guide Like patient is having deviated nasal septum, large concha bullosa, and where is the intersphenoid septum attached? So that is important, as in this case, I had to do the right side optic nerve sheath fenestration, but this sinus is attached to the carotid artery, ICA. So if I had to do this, I have to go posterior superiorly. Septectomy has to be done and open both the sphenoid sinuses, and then I can approach this optic nerve, because both optic nerves are in the left side of the sphenoid os. So there were 3 patients. I have done around 42 patients, in which 3 patients had the situation like this, and I always would like to operate on the worst eye, from where the loss of vision is more. So that is important to see. And here's the same patient having concha bullosa, in which lateral laminectomy has been done to have the good exposure. And as we do that, I always would like to do the middle metal antrostomy after doing uncinectomy, good uncinectomy, so that when I'm using the endoscope on the left, it's the left side I'm operating upon, so my endoscope and instrumentation should be good. So middle metal antrostomy is important. And one more thing is that you can see the inferior orbital rim nicely, and you can go above that. So after decongesting nicely the sphenoid os, so I'm using the Stamberger punch, so to widen the sphenoid os. After widening the sphenoid os, we have to see the skeletonize the lamina praeparatio. So after taking out the superior turbinate by coablation, you go for the posterior ethmoids. So after skeletonizing the posterior ethmoids, so you should have all good instruments with you. Otherwise, don't go for the optic nerve sheath fenestration. The rhinologists and skull-base surgeons, I'm specifically talking about all type of Kerrison punch, through-cut instruments, drill, because you have to drill the optic tubercle. So after doing this, you go ahead with removing the optic tubercle and all, and go ahead straight away on the optic nerve. First open the posterior ethmoid and then the orbital apex area. So after exposing the orbital apex area, then you go ahead, look for the optic nerve, which is posterior superiorly situated laterally. So you can see that I had elevated the thing, but there was still a big optic tubercle, so I had to drill it out. And all types of Freer's instruments, Stapes curette I use many times for the bones, and those should be there to elevate. So now you get the optic nerve. You should have good pointed knife, sickle knife, so that you just enter and then rotate it, so that there should not be any injury to the optic nerve, because patient is having the good vision otherwise. It's not complete loss of vision, it's just blurring of vision. So by any means, you should avoid injury to the nerve and complete all the layers, so that to get good egress of the CSF leak, you should avoid going towards the skull base area. So open it nicely. Earlier we used to do the 2 horizontal incisions, but with the time I just do opening this window and turn the edges superiorly and inferiorly, so that they don't get opposed later on post-op. And this should, this is another patient in which there was different anatomy. We had a large ONOD cell. So it's just for the sake, like we should read radiology nicely, so that we see the optic nerve where it is, and we deal with the situation of anatomy accordingly. So it was a thick tubercle, which was not managed by any chisel, anything, and we need to have sinus drill for that. And whenever you're taking out the mucosa, you just remove it from the optic nerve area and put a saline Adeline gauze and just elevate it from there, so you have a good vision and it doesn't come in your way every time. And cut it nicely in that area so that it doesn't come in your window space. So after elevating, drilling, and then elevating with the good Freers, you should judge that whenever you are elevating, you should not have crude, when you have the crude and thick periosteum elevator, when you should have a a fine elevator. And you can see the radio opaque yellowish scene. Here you should stop. This is skull base. So there's another patient. Sorry. So what we have observed over a period of time, that left side optic nerve sheath fenestration is easier to do because the curve of the instruments is like that. In left hand you hold the endoscope and your curve of the instruments is like this. So this is the right side. It was a bit difficult for me, what I observed, because your endoscope is on right side and your working of the instruments is like this towards the optic nerve. So drilling is difficult. You have to have a good exposure in that area, do the good middle metal antrostomy, and of course middle turbinate is not to be resected. So after thinning out again, the instrument has to be, you should see the tip of your sickle knife so that not to injure the optic nerve. So many people, they go for the bilateral optic nerve fenestrations, but I don't recommend. I do unilateral mononostril, worst one, and we have good results. The other eye also gets better when you operate and the next day patient says, "Dusri aankh se bhi acha dikh raha hai." So that is amazing because patients sometimes doesn't realize that it's not seen from the other side. So another video showing, this was my third or fourth patient, I think. Not a very good video because taken from the mobile. Earlier we used to make 2 horizontal incisions and take out some part of the sheath so that it's not get adhered. And we have a good window. So as I was going extreme medially, so after taking out this, I went more towards the skull base, and there's a gush of CSF at the time. So this is the area where you can't do repair also nicely. So I had a call, I called up my neurosurgeon and in the OT, and we put the lumbar drain in this, and there was no post-op leak at the time, and no repair was required. So we do 2 studies. One was a pilot study to assess the visual improvement after endoscopic ONSF in IAH with impaired visions, to evaluate the clinical symptoms and visual outcome, and to measure the optic nerve sheath diameter by transorbital ultrasonography, preoperatively and postoperatively. So this postoperatively we used to do just 2 hours, within 2 hours when the patient comes out, and we get the excellent results postoperatively. We had 10 patients already worked up, and what ONSF was done in these patients. Ultrasonography was done at pre-op, post-op 0 day, and 15 days, and 30 days. So immediate post-op was very good, but then it gets stagnant after 15, 30 days, and 3 months. So early presentation of these patients are, we have to judge that when this patient requires optic nerve sheath fenestration, so it should be done at the same, at that point of time, so that we get the good results. So what we saw was 80% patients were relieved of the headache, and we got reduced papillary edema around 30 days post-op, and significant improvement of vision was seen just post-op, then at 3 months, and it got stagnant at 30 days post-op. Median hospital stay was less. Contrary to Orchid, who operated severely visually damaged patients in our study, there were statistically improvement results were seen, but the proper patient selection and early intervention is the key for the successful results. And Gupta et al. Also did IH in pediatric age group and got good improvement in those patients. Unilateral ONSF significantly decreases the grade of papilledema in both ipsilateral and contralateral, so we don't recommend bilateral optic nerve sheath fenestrations. So Nityanand et al., these were ophthalmologists, and medial transconjunctival approach they did for ONSF and found various complications. They described pupillary atony, medial rectus muscle injury, CRAO even. Others could not explain plausible mechanism for improvement in headache and bilateral vision, and some showed that it's a placebo effect. Few showed excessive scarring, fibrosis, and fat adhesion. So there was a study in 2020 by SGPGI also done ONSF in 9 patients who had undergone optic nerve decompression with durotomy, and 2 patients. In 1 patient there was a CSF leak and drain was put, and 1 patient, although they didn't have meningitis, and visual acuity was decreased in those patients. And they recommended bilateral optic nerve sheath, optic nerve decompression with durotomy, but we were happy with the unilateral one. So this study said that ONSF is a promising surgery. Again, duration of symptoms are important. In 2 patients, there was worse vision and CVT cases in which the vision loss is complete. So in those cases, the prognosis is poor. And, we took it as a good predictor or marker when we see the intraoperative CSF drainage, egress of CSF and optic nerve sheath diameter reduced by transorbital ultrasonography. So there was another study we did, quality of life in IH patients who had undergone endoscopic endonasal optic nerve sheath fenestration. Group 1, 40 patients were medically treated, and 9 patients we did ONSF, in which we had these questionnaires were done. And what we observed, we did OCTA also in these cases, and there were improvement in visual acuity, and papillae edema also was found reduced. In various general health, general visions, ocular pain, all these parameters were also found better in post-op cases than the pre-op ones. GCL thickness and RNFL mean thickness was found to be decreased, and percentage of peripapillary density had positive correlation with the GCL thickness, we found that, and negative correlation with papillae edema and RNFL thickness. So what lessons we learned? That left ONSF is definitely easier to do than the right for the right-handed surgeon. Always gear up with the radiology. Good radiology, you should know about the orbit, posterior ethmoids, ONOD cells, sphenoid sinus size, pneumatization, placement of optic nerves, Delano classification, all these to be learned nicely. And always ready with all these instruments, and so that you don't get stuck up in the intraoperatively. Then intraoperative palpation of the orbit medially is called Stankiewicz sign, what we do, keep on doing in FES, so that we see that where we are, and that also helps. Then posterior superior septectomy and binostril approaches we did in 3 patients, as I said, so we were comfortable doing that. And we recommend, of course, the mononostril approach in most of the cases, but bilateral mononostril ONSF, but not bilateral. I haven't done bilateral in any of my case. And always go for the worst side. Don't think that we will operate on the other eye, egress of CSF will happen. I always go for the worst eye. And of course, multidisciplinary team is important. Neurology, ophthalmology, neurosurgery, rhinology, skull base, interventional radiologist, all should sit together and decide what is to be done for that patient at the same time. Thank you so much.
Thank you very much. Okay, because of time, we move to the next presentation. Right. Dr. Vernon Verhoeven, the title is Extended Approach to Cellular Lesion.
Thank you, Vansal, for the kind invite. Very good conference, very good attendance. Thank you, chairpersons. Can you change my presence? So I'll be talking on the extended approach. I think we had done all these dissections in the cadaveric course, and I'd like to show you also some difficult cases and some difficult situations where sometimes every day is not your day. As a surgeon, there are days when everything goes wrong, and those are the days which are most challenging. So I want to show you the real things, what can happen. So basically, these approaches, as you know, many of these tumors, they don't stick to the sella. They go in front, behind, laterally, and in all sort of places. You must have seen so many scans by now. This is a place where I work. And these expanded endonasal approaches are basically used for not the normal tumor which is just in the sella. You don't need to do these approaches unnecessarily. You do them only when you find that certain areas would be difficult for you to approach, and then we have these classical extended approaches, which are 2 are in the midline and 1 is on the side. So these are the basic extended approaches: the transtuberculum, the transclival, and the transcavernous. So the common tumors which we see in this areas are the pituitaries, the craniopharyngiomas, which are also being operated now mostly transsphenoidally. And then we have the meningiomas. Meningiomas per se I have not done till now because I'm still wary. I have not yet. I prefer the small supraorbital route. the SOCA. And for chordomas and for rat cases also it can be used. And then we have the indications, and one should be very, very wary of these indications where you're going to do extended approach, because mind you, involves a lot of drilling, a lot of removal of normal things, so you have to be very, very wary about removing these structures. Then we have these classifications, and then our surgery has to be tailored based on these classifications which we study. All the three classifications, the vertical extent, the lateral extent, and the extent behind. So these gradings and classifications let us decide how to approach these tumors, and this is what the normal exposure would look on the left, and then the extended exposure would look on the right, where you have to go and drill more, remove more bone, either from top to down or from medial to lateral. So when you talk about the superior exposure, it is more going beyond into the plenum, or you can go up to the cribriform plate, and that is what you would see once you do that. And then when you're doing the exposure more anteriorly, it involves the frontal sinuses, it involves the ethmoid sinuses too. And when you're doing the transclival approach, you got to drill down. Mind you, that bone is much more thicker when you're drilling down, and you have to be careful of the lower cranial nerves also when you're drilling there. And then we have the transcavernous approaches, especially for tumors which are around the cavernous sinus. And these approaches, basically, you have to know the extent and also the instruments you're going to use for a certain approach. The 0 degrees is good for the sella, but the 30 degrees and 45 degrees are used for the approaches which are more anterior. So you have to know the angle which one has to work, and these are the angles which you can see with either 0, 30, and 45 degrees. Also important is the instruments. The normal instruments which are made for sella will not reach in these extended approaches. So I myself have made my own set with a longer length and also with angles like a 6 o'clock, a 3 o'clock, a 12 o'clock, and a 9 o'clock suction angle. So that helps you to reach in the crevices. So this is what we would be looking at, the lateral approaches. There are 5 zones, the zone 1, the zone 2, zone 3, zone 4, and zone 5. And depending upon where this tumor is, you would be planning your removal of bone, and you have to also know the surrounding structures which can come in the way when you are doing the drilling. So this is the angles what you would get for a superior approach where you can reach with these scopes. And I'll just show you now, this is a tumor which is fairly big, it is going straight up. So your plan has to be to expose more anteriorly. So here, if you see here, we are into the sphenoid sinus, we are drilling, and have adequate exposure so your instruments go inside. That is very, very important. So here we are using the bone CUSA also can be good to remove the bone, and we have opened the dura here, and still as you're removing the tumor, you might have to extend the removal of bone. So here we are going anteriorly, and then we are delivering the tumor gently. So the technique is, you can use blunt and sharp dissection, but it's a gradual delivering of the tumor. You can use the bipolar where required, and that's the normal pituitary behind, and that's a tumor in front. So the dissection is very, very important. It has to be a gradual pull, a gradual tuck, and a gentle handling of the perforators. So which is very, very important. So that's the third ventricle. And then we use hemopatch, which is artificial dura, as well as fat and fibrin glue. So this is the patient, that's the post-op. So this is another patient. This is also a similar tumor. So here the exposure has to be proper. You have to have a good nose before you reach to this area. But sometimes, if the nose is not prepared properly, you can get into problems. It frustrates you. And here you see, sometimes fogging is also a problem. So you got to keep on irrigating and then do the debulking in a particular fashion so that the tumor keeps coming down, the one which is going suprasellar. So here, once the tumor is removed, you can use a little bit of flow seal. And then the most important thing is doing an inlay and onlay repair of this skull base. So that's the patient, that's the post-op. So I'll show you, there are a lot of pituitaries. So this is the patient which one has to plan. Now if you see this, there's a tumor going up, there's a tumor going on the side into the lateral part. So here what we would plan is, we plan 2 sessions for this patient. We go straight forward first into the cella, remove as much as this tumor, doing the Haddad flap. Here you're going to require sometimes bilateral Haddad flaps because it's going to be a large defect. So the tumor is already in the nose, so it is good, but it sometimes can cause problems because you don't know where you are. So we are debulking. We use the navigation also here, and we are debulking in the center. So we got as much as tumor in the midline first. And then we waited, because this patient was a very frail patient. So we waited for some time till we went in transmaxillary and transpterygoid. So that was the second approach which we did. So this is the post-op scan of the first surgery. Then we went in. Before going in, we did an MRI. We found this residual tumor here. So we used the navigation. And then we went in lateral to the sphenoid sinus to excise this part of the tumor. So basically, you have to plan these surgeries. So you don't go chasing it in one go. So here we are removing as much as tumor which is going down into the temporal fossa also. So here you require a little bit of bipolar coagulation and flow seal, which helps you, and that's the post-op, and that's the patient. So craniopharyngioma, this is a recurrent craniopharyngioma where the patient was operated from top. He had a reservoir inside placed. So again, here you need an exposure which is more anterior, and you might have to take down even the middle turbinate because you need more anterior exposure here. So here if you see the anatomy is good here because you can identify everything, and then you can get into the sphenoid sinus and work more superiorly. So we are drilling, and that's the tumor you're seeing here in the cella, but we have to go more anterior. So we are drilling more of planum so that you can have more of tumor in your range. And then you can bring down the tumor gently. So basically I call it a pull and pray. You keep pulling gently and pray to yourself that nothing happens. So here there was a tumor which was slightly adherent to the hypothalamus. So that part we do not try to remove. So we can, that's the reservoir which is seen here in the third ventricle area where the tumor was. So it was coming in our way, so we had to cut it a bit and then remove this tumor as much as possible. So after that, you have to do a good repair. That's the third ventricle. And we are extending a little bit more to get some dura for leverage when you're putting the fascia lata. So you have to do that so that you can buttress the fascia lata. This is a little bit of Surgicel powder. And a good repair. These cases require very good repair We don't suture. Till now, we have not sutured the dura because in bigger tumors, the dura is very thin. So it becomes sometimes difficult to suture. That's the post-op. It's the patient. So he was in the ICU for some time. He had DI, but then he came out. This is another patient, similar, but for want of time, I will not show you this. So this is another patient we did the same way. Another craniopharyngioma, the same way. So this was a challenging case. Sometimes you can get into, this was a tumor going into the temporal lobe, more lateral. So this was a transpterygoid approach, which we did. And if you see here, we are going to the maxillary sinus, entering into the temporal fossa, and we remove this tumor transmaxillary transpterygoid. But you have to be careful. Sometimes you can get into trouble. So the internal maxillary artery is a problem here, but you can control that if it be, that's the IMA. So that's not much of a problem. But as we go towards the temporal fossa and we go medial, that is lateral to the sphenoid sinus. So here, this is the part we have removed from the temporal fossa, and if you see this bleeding is from the petrous apex ICA. So we tried flow seal. It did not work. So here we are using a clip. We took an aneurysm clip and we could clip the wall partially, the rent which was there in the ICA. So one has to be ready for any eventuality like this. When this happens, always keep a set of clips which can be used, and that's the post-op angio. Always take the patient directly for an angio. And that's the post-op scan, and that's the patient. So this is another patient, recurrent clival chordomas, where the patient was irradiated. So one has to be careful when planning again. So here also we did an extended approach. And sometimes irradiated lesions can cause problems. So I think my time is up. Is my time up? So here, little bit, as we were doing the debridement, using the debrider, so the tumor is sometimes difficult. We are trying to dissect this tumor because it is fibrosed, and post-radiation, it becomes, there's a blowout of the ICA. So here again, we can use the clip if it is a partial tear and control the vessel. So you have to have a clip with you. And these are some cases which you require proper planning when you're operating on these cases. So to conclude, extended approaches have to be planned properly. You have to be ready for complications which can occur. And the most important thing is a proper skull base repair. Thank you.
Thank you very much, Professor Vernon. Nice presentation.
Okay.
Okay, sir. Now I will call upon Yaramani, Dr. Yaramani. He will tell EEG transpterygoid approaches for extensive skull-based lesions.
First of all, thank you, Dr. Bansal, for a wonderful event and as well as for a great hospitality. So I'm going to talk about the transpterygoid approaches for various pathologies. Dr. Bansal requested me I should complete in 10 minutes because we are already running much beyond our time. So what are the transpterygoid approaches? While the transpterygoid approaches are the extensions in the lateral plane, and quite often, like a lot of these tumors that we are looking at, from pituitary adenomas to various pathologies like chordomas, they extend well lateral to the cavernous sinus down towards the clivus. So that's where and towards the infratemporal fossa. So that's where a lot of these approaches are very useful. And as we see it, when the tumors, if we see from the side, I mean, which the neurosurgeons are not so often used to, that's the maxillary sinus, and behind the maxillary sinus is the pterygopalatine fossa, and these are the medial and the lateral pterygoid plates. So this is the area, and lateral to that is the infratemporal fossa. So these are the areas where a kind of extending our approach further lateral by opening the maxillary antrum and getting towards the pterygoid plates and further lateral towards the infratemporal fossa is helpful. So it gives access to us to the lateral recess of sphenoid, in the sense, I mean, well away from the midline, but within the sphenoid, and as well the pterygopalatine fossa towards the petrous apex, Meckel's cave, cavernous sinus, and the infratemporal fossa, and the lateral part of nasopharynx. That's why a lot of these, if we look at the anatomy of how these things are, so the important thing that we need to look at is we look at the osteology of how these bones are aligned, and we drape that with the neurovascular structures. Then we'll get to know how the transpterygoid approaches helps. Traditionally, the cursor is here, yes. So traditionally we are here in the midline, going further lateral, and this is the Vidian canal. The palate bone has a vertical plate, and it divides into two. The one which is towards the sphenoid is the sphenoid process and the orbital process. And this is the pterygoid. The entire of this area is behind the mastoid. In fact, the vertical part of the palatine bone forms the medial border of the maxillary sinus. So we remove the vertical plate of, drill off these processes of the vertical part of the palatine bone and get to the Vidian canal. And from the Vidian canal further lateral, we get towards the foramen rotundum. And these are the pterygoid plates that we have. So the first part of it is removing the medial part of the maxillary antrostomy. The medial part of the maxillary wall is removed, like here. And then the posterior part of the maxillary wall as well is taken out. And from the midline, we start moving further laterally over to the pterygoid plates and identify the Vidian now. Then that gives us the access. So if we look at it, the orientation part of it, the maxillary sinus, almost the upper part, we orient ourselves to the choana, and the superior and the lateral border of the choana, that is almost at the upper end of at the level of the pterygoid plate. When we are seeing in a live patient, that's what gives us the orientation. So this orientation is important. And this superior and lateral part of the choana is almost at the foramen lacerum. So the foramen lacerum comes in the middle 1/3 of the clivus, and the rest of the thing is upper clivus and other things. So we remove the medial antrostomy and remove the posterior wall of the maxillary sinus, and trace this, keep drilling along the superior and superior-lateral border of the choana. That is the the pterygo-sphenoidal fissure that will take us towards the foramen lacerum. So this is one of the very important landmark when we are considering the transpterygoid approaches. So the superior and lateral border of the choana is the one which we need to remember rather than trying to just get into the complex anatomy. That orients us to everything. And from here, we look at it, this is the basic thing, this is the choana, the superior lateral border of the choana is the one which is foramen lacerum, and this is our traditional cella floor. The middle 1/3 of the clivus and the upper 1/3 of the clivus, which consists of the dorsum sella and the posterior clinoids. These are all the areas, and further lateral, the tumor extensions are what we are covering in this. And we should master reading the tumor extensions in the radiology, both in the CT and as well as the MRI, so that to decide of, we don't have to see everything in every tumor. We study the extensions of the tumors well and remove only as much as it is required for us. So the steps of the pterygoid approach are maxillary sinus antrostomy and sphenopalatine artery, which is getting there from the sphenopalatine foramen, that needs to be sacrificed, and removing the posterior wall of maxillary sinus, as I said. Vidian now comes lateral and inferior to the foramen lacerum. Traditionally, that's not a great landmark always. The greatest landmark is the superior lateral border of the choana, which is the fissure that is there, and we remove the pterygoid base. So what it offers to us? It offers us the petrous apex sits here, so the lesions of the petrous apex can be addressed. And for seeing the petrous apex better, we need to come from the lateral maxillary antrostomy. So these all get a little more invasive, like as Dr. Velo was mentioning, these things. So one-sided maxillary antrostomy is generally sufficient. until unless the lesion is located here, where you want to use the contralateral maxilla. And when we want to use both the maxillary antrostomies, that's where the things get nasty, because we are losing the pedicles of both the flaps here. So that's the thing, and we have the petrous apex is here, the sixth now climbs over it. So this is the basic anatomy that we need to learn, the orientation of the transpterygoid approaches. So coming to the cases, as I said, the first case that we did by this approach after we learned about the anatomy was a case where the tumor has extended towards the cavernous sinus. So in this case, we are only expecting it further. 60-year-old man, we thought it could be a kind of chordoma, and then see the midline is done. Initially, we did the cellular portion, then further we extended the approach further laterally. The cellular part was cleared. Then our team informed us that, okay, we are not able to still get the entire thing. So we extended the approach further. Then extended over to the cavernous sinus, and then further, this is the extension that we are doing, palatosphenoidal artery, which is in the palatovaginal canal, that's being done. And we removed part of the dorsum sella is broken, and in the center, then posterior clinoid is drilled in this, and the extension is further taken. So this typically required upper 1/3 of the clival work, and as well as the part of the lateral recess of the sphenoid, and as well as the cavernous sinus. So all these three areas are very well covered by going transpterygoid approach. So that's where we cleared up the entire tumor. So it came out to be metastasis, and he was found to have a primary in the lung. So he's well cured. So we reconstructed this well. Then, So another case of the pituitaries, like we have two pituitary cases that we operated. Both are prolactinomas. One is a 22-year-old lady who was operated elsewhere before, and she has come back to us. She was on cabergoline, but it was never controlled. So she has very extensive tumor. She has a tumor which has extended in all the compartments of the she has extended in all around the cavernous sinus, all the way up till the foramen lacerum. So the prolactinomas in the kids, typically, this is a recurrent case. There was a lot of messy anatomy, and we went in with the maxillary antrostomy as we plan it generally. Then opened up extended the cellular extensions are done onto the cavernous sinus. Then the foramen lacerum was found. From there, most of the tumor, which was suckable, was cleared off all around the tumor. So these are invasive prolactinomas. So the surgery of prolactinomas is quite contested by many, but now the prolactinomas are again coming back to surgery from medical management. So that's what. So now our endocrinologist, the moment it's not a microprolactinoma, she sends and says, operate the patient, because they are never going to be free of. So we cleared off most of the tumor. So the last I found out, we operated this patient almost around 3 to 4 months back. So now her prolactin has reached close to 20, and she's on cabergoline. She's very well relieved of the things, and it came positive for both plurihormonal ectotroph and gonadotroph adenoma. She's on medication for now. She's doing well. So the other prolactinoma is in a kid. 50% of the adenomas in the kids, they are prolactinomas, functional ones, and they are invasive. So this kid, we can keep arguing on this and keep treating it with the medication. It's never going to get settled. So this tumor has well into the cavernous sinus, and this guy doesn't have a good sphenoid sinus or anything formed well. So, So this took a bit of time because the anatomy was not typically the way that we expected it, but Yeah, we can see the clival carotid, the cella exposure, and the entire foramen lacerum was done. In this case, we didn't cut we mobilized the VDN nerve for the lateral. Then fortunately the tumor was all suckable. So we completely got the tumor out in the first go. The patient had biochemical remission on day 5. So the KD is kind of, it's 10. So he's kind of, so far, I mean, he's following up with this. So this is another young lady with extensive meningioma, which was cavernous sinus meningioma, operated 2 years back, went for radiation for the residual. Now she has grown back with after 2 years, I mean, she has come back with a huge tumor. And this one, we took it up. We obviously understood that this is tumor which cannot be done by one approach, so we planned both endoscopic from below and as well as transcranial. So this one, we took the contralateral approach too. And this is as well, we could only partially remove this tumor because all said and done, finally what determines how much extent of excision that we can do is the consistency of the tumor. So it was to an extent suckable, and we can see the carotid here and the VDN now. So we could only partially could get it. The rest we operated from above, and it turned out to be a grade 2 tumor post-radiation in 2 years. So this one we have sent to medical oncology because we were enough frustrated irradiating these grade 2 meningiomas which are regrowing. So we sent to medical oncology and said, okay, please treat with chemotherapy. And so that's, see, there are cardomas and other things. Okay, it's one of time, I already consumed 15 minutes. So the transpterygoid endonasal approaches, these are good for the lateral extensions, and these are, a lot of these tumors, we can offer a very good surgical kind of near total, gross total excisions to the optimal excisions for most of these tumors with a lot of lateral extensions and as well as extensions down. Thank you. And for 2027, NEUROENDCON is in Hyderabad. You're all invited. For anyone who wants to register, 7,000 rupees is the initial offer, only for as long as Dr. Bansal holds this conference on for 27. Thank you.
Thank you very much, Dr. Yeramani. It's a great paper, and you have opened a new, I think, new corridor for new approach. Good. And any question, any comment? Then, okay, we will complete this session and then we will hand over the mic to you.
Okay, thank you, sir.
Okay,
thank you so
very
much. Thank you. Now it's time to add some excitement. Welcome to the quiz session now. For the quiz session, I invite our quiz masters, Dr. Prakash Nair and Dr. Jatin Bajaj. I invite my quiz masters, Dr. Prakash Nair and Dr. Jatin Bajaj, and our moderators, Dr. Sumit Sinha and Dr. Vamsi Krishna.
आ गया क्या?
चल रहा है, वहाँ से स्विच करेंगे. रेडी है, रेडी है, रेडी है.
Hello.
Hello, hello. Hello. So I request all the participants for the quiz to please come on the stage. वो स्विच कर लेंगे सर. Hello. So I request the participants, Dr. Himanshu, Dr. Ankush, Dr. Sagar, Dr. Sumit, Dr. Kelvin, Dr. Shubham Gupta, Dr. Naveen, Dr. Shritij, Dr. Sai Harish, Dr. Mahesh Mahi, Dr. Prakash, and Dr. Manjunath. The participants has been announced. Please come on the stage, sir. So you can write
You can sit by the sequence in which you've been called.
remember. Himanshu and सबको बोल दिया. Dr. Himanshu, Dr. Ankush, Dr. Sagar. Okay, Dr. Himanshu Prasad, Dr. Ankush. We don't have Dr. Ankush. Dr. Sagar, Dr. Sumit, Dr. Kelvin, Dr. Shubham, Dr. Naveen, Dr. Shritij, Dr. Sai Harish, Dr. Mahesh, three teams.
कोई बात नहीं, जितनी जैसे है वैसे कर सकते हैं. तो क्या करें? ठीक. बाकी लेकिन सेकंड थर्ड तो हाँ सेकंड फर्स्ट 2 राउंड में 3-3 करो. Okay, so welcome to everyone for this grand quiz finale. So the participants who are here with us have come through a very rigorous screening process. We had 2 rounds of quiz conducted on August 15, 2025 and January 26, 2026. This was an online selection process and all of them had applied and were the top 5 contestants in each of the quiz. So congratulations to all of you and thank you for joining us here in Jaipur. So there is an opportunity to win this grand finale. And for the audience who are present here, you also have an option to get some small prizes for questions that are passed on. But I'm sure they'll not let you answer any question. So any question that they're not able to answer might be passed on to you. But I don't think you might be able to allow them to answer even one question. So I'll just start with the simple rules. So we have 4 rounds. Round 1 and round 2 are rounds where you will be asked questions and you have to answer. If the first team does not answer the question will be passed on to the second team. And a team that answers will get 10 points. There is no negative marking in round 1 and in round 2. Round 3 and round 4 are buzzer rounds. So the team that hits the buzzer will have to answer the question. Now, a correct answer will get you 10 marks and a wrong answer will have a penalty of -5. So, these are very simple rules. And with this, we'll start. So, if you have any questions, you can ask me. Otherwise, we'll go on to the first round. Any questions? So, pencil and paper is not needed. The only instrument that you need is already there between both your ears. So, the first round, which is a round of quick singles. So, we had anticipated that we'll have 5 teams, but we have 3 teams, so we'll ask 1 question each for you. So, the first question is,
so after I finish the all the options, you will be given 10 seconds to answer. If you do not answer in the 10 seconds, then it will be transferred to the next team. So the question 1 is, the nasal cycle is a technique of systematically irrigating the saddonasal cavity. Option B, alternating partial congestion and decongestion of the nasal cavities. C, sequence of surgery in FES. Or D, a form of breathing exercise. Team A.
Option B, alternating partial congestion and decongestion of nasal cavities.
Okay. So you are correct. The next question is to the team B. So X-linked hydrocephalus occurs due to mutation of A, LCAM gene, B, SNAP gene, C, retinoblastoma gene, and D, GNAS gene.
This is, option A, LCAM gene.
So pass on to third team. Okay. So his answer is correct. So plus 10 to A team, plus 10 to B team. Scorer. Question 3. This cell shows a dense ring-like accumulation of cytokeratin intermediate filaments around the nucleus, appearing glassy or hyaline on staining. This change is a response to high levels of cortisol. Option A, Crooks cell tumor, B, ETA&TR, C, Ewing sarcoma, or D, Rosenthal fibers. So, answer correct, plus 10. So
we'll move on to the second round. And this is again a round of spotters. So the first question is to team A. You have a MRI scan that is given in front of you. You have to identify the condition shown in the scan. Is it a case of an optic pathway glioma? Is it a Dandy-Walker malformation? Is it aqueductal stenosis? Or is it scaphocephaly? You have 10 seconds to answer this. You have another 5 seconds for
Aqueductal stenosis.
Very good. So this is a case of an aqueductal stenosis. You can see the block at the level of the aqueduct with a normal fourth ventricle here. So the question goes on to team B. You have a coronal section of a CT scan with an arrow pointing to a certain foramen. Identify the foramen marked by the arrow. Is it foramen spinosum? Is it foramen ovale? Is it foramen rotundum, or is it the Vidian canal? You have 10 seconds to answer this question.
C, foramen rotundum.
Very good. So the answer is C, foramen rotundum. So the other foramen that you can see here is the Vidian foramen, Vidian canal that is located inferiorly. So the third question is to team C. You have to identify this pattern of nematization. Is it a cellar nematization? Is it pre-cellar nematization? Is it conchal nematization, or is it clival nematization? The CT shows a pattern of nematization. You have to identify the pattern of nematization. Is it cellar? Is it pre?
C, conchal.
Yeah, so that's the wrong answer. The question passes on to team A. So you have
Pre-cellar.
Yes, very good. So the conchal nematization is the pattern where there is a thick layer of bone, at least 2 millimeters thick, between the anterior part of the sella and the sphenoid. So this takes us to the next round, which is the super over round.
can you tell the scores? Thank you.
So now it's the buzzer round. All correct answers are plus 10, but negative mark minus 5. But there's a buzzer round now, so it's open for anybody. And if you don't answer, it doesn't get passed, it goes to the audience.
So I'll begin. Identify the structure marked by the yellow arrow. A, PCA, SCA, oculomotor. Yes. Okay, good. So plus 10 to team C. Next question. The instrument shown is most commonly used for coagulating epidural veins.
B, grasping and removing herniated disc bladder.
Nice, very nice. So plus 10 to C, team C. Next question. The triangular safe working zone between the exiting. Yeah.
B, Cameron's triangle.
Okay. So that's also right, Cameron's triangle. So I'll continue. Chalne do. Okay. Visualization of freely pulsating transversing.
Adequate neural decompression.
Speak loudly.
Adequate neural decompression. C.
Okay. Nice. So again plus 10 to team C. Come on, buck up other teams. The instrument shown is commonly used during percutaneous endoscopic lumbar discectomy, PELD. What is its primary function? Irrigation of epidural space, dilation of paraspinal muscles, creating a protected working corridor for endoscopic instruments, or removing disc fragments. Five seconds more. Okay, passing on to the audience, you will get a big chocolate. Yes. See, nice. Please come here. So next question. So creating a protected working corridor for endoscopic instruments. So look closely the video.
Now we are going to show you videos, and you have to see the video and then press the buzzer for the question. Okay.
Okay. So this was the video. What is the structure used for reconstruction? It's a buzzer round. Yes.
Pericranial graft.
What is the structure used for reconstruction? Yeah. Be specific.
Temporalis fascia plus pericranial graft.
Yes. Temporoparietal fascia. Next, the blood supply of this structure is team C.
Superficial temporal artery.
Yes, correct. So again, 2 plus 10 to the team C. Okay. So look for this video. Identify the anatomy. Answer, please.
The foramen of Monroe. That.
Identify the anatomical location, including side. 5 seconds more.
Left side. Left side.
Identify the anatomical location.
Sorry.
Identify the anatomical location.
This is the left side of lateral ventricle.
Okay, correct. So plus 10. What is the relationship between the choroid plexus and the thalamostriate vein in the left lateral ventricle? Team B.
Thalamostriate veins is on the left side in the left lateral ventricle.
Okay. So it's option A or B?
It's B in the left side.
Okay. So plus 10. Now next video. Identify. 5 seconds more. Team A, team A. 5 seconds more. 2 seconds more. -5, please. Next.
That is a tuber cinereum site for ET.
So what,
Floor of-
identify
floor
the
of third
anatomical
ventricle.
location.
Floor of third ventricle.
Yes, yes, correct. So plus 10 to team B, minus 5 to team A. The green arrow is showing?
Infundibular recess.
Yes, correct. Plus 10 to team B. Question 19. Identify the structure marked. Yes.
That is LOCR.
Yes, correct. Plus 10 to team B. The intracanaliculaar segment of the optic nerve. Yes, team C, what? Time over. Yes. Team B?
Medial OCR. No, sorry.
Wrong. Again, minus 5 to both the teams. Yes, yes. So we can pass it on. Please.
So the true optic canal corresponds to the lateral optical trabeculum. So we are at the last question of this round.
So this is an important video. Please see. This is one of the earliest video of what?
Minimally invasive discectomy. Tubular discectomy.
Wrong. Minus 5. So passing it on to the audience. Videos are one time only. No, not stereotaxy.
So we'll move on to the next question and then we'll give you the answer.
Which surgeon is credited with the first endoscopic endonasal approach?
Gerard Guillaume.
Yes, correct.
This is a video of Gerard Guillaume using the endoscope in 1960.
Yes, sir. I'm sorry. हाँ वो आगे ही बढ़ता जा रहा है.
Gerard Guillaume was a pioneer of microscopic surgery, but he also was using very poor resolution endoscopes for doing the pituitary procedures in 1960s. And this is one of the videos that is available in the archives of the hospital that he used to work in. So it's a historical this.
So after the quiz, the GBM is in the Tiger Trail ground floor. Immediately after the quiz.
So we are moving on to the last round of this quiz. This is the buzzer round, and there will be no questions passed to anybody. You have to answer within 10 seconds or we'll move on to the next question. The answers for all the questions will be given at the end of the round. Yeah, buzzer will have negative marks. So the rapid fire round, the first question, Ashutosh, can you tell us the score? So it's a close neck and neck race between team B and team C. Come on, team A. So first question. All the following arise from the cavernous ICA except?
The inferior hypophyseal.
Wrong. The tolvaptan acts on? Very good. The middle turbinate is the part of? The ethmoid bone, the sphenoid bone?
Ethmoid bone.
Very good. Correct answer. The persistent trigeminal artery connects the cavernous to the basilar, the communicating ischiae to the basilar. Very good. So this is one of the fetal circulations where the cavernous ICA is connected to the basilar artery. The BRAF B600E mutation is seen in team B. You have to answer now. Fast.
Papillary craniopharyngioma.
Very good. Papillary craniopharyngioma. The Woodruff plexus is located in?
Posterior end of the inferior.
Very good. Posterior end of inferior turbinate. The vascularity of the superior lateral anterior pedicle flap is derived from the sphenopalatine artery, the anterior ethmoidal artery, the descending palatine artery, or the posterior nasal artery. The vascularity of the superior lateral anterior pedicle flap. It's called the slab flap. So we'll skip. What is the mucosal valve at the lower end of the nasolacrimal duct called?
Hasner's valve. C. Hasner's valve.
Very good. The brachyury is used to identify.
Chordoma.
Very good. And the last question. Continuous irrigation during endoscopic spine surgery is used for?
B. Maintain a clear visual field and wash away debris.
Excellent. So this is the end of the quiz. I'll just go through the answers once more. So the superior hypophyseal artery arises after the ICA passes out of the cavernous sinus. All the others are branches of the ICA in the cavernous sinus. Tolvaptan acts on V2 receptors. The middle turbinate is a part of the ethmoid bone. The inferior turbinate is a separate and solitary bone. The persistent trigeminal artery connects the cavernous ICA to the basilar artery. The BRAF V600E mutation is seen in papillary craniopharyngiomas. The BRAF mutation is also seen in optic pathway gliomas, but it's a gain of function mutation. The Woodruff plexus is located in the posterior part of the inferior turbinate. It's a venous plexus, not the arterial plexus. The Kieselbach's plexus is an arterial plexus. The vascularity of the superior lateral anterior pedicle flap is from the anterior ethmoidal artery, comes from the roof of the nasal cavity. The mucosal valve, as he told us, is called the Hasner's valve. All the others are names that I have created. Brachyury is used to identify chordomas, and continuous irrigation is used to maintain a clear field. It increases the epidural pressure to control bleeding, not decreases. So with this, Ashutosh, can you tell us who the winners are?
So thank you very much. We have come to the most awaited results section. So the third is Team A, who has got 40 marks. Second is Team B, 80 marks, and the winner is Team C with 115 marks. Please stand. So, valedictory function, yes.
Thank you everybody for joining us.
Thank you so much, guys. Thank you so much, the participants. Thank you so much, sir. So now there are two important announcements. First is the GBM meeting. That is in the Tiger Trial Hall, ground floor. And the second thing is the prize distribution of award paper, quiz, and e-poster will be during the inauguration after GBM meeting over here only. The inauguration will be in Crystal Hall only. Okay. Thank you so much. You can proceed to the Tiger Trial Hall. Okay, so the participants for the quiz, you have to wait for 5 minutes over here. Okay, only the participants. No, you can leave, sir.
I warmly welcome all of you to the inauguration of NEUROENDCON 2026. We are delighted that in its 12th edition, some of the most skilled and renowned neurosurgeons from across the country and around the world have joined us. On this special occasion, I would like to invite
Dr. P. Sharan Chandra, President of NESI.
Dr. Subhash Raju, Vice President, NESI. Dr. Subodh Raju, Vice President, NESI.
Dr. Sumit Sinha, Secretary of NESI.
Dr. K.K. Bansal, Treasurer and Organizing Chairman.
Dr. Samar Albeba, President Election, IFNE.
And President-elect IFNE. Professor Joachim Ortel, Secretary of IFNE. And I'll announce his name, Mr. Balwinder Sangwalia, who is not present yet. He is on the way, so he'll join later. May I request all the dignitaries for the ceremonial lighting of the lamp? सरस्वती वंदना बजा दीजिएगा. समर अलबाबा.
सर, आपने ये लिखा.
Thank you so much. May I request you all to take your seats, please? And now may I invite Dr. K.K. Bansal to deliver the inaugural and welcome address. Dr. K.K. Bansal.
respected people sitting on the dais, dignitaries, and the president of NESI, Professor P. Sharachandra, esteemed members of the Neuroendoscopic Society of India, distinguished international and national faculty, dear colleagues and cherished friends. Good evening and a warm welcome to NEUROENDCON 2026 here in Jaipur. In times such as these, when parts of the world are still witnessing conflict and uncertainty, your presence here carries a meaning far beyond academic participation. It's a powerful affirmation that science transcends borders, that knowledge refuses to be silenced by discord, and that friendship among professionals can prevail over division. Despite the turbulence in some corners of the globe, you have traveled across the continents, from Canada to Japan, from Italy to the United States, from Brazil to India, and beyond that, together under one roof with a shared purpose to advance the science and art of the neuroendoscopy and ultimately to serve our patients better. The spirit of unity is true strength of our fraternity. NEUROENDCON 2026 is not merely a conference, it's a confluence of experience and innovation. We had cadaveric workshop, instructional courses, video sessions, debates, and vibrant academic exchange. In these days, 2 days, we shall dissect not only anatomy, but also ideas, not only techniques, but also perspectives. We will challenge conventions, refine our skills, and inspire the next generation of our neurosurgeons. Jaipur, the Pink City, stands today not only as a symbol of heritage and hospitality, but as a meeting ground of global minds committed to minimally invasive endoscopic neurosurgery. May the warmth of Rajasthan and Jaipur mirror the warmth of our professional camaraderie. On behalf of the organizing committee, I extend my heartfelt gratitude to every faculty member, delegate, industry partner, and volunteer who has contributed to making this gathering possible. Your trust and participation honor us deeply. Let this conference be a reminder that while the world may at times be divided by politics and war, it can always be united by knowledge, compassion, and shared purpose. Welcome to NEUROENDCON 26. Welcome to Jaipur. Welcome, dear friends. Thank you very much.
Thank you so much, Dr. Bansal, for your inaugural and welcome address. Now, I would like to humbly request President of NESI, Professor Dr. P. Sarath-Chandra, to please come forward and share his thoughts about this conference.
Honorable dignitaries on the dais, Secretary of the Society, Professor Sumit Sinha, the Vice President, Professor Subodh Raju, and of course, our dear friends from IFNE, Professor Samir Albaba and Professor Orchid. Welcome to all of you. So, it's truly an honor and privilege to stand before you and before such accomplished gathering of neurosurgeons, innovators, and thought leaders who continue to push boundaries of minimally invasive neurosurgery. Neuroendoscopy today represents not just a technique, but a philosophy, and it's a growing philosophy, as was seen in the conference here. One that emphasizes precision, safety, and better outcomes. It's even more relevant, particularly to have this meeting where we have friends coming from all over the world as well as from our own country, because our world today is characterized by rapid changes, professional pressures, and a lot of strife and war which is going on in some parts of the world, and meetings like this hold even greater significance. They're not just academic platforms, but spaces for reflection, collaboration, and collaborative growth. They allow us to step back from routine practice, exchange ideas, question our assumptions, and move towards renewed clarity and purpose. I would especially like to extend a heartfelt welcome to our distinguished international and national faculty and the delegates. Your presence here enriches this meeting immensely, and your experience and insights will undoubtedly inspire all of us. I also take this opportunity to express my sincere gratitude to Dr. Bansal and his entire team for their exceptional efforts in organizing this conference. The meticulous planning and dedication behind this event are clearly evident, and we are all beneficiaries of their hard work. As we have begun the meeting, I'm confident that the coming sessions tomorrow discussions will continue to enhance our knowledge, skills, and continue to strengthen our friendship bonds between all of us within this specialized neurosurgical community. So wishing all of you a very productive, engaging, and a memorable conference. And of course, enjoy the rest of the evening. We really look forward for the inaugural ceremony and the lavish dinner that Dr. Bansal is going to arrange today. Thank you.
Thank you so much, sir, for your inspiring words. Next, I would like to invite Dr. Subodh Raju, Vice President of NESI.
Respected Dr. Sharat Chandra, my teacher, Dr. Sumit, Dr. Bansal, Dr. Samir, Dr. Ottel on the dais, and senior people down below, friends, delegates, youngsters, and not so old people like me. It was the 12th annual meeting of Neuroendoscopy Society, still a young society, but the way it has grown over years. And some of us have been there since the inception of the society. And this society has its own teething problem and these things, but it is becoming the fastest growing and the most popular society actually. The only thing is more and more people adopting to minimal access surgeries, minimally invasive surgeries for the brain and spine. And for all the youngsters and these things, I always tell that the amount of workshops and on endoscopy being held in India, you don't have to go outside anywhere to learn anything. It is sufficient and robust enough. The faculties which we have in India are robust enough to take care of all these things. So encourage more and more people to come and join this and attend these meetings, attend the workshops, connect with peers so that you have talks and what your difficulties are, what are the challenges you face, especially people who are settling, young neurosurgeons settling down into individual practice. They are always worried that can I do this case, can I do that case in the private practice? There is no easy way to do that. And in life, everyone now talks of work-life balance. So for the youngsters, before looking at work-life balance, I always tell that first start working. Then you can look forward to work-life balance. Because the initial effort and the strength and the effort and your dedication, what you put in, then the work-life balance automatically sets in, actually. When you grow in stature and these things. And in a medical profession, who thinks of settling earlier? We are still not settled, so why should everyone be settled and these things? So in our profession, neurosurgery and endoscopic surgery, there is nothing called as settling, because today you become confident about a technique. There is a better technique which is coming down the way. So you have to be prepared with that. If you are not prepared to that, you will be left out. So keeping abreast in all these things, meetings, connecting with people, we have fantastic international faculty coming in who share their knowledges, and especially all the faculties who are coming are very friendly also. We should not forget that. We can connect to them anytime and they are always ready to help us. When we were discussing about skull-based surgeries, big osteotomies, craniotomies to remove tumors, now we have endoscopic petroclival. Sumit presented on keyhole petroclival meningiomas. Then the whole new thing of transorbital surgery came in. I mean, transorbital surgery we used to know, but that coming in a major way is a upcoming thing, and please look forward to it. Never leave thinking about innovating small things in life which will take that one step. It may be a millimeter, but that's what new you will be do every day and day in and day out. I once again congratulate Bansal. One important thing is that in such a short time, I mean, actually, frankly speaking, we have been connecting. In a short time, what Bansal could gather this meeting and organize it and do it in a great way, it is really commendable. And I think a big round of applause to him. With these words, hope you enjoy the rest of the conference and connect more. Thank you very much.
Grateful for your valuable words, sir. Moving ahead, I invite Dr. Sumit Sinha, Secretary of NESI, to address the audience. Thanks.